monitor for the complications like ROP and the hearing assessment in the follow-up of the newborn. Then we are also working on the revision of the home-based newborn care model, which talks about the special follow-up our at-risk babies, the low birth weight, which are discharged from the hospital. And so we are working how to strengthen the surveillance system of the stillbirth, and very soon we will be having the packages on the same. So thank you very much for having me here, and I am sure that actually working together we can ensure that every child survives and thrives well in our country. Thank you so much.
Thank you so much, ma'am. Thank you for taking us through the different components of INAP and also to guide us on how or what we can do to improve the coverage of different INAP indicators. So we all understand that these cannot work in isolation, and for everything health system is at the core. So the Indian government, through a series of health system reforms, has worked to strengthen the newborn healthcare infrastructure, to improve utilization of services, improve quality, and so on. And these reforms have focused on improving, besides healthcare delivery, the social determinants of health as well. So that is why we go on to the next session, which is on the India's health system, a game changer for newborn healthcare and survival, that would be delivered by Major General Professor Atul Kotwal. Sir, please. Dr. Kotwal is the Executive Director of the National Health Systems Resource Center, NHSRC, Ministry of Health and Family Welfare. With 40 plus years of experience in public health, epidemiology, and health system strengthening, he has been central to major health reforms. A decorated officer, he received the Sena Medal for Gallantry, the Vishisht Seva Medal, and multiple research orations. He has authored over 175 publications and contributed to key national initiatives including Ayushman Bharat, PM Abhim, IPHS 2022, and Telemanas. Dr. Kotwal's leadership in advancing comprehensive primary health care through health and wellness centers reflects his commitment to decentralization, innovation, and community engagement. Over to you, sir.
Thank you, Dr. Sudhapa, for that introduction and also for the invitation here. Really grateful to IHMR for this opportunity. Good morning to everyone. So my task is made quite easy by the previous two speakers. Dr. Mateen talked about, that what are the rates and all, and he already showed all the stats, so I won't repeat any of those. And Dr. Shobna Gupta very eloquently told us about all the initiatives being taken and also the way forward as such in a new kind of approach which is being taken by the Government of India. I would just like to cover on the health systems approach which we now need to take. As the sum of the smaller parts is bigger than the whole, that's what the health systems approach is. And if you see the NHSRC, which I lead since last 4 years plus now, looks at the entire health system. If you see all the divisions which are there, the entire health system is covered, and that's why we are part of the Government of India. But we at NHSRC have got that kind of leverage. We are like an arm of the ministry, but we may keep our arm in the pocket of ministry, or we may keep it away from the body also, abduct also away from the body also. So that kind of flexibility is there, and that's why we are able to provide our technical inputs in a very frank and forthright manner in every forum within the ministry and even outside. This is the building blocks of health system, which we want to now ensure that they get strengthened. If you see the seventh one, which one added, the sixth, you're all familiar with WHO's building blocks. Community processes. They were earlier just mentioned, as we call it in French, en passant, in some of the building blocks. But to give it separate as such, because without community participation, as Dr. Shobna Gupta also mentioned, without community participation, we cannot now further decrease the gains which we have achieved, significant gains which we have achieved. And that's why Dr. Mateen's statement that the SDG era, the reduction is not at that steep. I think after a particular level, further gains take a longer time, take more commitment, and the entire whole of systems approach is there. And that's why I think thanks IHMR for calling me here to look at the health systems approach as such. So this I am not focusing here, but look at this, that the interstate and intrastate variations which we have. Dr. Mateen's last this thing slide also showed, but few of the states have already achieved the SDG targets, And this, I think, has already been covered by Dr. Shobna Gupta. The main initiatives now beyond NHM is the Ayushman Bharat, these 4 main pillars which are there. Plus, we also have the, under Finance Commission grants, and that's where involvement of ULB and PRI is also there, plus additional funds for infrastructure and diagnostics, and a lot of other schemes also centrally sponsored, and also central sector. This is the reform under Ayushman Bharat which has taken place. 9 major this thing, but now you add IPHS and quality also. The 9th one is the adequate financing, which has been ensured. And because as public health specialist, I did my MD in 89 to 91, we always bemoaned the fact that the financing is poor for the public health sector. Not anymore now. It's the utilization, effective and efficient utilization, where we to work more, and the uptake by the states as such, and utilize that money in proper manner. So if you see the changes which are there, I'm not going to read as such. I think you all of you present here know about this. But see, it's a different total paradigm shift from what was the earlier sub-center health with only one A&M led, open only for 2 to 3 hours, twice or thrice a week, and that too, people thought that probably some outsider has come here. Similar for PHCs, the kind of facilities which were there, the drugs and diagnostics were not available with high out-of-pocket expenditure. So these things are there, and it has made a change. Definitely, it has made a change. So this is, the life cycle approach which we keep talking about. We keep saying that, earlier we focused on only RMN, CHAN, and now we've added the newer packages. But even in that, the life cycle approach which was there is still existing. And that is the approach which we need to focus on if we want to talk about NMR or even any other mortality as such, whether related to mother or child. Because if you don't take a life cycle approach and focus only on ANC and postpartum and intrapartum, then we are, I think, missing a lot in the entire spectrum of the reasons for the morbidity and mortality. Look at the number of drugs and diagnostics. Yes, all centers all over the country do not have these right now, but it's a work in progress. We as per the last year's survey in 18 states, which we did from NHSRC and Ministry of Health, almost more than 60% have got more than 80% of these drugs and diagnostics at the sub-center and PHC level, which have been converted to Ayushman Arogya Mandir, which is a major success. Within 4 to 5 years, we've been able to achieve this. Community platforms, how we can leverage. Ashas, we all know. And there, how they mobilize, and HRP tracking, because now as per the newer thought process, more and more deliveries should take place at higher levels as such, even though there are facilities at the sub-central arm also where deliveries are taking place. But high-risk pregnancy in this thing is very, very important to track. And outreach services, and also HBNC, which Dr. Shobna Gupta also mentioned. Village Health Sanitation Nutrition Committee, and also the VHSND which we are doing. So that how to make it more effective. We recently had a meeting with additional secretaries from 4 ministries, and where we have now discussed that how to strengthen that VHSND further, including the changing the composition of VHSNC, have only one committee at that level, include all social determinants of health as part of those meetings, as much in terms of the Pani Samiti being separate and Sanitation Committee being separate. Look at all those, and in the WCD, get them all together, make AAA more effective, the ANM, ASHA and Anganwadi worker, get CHO also involved, and get Jan Arogya Samitis, which is the facility based, which is a new, we had RKS earlier at these levels, now Jan Arogya Samitis at Ayushman Arogya Mandir sub-center and PHC level. How to leverage them? We have formed these at more than 80% of the Ayushman Arogya Mandir. They are having more than 10 meetings in a year at that level. Untied funds are being given and they are spending. But now in second phase, now from this year, we need to look at how effective are the conversations, how effective the interconnectedness between the health services, health workers and the community, how they understand the community's needs and how they interact with the community and provide services in outreach as well as there, including grievance redressal and social accountability. I have deliberately used accountability, not audit. I am somehow, I'm not very comfortable with the word audit. Audit is for something which you can measure, like building a wall under Manrega and all, or digging a pond. Health, there are a lot of intangibles. So the social accountability word which is there, and that's why the NHSRC and the government of India also started using this instead of audit, which was being used earlier. Capacity of HRH, Dr. Shobna Gupta has already focused on. I'll just cover one important rural-urban divide, the systemic factors which need to be looked at. how to make these lucrative for people to go. We generally say that HR don't want to go to rural areas. No, it's not that. It's more, much more than that. So the governance, the administration, and also the other factors of comfort and also quarters and all. That's why under PM ABEAM and Finance Commission grants, the new facilities that are coming up, we are making sure that the staff quarters are part of all the new buildings, new construction, so that people have adequate, and internet and all are generally available over there. Even recruitment delays and all, we are working with states to create their own recruitment board instead of using the routine channels as such. LSAS and CEMOC, that's a task shifting approach which is there. And this has really shown tremendous contribution, especially in the northern part of India where these are more. 8 minutes over? Okay, I'll just finish in 2 minutes. Okay. No, I only told him to let me know at 8 minutes. That's it. So, no, not his fault. I requested him. He was telling me 10, 12, 13. I said, no, 10 minutes is the total time. Let me know at 8 minutes. Okay. So, other is skill labs and dakshata and all. But here again, we need to know, and that's where the development partners also should come in focus here. That how to make sure that the skill conversion takes place. We keep on doing a lot of courses on capacity building. But how much is the skill change which is there? And also utilize the AR, VR technologies also now, which are there, how to utilize those. Instead of making the normal videos which are there, why not augmented reality videos, interactive videos and all, and also followed by some kind of assessment, and OSCE based or this thing assessment, and competency based curriculums which we are now trying to make for all the HR. Earlier we trained them in package wise. Now we are going to make comprehensive packages towards the end of the year. By the second or third quarter, we will go for a pilot. Currently, they are being drafted, and hopefully by the end of the year, we should be able to launch those. Leveraging IT, I think you all know, but UWIN is another, I think, and that's where in UWIN, another thing is which has been being added is the test, track and treat for anemia, which is very, very important for all the outcomes of pregnancy-related outcomes as such. Continuum of care and quality of care has already been mentioned, Lakshan, Muskan, and also all these 8 areas of concern. This is what I wanted to highlight, which we look under NQAS, and they're all part of Lakshya or Muskan is part of NQAS only. And huge number of transport. Yes, transport I must mention, and for the tribal areas under PM Janman, there's MMUs also, which can transport ladies also, and IPHS, so for the standards which have recently been revised, and there's an ODK toolkit. 97% of the facilities have already self-assessed. Efforts are now going. Yesterday also, last 2 days, we were with 17 states, MD, NHMs and principal secretaries for the 2-day orientation into NHM. And this was being discussed that how it's a governance tool available to them to look at various gaps and take specific actions to fill up those gaps. Exemplars was mentioned by Dr. Mateen. So I must share in 2 slides that, NSRC in collaboration with the University of Manitoba and I had looked at what has worked, and this is very heartening to see that what were the reasons. There are 3 states, Rajasthan, Odisha, 4 states, Odisha, MP and UP with high initial mortality, and Maharashtra, Tamil Nadu with lower initial mortality of neonatal. So this is what, Maharashtra utilized flexible NHM resources, the facility which was given on the original implementation framework of NRHM, which is continuing till now. Tamil Nadu leveraged BPP, Rajasthan strong ASHA workforce, timely payments, Odisha HBNC training Ayush doctors as SBAs, and MP district level referral transport system. And of course this, as Dr. Shobna shared, with robust national policies and guidelines and skill-based and capacity building was there. Few important other learnings from exemplar is lower mortality states like Maharashtra, Tamil Nadu to begin with as such. They improved intrapartum care and immediate newborn support, which reduced it further and reduced prematurity. Higher mortality states to begin with, like Rajasthan and UP, greatest declines according to the late neonatal period. So that means they need to work more on intrapartum care as such, the facility-based care. So to the late stage and impact of better postnatal care infection management, urban, rural, of course, and asphyxia and infection-related deaths reduced there. So they need to work more towards the other factors. So it's both, they need to learn from each other. That's what the exemplar study that way has shown us. Urban, rural and wealth quintile gap also reduced, but of course they still persist. Institutional deliveries, again, key role played by them. Continuum of care, entire all stages, again played a key role. So going forward, we need to continue investing in high quality and safe comprehensive emergency obstetric care, particularly in underserved areas. Strong public sector focus on these services and equity. So lesson for all is that political will which is there, that's why the NHM is showing as such. Community engagement, flexible financing and localized strategies as per requirement. We also have implementation system strengthening platform of NHSRC where we collaborate. IHMR Delhi is one of our collaborators. We done 2 rounds of study. In second round, they have done 2 studies with us. But this is was other unique done by us only. To Kilkari project, how to improve it. And based on this, the entire project was revised and strengthened. Even Mobile Academy also. We have not only formed this IRHSS, we have formed this and share with all the states for replication and upscaling of these practices. Like for Telangana, I'm just sharing 2 states for paucity of time. Telangana looked at capacity building and training of staff nurses and doctors, online education section, and this was before these online and all became popular. Emergency management and also KMC, leveraging ECRP funds which were given. Many of the states did that. Some states did very well, like Telangana, and strengthened in-house management. See the referral rate reduction from 5.7 in July to 1% by 2025. That's a tremendous success as such. Meghalaya, local leadership building, regular review, and also they have their own app initially before other systems and portals came up into being. The way forward, I think a lot of it has already been covered, but I'll just focus on one is that if you see the last governance reforms, public health management cadre, that's the way for future. We have, the contractual under NHM and all, but the way forward to have public health cadre, look at Tamil Nadu. We keep on giving example of that. Why? Because since last 100 years plus they have public health cadre. Public health cadre, health management cadre, specialist cadre, teaching cadre, and 5th one, nursing cadre. Odisha has already made so that from ANMs and CHOs also have something to look forward to subsequently. And that's why you'll be able to attract and retain quality HR into the public health system instead of only the contractual work which is there right now. People join at one place and for lifelong they are supposed to work there only. So this is the kind of thing which we are working with states now. A lot of states, Bihar has already, by the way, Bihar is the front runner in this. They have already notified public health management cadre. It has financial implication also. But to begin with, we are asking states to have a financially neutral proposal so that fit available HR into various cadres as such, with some kind of assured progression, even if not a position, assured career progression as such with financial outlay also subsequently and later on, as and when the state also realizes. And that way, state will also increase their spending on health to 8%, which was part of the national health policy also as such. So I think rest all I'm not covering here. But NQAS last point is that, once a facility is certified, sustenance is more important. And that's where collaborations and all, we in fact work with a lot of partners and both government as well development as well as non-government. So to work that how the sustenance of quality takes place continues in all the public health facilities. So I'll stop here. Thank you very much for patient listening.
Thank you so much, sir. I think, it's very heartening to see the different health system reforms that have been made in the country. And I agree that 10 minutes is too short a time to discuss about everything, but we are very confident that everything will get fed into the State of India's Newborn Report 2025. So we are now going to the next session, which is on research. Research is, as we all understand, is a cornerstone to generating knowledge for evidence-based practice. ICMR is playing a pivotal role in advancing the research agenda of the country, aligning itself to the national priorities. So over to you, Dr. Sanghamitra. She'll be taking us through the session which is on advancing newborn health in India, the transformative power of research. Dr. Sanghamitra is the Additional Director General at the Indian Council of Medical Research, New Delhi, where she leads the intramural research and supports national health policies aligned with Viksit Bharat 2047. Formerly the Director of ICMR RMRC Bhubaneswar, she is an internationally recognized public health expert with over 400 peer-reviewed publications, an H-index of 47, and inclusion in Stanford's list of top 2% most cited scientists. A fellow of NMS, FRS, PH UK, and UICC, she has received prestigious awards including the President's Appreciation Award, IMA, the Chief Minister's Award for Excellence in Healthcare Services, and the Times Power Woman Award. Over to you, Dr. Sanghamitra.
once again a very good morning and very heartening to see a full house. When we entered with both me and Sutapa and Professor Kotwal and as well as Sovana ma'am, we were wondering whether we will be the audience and we will be the speakers. So thanks to all of you for making our day bright and full of sunshine and full of happiness, because nothing could be more traumatic for a speaker to see that they are only listening to themselves. So thank you once again. Already, and thanks especially to Dr. Sutapa for making me a part of this brilliant and esteemed panel, because I think I'm the only one who is not an expert on newborn health or child health. My job throughout, because though I used to be a clinician, I never claimed that I am a clinician now, because I left medical practice quite a long back. And since I think last 2 decades, my work has been primarily around doing research and contributing to how best all the services or all the programs or all the policy towards improving health can be kind of optimized or improved or shaped. And already Sobna ma'am and Professor Kotwal have very inspiringly, as well as both the global Dr. Jia has also kind of given a very inspiring scene for all of us that we are progressing ahead, we are progressing well, and India has been able to dramatically demonstrate that dramatic decline in both neonatal death and under 5 mortality has been possible. But here I would be primarily describing what Indian Council of Medical Research, ICMR, is the apex medical research organization of the country, and being at the helm of the affairs for research under the Ministry of Health and Family Welfare. Our counterpart is Department of Health and Family Welfare, and we are the co-passenger in this journey towards reducing neonatal health. And I must congratulate Sutapa, you have met the panel so well. I mean, development sector, private, I can see program, I can see think tanks, and I can see the research as well. Me. So coming to the ICMR's portfolio or contribution or trajectory towards improving research first, and then I will move to our some key research projects that we have undertaken towards this mission of reducing newborn mortality and improving every child is born healthy, to ensure that born healthy mission. So coming to our research category, so what we have kind of now very recently, after our new Director General and Secretary DHR has joined, we have revamped our grant system to make it more solution driven, because primarily initially or maybe 2 decades back, our research was mainly focused to admiring a problem. The problem magnitude is these are the causes of neonatal mortality, these are the social determinants, but now we are more into how can we solve it. Rather than describing a problem, how can we solve it? And towards this, what we have done is that we have divided, or we have kind of I won't say compartmentalized, but we have categorized our research into 4 Ds. And the most important being is that first, how description has already happened. I mean, ma'am has already described that how neonatal mortality is going ahead, what are the factors contributing to it. But our job is then comes next is develop interventions, develop solutions that are feasible, that are implementable, that are affordable, and that are sustainable. So that is the development division, research of our extramural research. And third is our delivery research. So we have developed a model, we have developed a trial, then how do we deliver in a real world settings? Because most of you must have seen very brilliant RCTs, very brilliant controlled trials have failed when they go to real world setting. So our delivery research tries to see how our solutions can be delivered in a real world setting. And most importantly is discovery. One set of scientists are primarily focused on, for example, can we have a predictive biomarker for preeclampsia? Can we have something wherein we can say this is going to be a premature delivery? So this discovery division is primarily into discovering something new or new knowledge generation. And towards this, we also have revised our grant system in terms of financially. We have Center for Advanced Research. That means any PI or any person and any institute who is already established or accomplished researcher, they get a one-time grant to set up in that particular area of neonatal health. Then we also have NHRP. I will just go through that. What are our NHRP? The name indicates that we do consider neonatal health or newborn health as a national health research priority. So many of our national health research priorities are now focused exclusively on single digit neonatal mortality. And apart from that, we do also fund intermediate grant and small grant, which are investigator initiated. It is not institute or headquarter or ICMR driven. These are because many investigators they have their own ideas, own curiosity. So these are more towards small grants and intermediate grants, kind of in this whole journey to begin with some ideas and see what works, what doesn't work. So coming to this, our first national health research priority, which is Sankalp. So as you can see that the most important Sankalp is that how do we strengthen, already Professor Kotwal has pointed out that the programs are being implemented, but how do we make it more efficient and more effective? So basically what Sankalp wants is, intents is that how can we strengthen the program which is being implemented to achieve single digit neonatal mortality. And most importantly here, we do work with the program, for the program, so that all the interventions are co-developed and optimized, and at the same time they are very context specific, as all of us have seen that each state has their own context, each state has their own regional problem, and each state has their own unique cultural problem as well. So for addressing this neonatal mortality, how do we develop context specific solutions, and also with a very inbuilt robust evaluation system. And what we are expecting is that we'll be generating evidence which can be taken up by the program, so that suitable models which can have a intervention toolkit, a package of intervention which the program can take up for the single digit neonatal mortality. As you can see, these are the 10 study sites. Since it's a national health research priority, we are having 10 study sites, and definitely the findings are going to be not only scalable but also nationally applicable. Then second is as already all of us know, stillbirth is another reason for neonatal death. So our second project, which is again another NHRP, National Health Research Priority, is how do we develop an optimized model for comprehensive intervention package and delivery strategies to reduce stillbirth. So again, this comprises of both formative phase, then optimizing the interventions and delivery strategies, and then of course inbuilt evaluation. As you can say that already we have completed the first phase, and there are 8 study sites. Again, since it's a national health research priority, 8 study sites are been included, and the aim is that at the end of the project, we intend to see that both the burden and the timing of stillbirth is reduced. Now third is, all the time, very nicely told by Professor Kotwal, why are we following Western frameworks? So why do also have Western reference standard? So this Unnati scheme is that we need to have our own standards so that we can assess the growth and development of our own children. So basically Unnati stands for, as the name suggests, upgrading norms for growth and development assessment of Indian children. So basically what here we are trying to do is that we are going to develop standards for our own children up to 2 years of age, and to develop normative charts so that we can assess for any program, for any intervention, for any standard, so that we don't have to follow Western standard, we follow our own standard. Then coming to the under 5, so what we are doing is that, because under 5 malnutrition and anemia, as highlighted by my predecessors, is that still continues to remain a stubborn challenge for all of us. So for this, what we are going to see is that how can we have improved take-home food along with, as you say, so told, community engagement and behavioral change. So how can we have a complementary strategy or a composite strategy to improve nutritional status in children? And this is very nicely named as NECTAR, and it's a cluster randomized trial. Of course, it's the trial. Then again, we have to move it into delivery research, because this is a development study. That means we are developing a model or a trial, and based on the trial finding, we will move into delivery phase, where we will see it whether it really works in a real world or the situation or not. So first 1,000 days is extremely critical for both neonatal survival, growth, as well as development. All of us know, I won't highlight the importance of 1,000 days. But again, as you can see, because we nearly need to approach, take up a life course approach, so we have stillbirth, we have newborn health, we have under 5, but at the same time, we should not miss the 1,000 days. So fill that critical gap of 1,000 days. We have another project which is under a CARS, that is, we have set up a Center for Advanced Research. And what this research center will do is that they will scale up different best practices and convert them into learning models, which is all scaled. And this is, as we can see, we are designing and implementing a very comprehensive care model, and already ma'am has told INF targets. So how do we achieve these INF targets? Through this, developing a scalable model and evaluate its effectiveness. So currently it has just recently initiated, very last year only we funded it, and it is in Karnataka in one district, because the CARS will be, we will start as one district, but later we will scale it up. And then how can we have some innovations? So this is most likely about innovations, or what do we do out of the box. So service delivery innovations, service delivery, all of us know, are one of the critical building blocks of the health system. So how can we have some innovations and showcase the innovations and offer these innovations to different states for taking up towards newborn survival and maternal health goals. So basically it's newborn and maternal health jointly, and now it is kind of the just preparatory phase, so I'm not going to tell much detail. Maybe next time when we meet, I will be able to share what is the update. So what I wanted to kind of convey is that research eco, because all of us know when we are trying to improve a mission, when there is a mission for reducing newborn health, one side is making a very good policy and planning, another side is implementation or program, and the third is very important, is research. So we from ICMR are committed to contribute or to support that research block of the whole ecosystem. And what's the way forward? All of us know that digital health is coming up in a huge way, but how, and COVID pandemic has very aptly shown that we can leverage these resources. So how can we use digital health in newborn care? So our next challenge, or our next funding will primarily be focusing on integrating digital health in newborn care. Basically, how do we improve access of information, though through integrated portal, but what digital, or how can we leverage or harness an Ayushman Bharat digital mission? And then how can we also support in terms of remote monitoring? We have set up 5 medtech zones in different IITs, and constantly they are producing designing new devices and new designs for remote monitoring for neonatal health, and initiating early intervention, again using telemedicine or remote technology. And how can parents, or how can we use information technology or access to mobile phone for parents' empowerment? And most importantly, how digital technology should not be a digital divide, but how it can be used as a tool for equity or tool for reducing the disparity. Thank you, everyone. I won't use that slide to take half a minute, so I think I finished it before, and I didn't see your raised hand. Thank you, thank you. Thank you so much, because I wanted 5 minutes to discuss with you all.
So thank you, Dr. Sanghamitra. I think we can take 1 or 2 questions. So can I request all the panelists to please come to the dais? I don't know whether we can call it a dais, but yes. That's like a... But this microphone... Okay, so are there any pressing questions from anyone? Anyone wants to know more about what is being done in the field of research, or maybe how to bridge research and policy programs? Yes, please.
Can I have a general question that nobody touched upon C-sections, and for breastfeeding, the C-sections also impact the breastfeeding. I think there is excess of C-sections in many places, not in the poorest of the poor, but in many other segments. So that should be integrated, or maybe it is, but nobody's talked about it.
Okay.
I'll pick up that. So, yeah, definitely, you rightly said, but for that, there is a C-section audit is there that we do at the ministry level during different meetings and at the state level also. that every C-section these audits should be done, that what is the indication. And so to enhance the breastfeeding during that, we are actually working on that. We have the IC material videos where it is shown that how a attendant, already there is a provision that there is attendant, should be attendant within the mother. So how the baby can be breastfed during the C-section also by putting on the mother's chest prone. So for that we have the IC which we are circulating and making it more aware for the health personnel. I think this is our health personnel which need to be more aware and confident that yes, that can be done. And one of the important stakeholders I would say is the gynecologist who are actually operating that that can be done without hindering the aseptic field. Would you like to add?
I'll just add on to this. Excellent question actually. It's a cause of concern everywhere. And it's got, it's much beyond the medical sector. It's socio-cultural and economic factors also which are there. So I think we need to, that community participation all which I mentioned in my presentation, that needs to be strengthened. Again, look at various factors. We need to have a disaggregate analysis state-wise. And we had a lot of meetings with states where I have heard the specialists also talking about that it has helped us reduce the neonatal mortality and maternal mortality in last 10 years. Why are you now talking about the increased C-section rate? But anyway, we need to address those factors. And of course, the demand side, the supply side and demand side, both factors need to be addressed. And another important thing I would like to share with you, if you see in PMJ, the difference between C-section and delivery is not that much. So that the perverse incentive which was there for cesarean, that has been reduced. The package rate, if you see, a very minimal rate. And we are now also discussing that how it can further be reduced so that perverse incentive is no more there for going for cesarean section under PMJ. The large number proportion is using that facility nowadays. Thank you.
I mean, just to add to both of you, I mean, you know about this Robson classification as well, kind of to avoid unnecessary section, particularly at the facility level. There has been kind of some initiatives going on by FOXI, and UNICEF is also working with FOXI along with WHO, how to kind of adapt that Robson classification in the system. Part of the SOP and the audit, what Dr. Shobna also kind of mentioned.
Want to add anything to it? Is ICMR doing any research on how to reduce C-section, unnecessary C-section maybe?
Yeah, again, what is unnecessary is maybe discretionary for the gynecologist. I mean, what we may think unnecessary, the gynecologist may think necessary, but that is something which is debatable. And at the same time, as I would echo with what Professor Kotwal said, is that there is a lot of demand side, because with women empowerment and people are also choosing for CS. It's not that only the gynecologist is imposing it. So this is something I think requires not only quantity I would not say in terms of statistics, but also taking up some qualitative discussions or this research, why women are agreeing for or promoting or they are willing for CS section. When we were in MBBS, we never thought that CS is desirable, but now it's becoming desirable. So it's a kind of a cultural shift also. I do not know whether anyone has read a very recent Lancet paper where they have highlighted that low CS section means in any area is low equity. But that is not actually true. Access to CS facility may be an indicator of equity, but having lower CS is never an equity. And that is something, then confusion has to come out. We need to have facility for CS, but whether going for CS or not, that depends upon that situation at that particular moment. So that's what I wanted to add. Yeah.
So I think we are getting reminders from the organizers to finish the session because we have already. I think very excellent session, very useful inputs, and each of the sessions has given us some set of recommendations which will definitely feed into the State of India's newborn report. We are very thankful to UNICEF India for supporting us in this endeavor, with support from obviously the Ministry, NHSRC, ICMR. So I think so we conclude the session here. Okay. So thank you all of you, all the speakers, Dr. Sanghamitra, Dr. Kotwal, Dr. Shobna and Dr. Zia, for all your support and for coming over to this, to attend and deliver your sessions in this particular panel. Thank you so much. And for the audience for being so interactive.
So, sir, just one moment. So, it's been an absolute honor and privilege for us to, listen to such an eminent speakers. Now, we from IHMR and UNICEF sides, we will, want to felicitate the speakers and the moderator. So now I'll request Professor Sutapabi Niyogi, Director IHMR, to felicitate Professor Atul Kotwal, sir. Again, I will request Dr. Sutapa ma'am to felicitate Dr. Sangamitra ma'am. Then Dr. Sobna ma'am. Then Dr. Zia. And finally the moderator and the moderator, may I request Shobna ma'am to felicitate Sutapa ma'am, please, once. Okay. Just done. Then ये भी अभी ले लेना. Thank you to all the speakers.
colleagues, we'll get started with the roundtable in a moment. We are still waiting for the previous session participants to leave the room. Colleagues, those who are in the room, just so you are in the right session, to confirm, this is the roundtable on building public-private partnerships. That's the one. So in case you are still for newborn health, that session has finished. Well, we can talk about that, but it might not go in the same direction. Thank you. This is a slightly odd room to have a round table in, so I would just ask colleagues who are some of our designated speakers if they could take the seats here. And so I would like to invite Oleg, who's already here. Rajiv, if you can also come, please. And because the way we have planned this session is essentially an interactive dialogue. If you would just bear with us for a minute, because we are slightly delayed in starting because of the previous session overrunning. Colleagues are sorting out some of the final logistics, so we'll start in 5 minutes. So do take your seat and bear with us. So, colleagues, we have expected actually a roundtable. As you can see, this isn't one. So the format of the session that we had, and so do bear with us, because this is not how we expected the layout of the room. The way we had planned this session essentially was that we will have some remarks by about 3 or 4 speakers to kickstart the conversation, and then the roundtable, all of you join in on this conversation. So we will kickstart the session, and we are already a few minutes delayed. So thank you so much for joining us for this conversation on building public-private philanthropic partnerships. This is an initiative that the Partnership for Maternal, Newborn and Child Health started a few months ago in terms of ways and ideas on how we can leverage the public-private philanthropic space to deliver for women, children, and adolescents' health. And for those of you who do not know what the Partnership for Maternal, Newborn and Child Health is, we are the world's largest alliance working for women, children, and adolescents' health. Partnership is a hosted partnership of the World Health Organizations. We are based at the WHO headquarters in Geneva, And my name is Rajat Khosla. I work as the Executive Director for the partnership, and it is my great pleasure to welcome you all for this roundtable conversation. Colleagues, the data, the statistics are very well known to you all. We are looking at progress on maternal, newborn, and child health, which has largely stagnated or stalled, as one would say, in various regions of the world. And actually, since 2016, we are looking at trends of reversal of progress that has happened across the spectrum of indicators related to maternal, newborn, and child health. The most recent data that is released by WHO on maternal mortality, for instance, presents a picture where we are still looking at about 700 women dying of preventable causes in childbirth every day, 260,000 women dying every year. With that in mind, one has to look at how can we actually deliver for women, children, and adolescents in the variety of settings, and particularly recognizing that increasingly, predominantly mortality is actually coming from complex settings, from fragile conflict and disaster settings, from low and lower income country settings, and for climate affected scenarios as well. And when you do look at this rather complex picture that is starting to emerge, one does need to look at is how do we most effectively reach the women, children, and adolescents that we are trying to reach. And in doing so, we do look at both the ability of state and government-run programs to deliver on this, so the public provision of healthcare services. However, we do know that we are looking at, over the last several years, a plateauing of funding that is going into public health more broadly. And within public health expenditure, if you look at it at the country level, you are looking at a reduced funding for programs related to women, children, and adolescents' health. The same can be said if you look at the OECD data for ODA investments related to these issues, which have been stalled for a long period of time. And over the last few years, for programs such as family planning, reproductive health care, we are actually looking at a reduction in funding that has been happening. Now, of course, that picture has now become even more complicated and more precarious because of the US withdrawal and freezing of aid, but also how several of the European donors are now reacting in terms of scaling up their defense expenditures and scaling down, as a consequence, the overseas development assistance that is available. So what do we do? And what are some of the solutions that are available to us? And in this regard, we do look at, what are the sort of partnerships can deliver for these issues. And it is, with that, we do look at the private sector, for instance. And private sector, not least because of the potential to match the funding, to plug the deficits that we are talking about, but also private sector as a partner to deliver in that complex settings and scenarios that we are talking about. So what is their role? How do we partner with the private sector? And of course, within global health, there are critiques of private sector as well, the non-state actor and the role that non-state actors can play, and how do we navigate that sensitivity, which many would talk about in terms of the growing and the rapid expanding role of private sector. What is the role of the philanthropic institutions? Today, one of the biggest funders of global health is a private philanthropic foundation. What role do they have to play when we do look at these scenarios, and what can be done and achieved through a model that we would like to call as the public-private philanthropic model? We are very pleased to invite, as I said, this is meant to be a circular table. There are nameplates for for all of you in that thing. Some of the ones we have been able to find. Please bear with us. This is not by any means meant to be a disrespect for you, but what is just a funny format for a discussion which was differently planned. What I will do is, in that spirit of conversation, I will come to Oleg. I will come to Sandeep and to you also from Laridal for your brief framing remarks on what do you see are some of the potential, the challenges, etc. And then what we will do is we'll try and do a more tour de table, and we'll get you all to speak your interventions. And I have some framing questions that I will come to you. But let me turn to you, Oleg from Ferring Pharmaceuticals, for your reflections on how you see the public-private philanthropic model playing out. Over to you, and thank you for joining us.
Thank you very much for this opportunity. Good morning, ladies and gentlemen, colleagues. I'm very, very proud and humbled to be the speaker here. I'm working for the last 6 years actually specifically on this ESG initiative by Ferring Pharmaceuticals, which is looking to introduce heat-stable carbetocin to the public sector of all low and low middle income countries, including India, including African countries. And we are doing that in collaboration from the very onset. So actually just talking about the role of the private industry, so we were the innovators behind carbetocin initially. That was introduced in late 90s. But it was originally for the C-section indication for postpartum hemorrhage prevention. And then Ferring developed the heat-stable version, which is addressing the challenges and the needs in developing countries in many places that's hot climates, challenges with the cold chain. And then about 11 years ago, we started this partnership with WHO and MSD for Mothers to first looking at the clinical development for the vaginal delivery indication for postpartum hemorrhage prevention. So that was the first step, and it's starting from the onset. The clinical development was done, and then it was going into the phase of updating the guidelines, updating the essential medicine list, both at the global level by WHO, but also at the country levels. And it's also related to the regulatory work, because we committed to register the product in all the countries which are in scope for this initiative. And this work is being done in collaboration with Concept Foundation, and so Ferring and Concept Foundation are working on all the regulatory filings. We got the registration initially by Swissmedic in Switzerland. India was one of the first countries also. Currently we stand at 25 registrations and counting, so we still have about 40 countries to go in that scope. So it's a huge undertaking. Then a heat-stable carbetocin is well, it's an important innovation addressing the postpartum hemorrhage challenges and the needs. But I think it's also a great example. It's a case study, but effectively highlighting kind of like a litmus test, going through various stages of the introduction of the innovation and showing what are the barriers and what are the ways to overcome. And at every stage of this work, we're looking at collaborative efforts of different partners. So regulatory stage, then the advocacy and the policy change at the country level. That we collaborate here with UNFPA, for example, is instrumental in that kind of work. UNICEF in some countries also. We collaborate very closely with OBGYN societies, midwife societies. Also, evidently with the ministries of health and the whatever division is responsible for the maternal and child health, and also for the increasingly so with the universal healthcare. We also collaborate very closely when the product is registered and is included in all the national formularies and it comes into the system. We are also collaborating with various programs and organizations at the local and at the regional level to introduce the training for the healthcare professionals, because it's been for decades when oxytocin was used for postpartum hemorrhage prevention, and people know that it's poor quality or degraded by heat, so it requires multiple injections, and that is not the case for heat-stable carbetocin. So it's not a very complex training, but it needs to be implemented. So we collaborate also again with multiple organizations in different countries how to introduce that. Importantly, like we collaborate with Maternity Foundation on the Safe Delivery app and advocacy and the training. We collaborate with Lardal on the introduction also and the training efforts. Importantly also, like once all this kind of regulatory and clinical steps are done, a lot of implementation research was also done by various collaborative groups. For example, MSD for Mothers were supporting Smiles for Mothers initiative in Nigeria and Kenya. We also see the increasing role of Unitate in funding and supporting the both the implementation research, like Amplify program by GPI, GoPath, FIGO, and also the clinical development continues for this REACH trial for the treatment indication for heat-stable carbetocin. My point is that without this very broad scope of collaboration, all this progress is not possible. So we need to really, and it's complex. It's not easy, but it's like in this kind of close collaboration and continuous dialogue. That's the only way we could succeed. I would also like to emphasize the role of the governments and the national or the state levels, because in the end, it's the political leadership which is enabling us to really get these innovations to the patients and to the healthcare professionals. And I would like to end that with that, just like all these accumulated efforts and the political leadership would lead to the outcomes which are very impressive. For example, Makueni County in Kenya, for the last 2 years, following the introduction of heat-stable carbetocin and the emotive bundle, they recorded 0 PPH-related maternal death. So that's achievable, that's doable, and it's I'm a very passionate actor in this field. I do not understand why we still have this kind of rounds of bureaucratic debates, just to why we are contemplating. There's plenty of evidence which need to overcome these last barriers.
Absolutely.
Sorry for this long spiel, but it's I just try to cover a couple of decades of the work of different collaborations. Thank you.
Absolutely, and thank you for that, Oleg. And it's an important framing, because what you point out is not just in terms of the collaboration between public-private philanthropic arms of different institutions, but also many of in this room would know the top 5 causes of maternal death still is postpartum hemorrhage, and the innovation coming via the ESG model that Fairing championed with partners has been game-changing. And not just in terms of reduction of cost, but also in terms of the ability to scale and how do we do that. And we'll hear more from other colleagues as we move through this square table conversation, or whatever you may call it eventually. Sandeep, I would like to come to you next from Bayer, and then just so we know how we are going to do this, after Sandeep, I would like to come to the colleagues from Laredal and Maternity Foundation for their brief reflections, and then we will go through the square of this room and hear all your perspectives as well on some of the opportunities, lessons from South Asia, and your own experiences as well. Sandeep, over to you. And if you could also introduce yourself, given all the nameplates are wrong and not there.
More or less correct, more or less correct. Good morning everyone, all the speakers and all the members of the Square Table Convention. My name is Sandeep Verma. I'm the cluster head for consumer health, Bayer Consumer Health for South Asia. Where do I start? So essentially at Bayer Consumer Health, I'll try to keep it in 5 minutes flat. So at Bayer Consumer Health, our overall vision is to reach out to 100 million underserved communities, okay, by 2030. So in the next 5 years. So we have we are currently reaching about 25 to 30 million, but our vision is to reach almost 100 million women, 100 million people in the underserved communities with self-care. Now, what is self-care for? I mean, I'm sure all of you know what self-care is, but just a very quick definition of self-care. Self-care is essentially all preventive health methods that you take with or without the help of any healthcare providers. It's all preventive healthcare. I think you started with a very, very sobering comment on the 260,000 deaths, that happen to women in the stages of pregnancy or post-pregnancy. And in the light of this, it's very apt to know that this year, World Health Day is focusing on, I think the title is Healthy Beginnings and Healthier Futures, or something like that, right? Hopeful Futures, sorry. Hopeful Futures. And this is such an apt thing to talk about. Besides the 260,000 deaths of mothers, there are also 2 million children who die in the first month of birth, and there are also almost 2 million stillborns which happen in this world. Now, statistics are mind-boggling, but just to put it in perspective, that's like 1 preventive death every 7 seconds across men, across children and women. Essentially, and that's where we believe that we've done something that may be scaled up. So at Bayer Consumer Health, our focus is on the first 1,000 days So when the pregnancy, when you figure out that the woman is pregnant, till the next 1,000 days, if you're able to take care of her nutrition, I think that can just put the whole entire trajectory of health of the mother and the child into a different orbit. We started a program in 2020, which is called the Nutrient Gap Initiative, where we are basically working with a public health NGO called Vitamin Angels. And the program is basically, it sounds like a very basic program, so I'll just tell you, it's basically a three-pronged program. The first prong or the first pillar is accessibility, access. So what Bayer does is that we provide 6 months of free multiple micronutrient supplements to all the mothers across 20 countries in the globe, and we go to the underserved communities. Now, very important point here to mention is the role of MMS, or multiple micronutrient supplements, and what this is. So the World Health Organization in 2021 has called this to be put in the essential medicines list of all the countries. Some countries have done that, some countries are on the way of doing that, and this is the single intervention that can actually help prevent all of these deaths that we've spoken about. So back to the program. So the first leg of the program is providing access to these MMS in the underserved community. That's what we do. We're doing that in 20 countries right now. The second leg of this program is education and awareness. And here, obviously, one important part is to make the mothers aware of this, or the pregnant women aware of this, the importance of this and how to take care of herself. But what we figured out is that it's even more important to make the healthcare workers aware. And especially in these developing countries where you have a lack of doctors. We all know, what the situation, what the statistics in India and rest of the countries are. Healthcare workers' role is so important. So what we do is that we actually have certification programs for the healthcare workers where we train them on MMS, the importance of MMS, and how to ensure that they're giving the right information to the expectant mother. So that's the second leg, accessibility, education, and the third leg is policy change. You spoke about the policy change and the importance of governments in this. So we're also trying to work with the local governments, with the country governments, and trying to get MMS to become a part of the national health policy itself, okay, just to get it more priority. And I think it's the simplest intervention. I think you spoke about very serious issues. I'm just talking about self-care. I'm just talking about preventive health. I'm talking about things that can be done so that you don't come to that kind of a stage, So that's what we do. This program is called Nutrient Gap Initiative. We just launched it like last year in India as well. Currently we've reached about 20 million expectant mothers in the last 4 years of this program. We believe that we can scale it up much more. And I think the and we have many success models. For example, Bangladesh has included MMS in their national health policy. Indonesia has included MMS in their national health policy. And I think the Indian government is doing a lot of stuff as well. One of the biggest challenges in India is anemia. One of the biggest things which is the cause of all of these issues in India is anemia. As per the latest report, almost 60% of women in the reproductive age in India are anemic. 15 to 45 are actually anemic. So MMS actually helps you in preventing anemia or catching it at a very, very early stage itself. And so I think what we have done, what we are doing is just a very small drop in an ocean, but we believe in adding more and more drops so that this program can become much more scalable. And obviously we need collaboration from everyone, all of the people that you spoke about. So my simple point is, my last point is that we should identify such programs or such pilots, successful pilots which have been done by other companies in other countries, and then we should try and scale them up as much as possible. Yeah, because it's otherwise very difficult to keep starting new programs. That's really not a workable or a sustainable option. So let's identify these programs which have had some semblance of success, and let's try and scale them up into as many countries as possible. Thank you.
Thank you. That was wonderful, Sandeep, and really remarkable, because one of the things that we at the partnership are looking at, and in partners with the private sector philanthropic constituency, is how do we think about innovation pipeline? Not just looking at innovation deficits and gaps, but actually seeing how we can incentivize low-cost innovation models that can then be taken to scale and result in actual policy decisions. And wonderful to hear the example of the nutrition interventions that you talked about, and preconception interventions as a key area to focus upon as well. Colleagues, what we will do now with these two very helpful framing remarks is move into the roundtable. And I do have the colleague from Laredal and the Maternity Foundation to help start the conversation. And the conversation, we would like to focus on not just looking at the value proposition of public-private philanthropic partnership. I'm sure we can all speak with great passion to those issues, but also I would like to really hear from you your experience in implementing it. Where do you find the challenges? Are there policy frameworks that enable such partnerships to flourish, to happen, to take place? Are there governance issues that you are confronted with? But also solutions that have proved very helpful. I know for both colleagues who are going to go next, there has been some remarkable work that has been done, which has led to saving countless lives in countries that are in desperate need as well. So if I could start with you, and if you could please introduce yourself, given us a slightly clunky situation at the moment. Thank you.
Thank you so much. So I'm Anna Frelsen, and I'm the CEO of Maternity Foundation. We are an NGO, and we are behind the Safe Delivery app and program that currently is scaled across 70 countries and have reached almost 500,000 healthcare professionals in low and middle income countries. The Safe Delivery app is a boil down of global and national guidelines that are, translated into a job aid and into a training tool and into an accreditation opportunity in the countries that we work in. And it's designed for and with the remote setting in mind, which also means that it's a free tool, it works offline, etc. In the conversation of how we work together, the idea of sort of being an NGO with a program that goes out and roll out a program, I think is a little bit yesterday. So we have a global good. The global good needs to be first and foremost endorsed at the country level for the national guideline. For that we need ministries, we need midwifery associations and other professional associations. Then we need the tool, the training methods to get out and into the hands of the midwives and the other healthcare professionals. That requires partners all the way around. Because there's no midwife in Afghanistan or in Bihar who will think about the app just like that. It's about the partnering ecosystem. There are also, I think, when we talk about these partnerships, we all talk about, the importance of partnering. But it's not only that it's important. It's not about the what or the why. It's about the how. And there we need to talk about, where are the real synergies in the business models of how we work together. Even NGOs have started to talk about business models, just as much as pharma companies are talking about social impact. So this sort of is becoming more blurry, and that's the sweet spot. That's the opportunity, but it can also be where it becomes a little bit difficult. So finding that complementarity in the actual, implementation is crucial, and it can be done, and it needs to be done ultimately for the mothers and the newborn. Just a few examples of course, as an NGO, we do not promote specific drugs or specific interventions, but I still think, what we can provide is access and understanding of the ecosystem, and as you mentioned, Oleg, we can provide, instructions and guidance around, the commodities and the innovations, whether that is how to appropriately use various oxytocins and carbetocins, and including, of course, heat-stable carbetocin, whether it's, how to, guide around family planning and the use of various modern contraceptions, implants, etc. That synergy, if you can translate that into real, synergies in collaborations, I think that's where we need to get to, not just like the importance of working together. So my hope is that we will see many more of these examples in the future, and I think that is the way we need to go.
Thank you. Thank you for that, Anna. And actually, very helpfully bringing us into how we situate these issues within a very complex ecosystem that we often operate in, and how do the different moving pieces actually fit and work together. But what is also important, I think, as you were talking, I was thinking, is that how important it is for us not just to end with the idea of innovation or a product or a commodity, and the fact that putting it on the table does not necessarily guarantee access. The examples that you gave from Afghanistan, Bihar, etc., are very much point in case. And a request to all our speakers is that do feel free to come back at any point in the conversation as you deem free, because it will be good to hear your reflections on the other things that you are going to be hearing from you. And with that, over to you, Rashmi, and from your perspective at the Laridal Group, and do introduce yourself further.
Good morning to all, and I'm Dr. Rashmi Aradhya from Ladal, and we are a small Norwegian company. It's a private sector and it's a family-run company, established way back in 1940 as a publishing house, and we went on to make toy dolls and then life-saving dolls. At Ladal, we have this humongous goal of helping save 1 million more lives. And we also believe that survival is not just a function of just an innovation, but it's a function of medical science multiplied by educational efficiency, multiplied by local implementation. And when I say local implementation, it includes policy and the bricks and mortar at the field level, at the equipment and all of that. Now, typically, the medical science now, it's because of the internet and everything, it's available across, in the remotest of the parts of the world. It is the educational efficiency and the local implementation which typically are the weakest links of the chain. And even if the best medical science is available, but either of these is weak, the survival that you get is exponentially reduced. And one of the things that we also believe is we make a lot of innovations at Ladal, but unless innovation is translating into impact, that innovation is of no good. And so I'll give you one example of an implementation like what you said, so Tanzania, 30 hospitals, sort of a PPP model with the government of Tanzania. We kind of combined the quality of care with innovations. Instead of a stethoscope for a baby, we made something where, one hand of the midwife or the health worker is free. You just put in like a strap which gives you a digital reading of the newborn heart rate. Instead of, the PNARD, we made something called as Moyo, which sort of, sticks onto the mother's belly, and it gives a digital reading and also an alarm on the therapy component, and also for resuscitation and all of that. Different innovations. Come to the training part, again, highly affordable ways of using digital data from training, wherein I don't require for a faculty to actually come teach me all the time, but my phone is teaching me. So I'm just there by myself in the middle of the night, whenever I have time, practicing by myself. And this data is feeding back into the facility champion or the head of the facility, who's actually saying that Rashmi scored 80% in newborn resuscitation or managing postpartum hemorrhage in training. But in a real case, which is also gathering some data, her score was less than 50%. Or she wasn't able to get the baby from here to there in time, or she was not able to start the ventilation in time. All of that data coming together, guess what? In just a matter of 3 years, we have been able to see, and this is completely driven. so the different components here, like, so the government brought in the vigilance and all of that. The facility itself brought in their own way of looking and getting things done. Ladal brought in the innovation, and then there was another, the SAFER, which actually brought in the research component. So all coming together, there was a reduction of maternal mortality by 75% and newborn mortality by 40%. Unheard of. And I think that's the power of public-private partnership, when everybody understands what's their realm, what's their strength, comes together and beautifully sort of, puts it together as a mosaic to actually come up with impact. And I think this is and this has just been published in the New England Journal of Medicine just a few weeks back, and that's something that we are extremely proud of, because it's not just one person. It's not just the innovation in itself would never have done this, or just the facility champion would never have been able to achieve that result, or just the ministry by itself would never have been able to achieve the result, had they just done their vigilance bit of it. But I think when everybody came together doing their bits, that's when magic happens. That's the power of public-private partnership.
Thank you. Thank you for that, Rashmi. And for those who haven't read that New England Journal of Medicine paper that Rashmi just mentioned, do please look it out. It is a remarkable achievement, and the work that has been done in Tanzania is being reported there. And one thing which is rather remarkable about the Laredal study is also the learning approach, which you were talking about, which is built into the frontline provider experience and how it can be built and then built to scale. And that's remarkable. And I think let's see how we look at these issues and continue to build through the different other perspectives as well. Prachi, over to you, and do please introduce yourself, and will be great to hear your perspective as we move through the other speakers too. Thank you.
Thanks, Rajat. My name is Prachi, and I lead external affairs for Organon for India, South Asia. And Organon is a global pharmaceutical company, and I think what is unique about us, that we are a women's health company, and a very brave decision as we parted our ways from MSD 4 years back. I think I was very excited to hear about the whole idea of public, private, and philanthropic partnerships, because that is the core strategy for making our drugs accessible. As the pharma companies are coming closer to the ground delivering their services, we see that drugs are not just changing in the new molecules. There are new devices, there are new delivery mechanisms, which are making a huge impact on how a medicine can be taken to a woman for saving her life, for changing quality of her life. Organon has a global access initiative, which is actually called a global access program. Which is in partnership with Gates Foundation, UNFPA, and several organizations who would be participating in this conference, and which actually makes our contraceptive implants available across FP20-30 countries at a very, very cheap price, at a fraction of price which they're available in other markets. In addition, we have something called Her Plan is Her Power, and at the core of our philosophy, we believe that when women will start making decisions, they will become healthier. And as a pharma company, we really do not have ability to reach women and enable them to make decisions. So in India, we have several partnerships. UNFPA, Deepa is sitting in the room, has been supporting us in that. I would just like to share a small story on what we did in India locally. We started a small pilot project in tea gardens of Assam to demonstrate how contraception access can save lives of young girls who are 16, 17, 18 years old, severely anemic and subjected to repeated abortions or repeated pregnancies. And that small project actually, um, what do you say, it pursued Government of India to bring Implanon in their basket of choices. And today implants, our contraceptive implants, are part of the National Family Planning Program. And in last 3 years, we have continued to work with our philanthropic partners in making training more accessible, bringing quality training, retraining, and sustainability of what they learn, taking to the last mile. We are creating new delivery mechanism, not just the National Family Planning Program, but also through social marketing organizations at a much cheaper price than what we would do. And we realize that commercial market, our corporate hospitals, are often not the best point of service delivery centers to reach women who are in tier 2, tier 3 category towns. So we have actually changed our overall commercial strategy itself to come in the ambit of public-private philanthropic partnerships, and that has given us tremendous strength and rapid growth in the Indian market. So I'll pause here. If there are any questions for me, I would be happy to take.
Thank you. Thank you very much for that, Prachi. And importantly, coming in from a reproductive health commodity supplies perspective, and how does one innovate access to a contraceptive commodity, which many would think is a given in today's state, that there will be stockpiles that one could come and access from, but it isn't. And thank you for showing how the whole business model has been turned around to build into that public-private philanthropic model. And then I hope as we go through the conversation, we can continue to build upon these perspectives. We do have all 3 UN agencies in the room. We've got UNFPA, UNICEF, WHO. So as I said, this is whatever geometric shape we are in by now. But unless people want to jump in right now, I would like to go to the 3 of them for their reflections to help us build through this. That was the kind of applause we were looking at. Exactly. So can I start with you from UNFPA perspective as well?
Thank you, Rajat. I'm really excited to be here in this room and to listen to a lot of all what you're sharing. It's actually music to me and to UNFPA, because there have been several initiatives globally, and what we are trying to bring down to India, and how do we bridge this or connect the gap between public, private, and philanthropy. Just to share, one of it is like we have this Women X Collective, where we are looking at innovations and pilots which have been done globally by the private sector. In others, how do we take it to scale in the public sector? That's something which we are really looking at, and also within India, trying to target states which have high maternal mortality. How do we bring those innovations to here? So that's something, when we are talking about bringing all the 3 Ps together, this is something which I think as UN agencies or philanthropies can actually do. Another thing which I wanted to share, connected but slightly different, is the Coalition for Reproductive Justice, which UNFPA launched in 2023 at Davos during the World Economic Forum. And then last year we launched the India chapter. Essentially, this is about advocating with the corporates and the private sector on sexual reproductive health of women in their workplace. And we've got excellent responses and interests of large corporates and companies who want to be the champions. And it's not just about advocating and introducing, but we are also helping them with some measurement tools. We have something called the return on investment. And we did an exercise with Shahi Exports in India, which has nearly 60,000 or 70,000 women in their workplace, where they invested for menstrual hygiene. And the return on investment was humongous. For every dollar they invested, they got about $3 in return. So we've had excellent examples, and also now we're seeing greater interest of large corporates such as the Tata Motors, IKEA, Welspun, etc. So our effort is essentially not just to advocate and influence and work with the public sector, but we're trying to see how do we connect all of it, taking pilots to scale, bringing in innovations from different parts to India. And what I see the strength of all of these sectors is with the public sector, we see there is reach, there is universality, infrastructure, etc. And private sector, it can bring in efficiencies, innovations, tech, non-tech, quality, attract talents, all of that. And philanthropy, of course, they can bridge this and ensure that we reach out to the underserved regions. A lot of it, what we are talking about, even this morning I attended the session on carbetocin, etc. How do we advocate with the government to see that that's a need in the most unreached areas? Although the debate is different, how do we scale it up in such a huge population, but how do we kind of work on mechanics to see that it's available to the most needy? So I just pause here and hand over to you.
Thank you so much. And I was actually at the launch of the Women X initiative, which was at World Health Summit in Berlin a year ago. And it's remarkable, the kind of ideas, innovation, and talent that is being brought through the initiative led by UNFPA. UNICEF, next, please. And do introduce yourself.
Sure. Thank you, Rajat. Sorry, the first opening plenary, we had to extend. So I'm Vivek, by the way, currently the Chief of Health for UNICEF in India. And very happy to be here. We are discussing the 4 Ps. The PPP earlier, when the 4th P was missing, people thought that, and I'm talking of the MDG era, we are discussing SDGs today. People thought that public-private partnerships was very transactional, thinking that, there is public, which needs something, and then private comes in. And this transactional thing, then the 4th P started getting added, that is there a purpose? Who can bring in the purpose? Or people, where is people in it? And now we have philanthropy, the 4th P, of course, which is largely driven by purpose. But I would want to refer to, when we were moving from MDGs to SDGs, the SDG Knowledge Hub came up with a paper which said this nexus is very important. And let me point you to the 17th SDG itself, which is about partnerships. That to move to an SDG era and to look at 2030, the 17th goal itself is about partnership. And where this Knowledge Hub paper said, whatever partnerships that we do, we should look at this nexus from the point of view of A, B, and C. And A here is administration, which is the states, who's responsible for taking things to scale for its population, like State of India. B is businesses. So businesses come in with their A's, like their assets, their corporate social responsibility, and their employee engagement. Many of the businesses have thousands of people, if not million, working across the globe. And C, and the most important part of this nexus was the civil society, who can hold the A and the B responsible. So what is important is, not in isolation, but we know that what value add they all bring. But what is important is the nexus should have all the 3 C's. I added a D to it because I came from civil society to the UN. I was earlier in an academic institution, I still teach. And I realized UN is not as powerful because of her multilateral nature as the civil society sometimes. Civil society can raise any issues to bring accountability, even with the D. But D can bring in a lot of policy which are global, for example, the SDGs themselves, and help states to see how this is translating. So I think the message is that it is not one or the other. This nexus is very important. And I'll pick 2 examples because we are discussing World Health Summit. So at the World Health Summit 2023, UNICEF launched a $100 million plus partnership with the MasterCard for community health and nutrition development. We call it the CHDP platform. That today, even with the decreasing mortality, or even if we are going from like the recent World Health Day theme of healthy beginnings and hopeful future, we need to strengthen for UHC approaches through primary healthcare, engaging communities, the role of communities themselves, and frontline health workers as the agents for the communities. So a launch of this partnership where MasterCard came in, UN and UNICEF, mainly through UNICEF, the other partners came in, and now we are trying to see how this can be used to catalyze things. Second, that many of the states are now seeing rise of these philanthropies and businesses within country. So for example, a business in India came to UNICEF and said, we want to invest our corporate social in early start, care beyond survival, which is not just a moral imperative, but if you're talking of demographic dividend, we want the population to be healthy. And that $1 million, which is not a small endowment for somebody from India, $1 million fund was to work on developmental disabilities. Again, driven by some personal motivation, but they were okay to say, okay, not one specific condition. We are fine if UNICEF feels that with Government of India, we can align to some of the priorities and catalyze things in inclusive ECD. So now with that fund, with the recent UN IGME estimates that were released, India was spotlighted as an exemplar in reduction of the child mortality, also maternal mortality. Globally, there has been a stagnation. But what is more important to understand is that survival is just the beginning for newborns. That's where we begin. We don't end there. Then beyond survival is the main game. And inclusive ECD, this $1 million fund from an Indian business is to provide frontline functionaries and parents of children with special needs. The 20% children who will either be born with birth defects or will fall out of the growth trajectory if we don't follow them up well. So we are catalyzing that. And now states by states that have already started going towards single-digit mortality, now we are using the government platforms and programs to see how focus can come in this issue. So the message is very clear. We have seen this recently grow, and Rahul is sitting here, who's from our partnerships team, that the value of the money that can be generated, not just the money, but as I said, for businesses, ACE, assets that businesses bring, this corporate social responsibility is the only thing mostly people understand, but also employee engagement, we can catalyze a lot of change. Thank you very much.
Thank you. Thank you for that, Vivek. And then very helpful to bring in the focus on partnership at the core. And as somebody who does lead the world's largest partnership on the topic, I can tell you how critical it is to have that as the core value proposition on what we do, not just least because of the power of us coming together and what we can do together, what we cannot do separately, but also to reach the hardest to reach, which requires us to, as several examples here have shown. And with that, I'm coming to my host institution and dear friend from WHO CRO for their reflections from the World Health Organization perspective on how do you see this, Rajesh, and do introduce yourself as well.
Yeah, okay, thank you. Thank you so much. I'm Rajesh Khanna, and I'm the Regional Advisor for Newborn Child and Adolescent Health at the Regional Office of Southeast Asia region. Now the topic, I think we don't need to say why is it important, because all of us are converts, to be honest, in a small room. But critically, the time is changing. You know, we have seen the latest estimates that have come up for mortality, both maternal, and we also had the newborn child and adolescent estimates. But we are still losing lots of children. Though we have made significant progress. More importantly, the agenda of survive is now not that exciting. Of course, I don't say that it's not there. It's there. But the countries are in varying stages of transition. And thanks, Vivek, that you brought it up. We also have the agenda to make sure thrive and transform. You know, if we are really looking into comprehensive approaches. The third is, it's not about me nowadays, it's about we. Just reverse the thing. Now, coming to such excellent examples and coming from WHO. Now, WHO, just to let everyone know, yes, it's an intergovernmental agency. And we work directly with the governments. But one big thing is that people realize is that, and we usually think that, no, WHO does not go into implementation. I'm sorry, friends, this is where WHO's role has been, you know, disappointingly not been very clear. The challenges that I'm hearing today, accountability, we are hearing governance mechanisms being considered, issues regarding policy making, So these are the issues that probably I need to learn more from you, and I think, so Rajat, over the subsequent discussions, I need to get more clarity on these. But these are the issues that we can really work together. Making sure that WHO is definitely for public-private, the 4 Ps, and we are changing our organizational mandate also. We have a new foundation that has come up, which is exploring partnerships. We have long-standing commitments. LADL has been, we are working with Ferrin. So we are, MSG has been a long partner. We are also working with Maternity Foundations. So we have been working with a lot of partners, but the only thing is that we don't work, we make sure that this gets translated into impact at scale. So we help them transition from the phase of inception, making sure that they get inroads into this country system. We support the countries into accepting, establishing norms, guidelines, how this can be monitored, monitoring, evaluating it, so that you have a sustainable, impactful model created, which can then be taken by country and the other partners at scale. Just to give you 2 important recent innovations where you can see huge change that has happened, and WHO played a critical role. We all heard of kangaroo mother care. Now since 1971, I think that this was 1979, sorry, this came up. But till 2015, it was just patchy implementation. There were some evidence gaps, and that's where WHO, as its ability to convene different organizations, brought together all the organizations. I think there were about 70 organizations involved in it. So 3 different issues. Can you take this low-cost intervention at scale? When do you start it? Can you start it in unstable preterm babies? Because it was always thought that you can only start it at babies who are stable. And third, you only think, people already thought that it can only be done at the facilities. You can't do it at the community. So taking these 3 questions over a period of 5 years, working through implementation research, working with the governments, philanthropies, and private sector, a huge evidence base was created. 2 years back, we had the implementation guidance and a new white paper that was created. And it clearly showed that there's going to be at least 40% reduction if all the 3 things can be done. So it's a life cycle approach, first of all, that we are taking. And secondly, this is the power of the 4 Ps that we are looking at. And I'll share, apart from it, the bigger thing is that because I come from a regional perspective, India, we have seen excellent examples of COVID vaccine production. Nothing better than this from a PPP model. Bangladesh, you had the community clinics, started way back in 1998. Again, the 4 Ps were involved in it. In India now, in urban scenarios, you have the 4 PPPs model. School health program in Thailand. Lot of private sector engagement and philanthropies, but then the government is taking leadership in it. So you have from the region fantastic examples, and this is where I think as WHO, we tend to contribute. Bringing the best practices, making sure you work with the government, contextualize the solutions, first create evidence, then make sure that how you can implement them, and then supporting the countries in implementing them at scale. Creating first evidence, so you have contextualized solutions being created in the countries. So I will stop now and look forward to hearing more about these challenges from you people, because you are the real ones who are working at the field. Thank you.
Thank you very much, Rajesh. And actually, very helpful for you to lay out how does WHO work in this space. And often people think about WHO's role as limited to only normative aspects of it. But what is critically important, as Rajesh very rightly demonstrated, WHO's role from a programmatic implementation perspective as well, but also WHO as a space for convening and bringing together and advocacy and hosting some of these initiatives as it does. Colleagues, this is where having a round table would have helped, because we would have known each other and who are there. But as somebody who spent a lot of his time in academia, I'm going to start calling out people, unless you want to raise your hand and take the floor next. Oleg, let me come to you in a second, but let me take a few other perspectives from the room, and then I come back to you as well. Please, and do
Rajat.
introduce yourself.
Thanks all the speakers for great perspectives. I'm Himanshu Sikka. I'm from IPE Global, and I lead a initiative, Samrid Impact Solutions, which in a way acts like a bridge between the public-private philanthropy space and helps them to come together and scale their work. One important aspect that I wanted to kind of highlight, which we have kind of so far missed in the discussion, is that private sector is not homogeneous. It's kind of very, very heterogeneous. While in the room we have the large organizations, global organizations who have been working and doing great work in LMICs, but there is also an innovation kind of ecosystem that's brewing in countries like India, in Africa, where you have a lot of startups which are also coming up with very innovative low-cost solutions. And that's also a very key private sector that needs to be brought into the discussion. And that's specifically where we have also been working a lot with local domestic innovations and helping them scale their operation. Another big aspect of the private sector is that while of course philanthropic money comes in, but there is also a lot of private capital that is sitting on the fence, looking at this space, looking at health. They realize that this is a market which is mature and maturing and ready to come in, but they're looking at kind of structures where they can invest, because healthcare, unfortunately, is a space which requires long-term investing landscape. Gestation periods are high, failure rates are also high, adoption rates are slow. So given that, when we're looking at PPP, I think these are the two more pillars that we need to kind of look at, or sub-pillars that we need to look at, and see how we can, as a group together, facilitate them. Through our work, we have kind of worked with close to 100 startups now in the country and help them scale their operations. But that's only, I won't even say a tip on, of the iceberg, but possibly a needle in the haystack of the kind of innovations that are there in the market. So as we kind of move forward, let's also think how we can kind of build that ecosystem further.
Himanshu, stay with that. I did actually, before I come to you next, it's an important point which we don't talk about and often gloss over when we talk about partnership models and bringing public-private philanthropic together. That you said this is not a homogeneous sector. There is a diversity of private actors that we are talking about, and there is also a question of trust that comes in, because often people critique some of this work because of different motivations, objective, marketization, as it is being critiqued. How does one navigate that space, and where do you see this meeting of minds that can help to deliver on the solutions?
Yeah. See, based on our experience, whether it's a large corporate, private sector wanting to work in country, or a small startup, I think the biggest challenge that they face is that even if they have regulatory approvals, unless they have proven in large numbers through pilots, through validation studies on the ground, trust never comes in. Doctors and health practitioners want data, and unless that's lacking, if that's lacking, that trust will never build up. So, like we have worked with Ferring, the implementation model in Madhya Pradesh. The drug carbetocin was approved by WHO, was approved by the government, but still not being adopted in the public sector. Why? Because they want to see real case studies on the ground. Similarly, with a lot of startups that we are working, they also require that validation support. They have CDSCO approval, but nobody is going to adopt their solution unless they do multi kind of centered research, which gets published in peer-reviewed journals and then gets adopted. Similarly, when you're looking at capital coming in, again the question is also always comes in from philanthropy's mind also, and from government also, they are making profit. Our basic question to them is that without profit, you cannot have a sustainable organization. So you have to bridge that gap. You have to kind of show them the value addition that today you are spending X amount of money, which is not leading to any results. If you adopt these solutions, then things can be done differently. And there, I think one key thing that we have kind of tried to, and it has kind of worked, is that can we use the philanthropic money to be that trigger, to be that catalytical capital in the beginning, which can then get in more commercial capital in and help both established and early stage companies to grow their operations in this space.
Thank you. Thank you for that, Himanshu. An important point, because I think what you did say is right. We do need to recognize there might be different triggers, but that there is a commonality of goal to be achieved, and how we get there is important. Oleg, I know you wanted to come in, but let me take a colleague first, and then next to you, Oleg, and I come to you, and you as well. Thank you.
Yeah. I'm Dr. Shanta Kumari. I'm the FIGO treasurer and the past president of FOXI. I'm sorry, my voice is gone. I do understand. So at FIGO, we say we are the global voice of women. And FOXI, we have about 45,000 members here. We have 139 countries in FIGO. All these innovations, all these advocacies, all the drugs, everything. But remember, we are the first, obstetricians are the first point of contact with the women. So with the innovations, the drugs, the policies, the advocacies, when we dole out and the women are in touch with us, good, we are lucky. If there's something wrong, then we are at the receiving end. So actually involving the OB-GYNs right from the beginning, from the time of your inception of your innovations to the implementations and for the best result, I think that is very important. With Vivek is there and Saeed is there. Innovation is okay. There's a simple, we're talking about violence against women. Dhira project, that was an advocacy which I started 10 years back. But that one small advocacy where bringing the most important point that the violence against women contributes to the maternal mortality rate. And not one organization, neither the funders, philanthropists, or any nobody individually can make a difference, but a mindset, I think that advocacy, Cash the Meng, the Dhira online school certification course. So these are very important for actually bringing about a change. Then the governance, measuring, we can't measure it right now. Probably 10 years, 15 years down the line, we'll be able to measure it. So that is the most important involvement, the point of contact.
Absolutely, absolutely, and really value your comment and the role that professional organizations like FOXI, FIGO, and others play, and how do we bring them into this public-private philanthropic partnership model and what that may look like. Oleg, you've been wanting to come in, and then I come to you, Rahul.
There's
next.
2 points to follow in this discussion. I think one important consideration is also academia, because it's when we talk about the innovation can come when there is a basis. And just where there was a lot of talk about the gap in the innovation for women's health specifically, but it also relates to the lack or kind of scarcity of base science to support the further innovation and clinical development, for example. So before you could develop a drug or develop some intervention, you need to understand certain mechanisms, and that is actually kind of a big gap. So that's one consideration, how to start thinking early enough and start building this foundation for the future innovation. The second point I would like to make is actually just going back to the potential role of WHO as a convener, is because when we talk about public-private partnerships, we increasingly so, and in my examples, I was trying to also to show it, it's a multi-stakeholder, multi-organizational, it's not a dialogue even, it's kind of a polylogue, if you wish, and it's actually very important to get this dialogue going, but also coordinate these efforts, because a lot of times some kind of bilateral initiatives are either conflicting or kind of stepping on each other's toes, leaving some other areas bare. And that's actually this coordination and somehow to like engaging people early in the decision-making process and discuss things together than to optimally deploy the resources and innovations. I think that's a big consideration. I don't have a good proposal for the solution, but I think this postpartum hemorrhage roadmap to 2030, which was championed by WHO, could continue, like at least being an example of being in this kind of coordinating role of WHO could be established, and that could be something which would be helping everybody on that road. Thank you.
Thank you, Oleg. And actually, you know, that is critical to recognize, and that goes to also what Sandeep was saying. We need to look from access to education to policy uptake. And the self-care example is a very useful one in that regard, because a lot of learning came from bottom up, from academia, from practitioners, on how we can provide care in the hands of people to reach those who are often hardest to reach. Rahul, you've been wanting to come in. Do introduce and go ahead.
Thank you, Rajat. So hi, I'm Rahul Bansal. I head the private sector partnership team for UNICEF in India. So the work which UNICEF does with philanthropists and businesses is managed by our team. And just wanted to unpack a little bit of, you know, the partnership bit which we were discussing a while back. If we look at the public, private, and philanthropists, all of them are doing things on their own and some amazing things. And sometimes the relationships are very transactional between them. And the intent is to really move away from those transactional relationships to partnerships. And partnership really is about understanding what are the aspirations of each of the three players and trying to see, can we sit around the table and have a fit among all the different partners, and do we complement each other? And sometimes we do and sometimes we don't. So we have private sector, we have philanthropists coming up with very different aspirations but working towards the same goal. And we do complement each other, and then we look for additionality. So 1 + 1, if not 11, should at least be 3. And then it becomes a partnership. Otherwise, as a PPP, we're all doing great work. So even in UNICEF, and we do a lot of work with businesses and philanthropists, we try to go into a space where we can start to be open and transparent, start to trust each other. And it's like a relationship. It starts on a very high note, and then you hit the bottom. But then if you're partners, you should be able to come around the table and start discussing the challenges and the exciting parts of your partnership. And we've seen partnerships where we have 4 secretaries, 4 CEOs, multilateral, sitting around the table and really co-creating solutions. And you see the work which they were doing individually completely translating into a true partnership which is developing. So, and then eventually you want to look at something which is scalable and sustainable, which can stay, because India has a lot of resources coming from public sector, private sector, philanthropists. So through your partnership, if you can build something which is catalyzed and at scale, then that partnership makes a lot of sense.
Thank you, Rahul. I need those remarks for my next speech, but thank you. Very, very helpful, because I think importantly, underscoring the value of partnership is not just what we can do ourselves, what we do together, and how we build that together as well. And over to you. Next. I'll come to you next.
Thank you so much. My name is Yamini Atmavilas. I work at an organization called Dasra. Dasra has been, I guess, for the last 15 years working on building multi-stakeholder collaboratives and doing a lot of the slog work of figuring out what it takes to line up incentives of extremely diverse actors onto a common goal. So I'm just going to maybe share 2 very quick points on what I understand that it takes, adding to the conversation going before. I think from our 10 to 19 adolescent collaborative work, we learned not just that this is long-term change, but how do you, I think, figuring out how do you take all actors along on this long-term change. And so some will join and drop off, so it's like that train, very cliched. Others will stay for the long haul, but you as the backbone organization that's like PMNCH, like all of us who are building those alliance sort of, we have to stay for the long haul. And there, I think philanthropic capital becomes extremely critical. But we haven't like yet figured out how private capital can also sort of stay. And I don't know if it's like payment platforms. How do you get, that matching sort of resourcing going? Because I think that's the third P that's extremely critical in terms of capital and financing. The second, I think, is structuring finance. And I think this is both on the side of philanthropy. I think we've spoken a lot about structuring private capital, but I think philanthropic capital similarly needs a lot of structuring, especially when you go away from the large institutional donors that do underwrite a lot of the innovation and the risk costs. There's a whole ecosystem of other kinds of philanthropists. So to your point about diversity of private sector, philanthropy is also extremely diverse, and it's more important now more than ever to have an extremely localized approach and bring in domestic philanthropy into the conversations for more than short-termism, more than CSR types of initiatives. And so I think there we have a lot of learning on what does it take, how do you engage and do this continuous engagement. Sometimes it's not financial at all, but there's a lot of legacy building and a lot of ambition when it comes to transformative, especially around healthcare. Education and healthcare remain the two biggest sectors that philanthropy invests in India, or domestic philanthropy invests in India. So I think a lot of learning around how do you create those platforms that are much more, or at least adapt maybe a sub-platform that's much more a safe space for learning to be built for philanthropists. And we have some insights on how they learn, right? And I'll just make two quick points. One is field. We can have hundreds of intermediaries in the room. We can all, I think, expertise and real deep understanding of what is the nature of the problem and what's the nature of the solution. So the more we are able to curate and more we're able to really bring these things closer to the philanthropist, the better you're likely to unlock some of these resourcing. And second, I think, is thinking through, but thinking through the evidence piece. I think there are many archetypes of philanthropists, right? And I've had them say, okay, if you can tell me, show me evidence that by working on addressing gender norms, I can save I can reduce maternal mortality by X, then I'm happy to invest in this. So being really ready with our suite of evidence, and also with whatever agenda we want to sort of push, if it's gender, if it's adolescence, just being really ready with that and connecting them to the big outcomes of interest. Just wanted to share that. I think one is the real discipline and diligence of nurturing these relationships and platforms, but also being agile and ready to engage different stakeholders.
Thank you. Thank you. No, absolutely. As we go to our final speaker for the day, it's important, I think, and one does not quite often recognizes the need for a more longitudinal approach and investment to some of these issues, because change, as we know, often happens very slowly and progressively, not in big bangs, although some of what is happening is rather showing the opposite of what I just said. Please, over to you.
Yes. Hi, I'm Harjot Khosa, and I'm from International Planned Parenthood Federation. So very happy to be here and like expanding basket of choice, Prachi, or talking about self-care, we really need to push for it more. And on Vivek's point of 4 Ps, I think there should be an S to that, and that's called solidarity. Now more than ever, what the world is going through post-January, we need more solidarity. And talking about, again, UHC, no UHC without sexual reproductive health rights and justice, I feel justice is something that with the current right-wing increase and our South Asia, sitting in South Asia, we are unable to tackle it. We are unable to get women to abortion clinics or to get a morning after pill, which is abortion is coming $200 in LMIC, private sector. So one just last request, because UHC, like this year theme is also financial protection, and a women or a community member is just one step away to poverty, getting into poverty, and that's a medical bill. So maybe we get into public health, very, very important. We need private sector, we need partnerships, but we need solidarity. We need women in all diversities to get what they should get without getting into poverty. So just last point and the request to all of you. Thank you.
Thank you for that as well. So I would like to come back to our initial speakers, and with one question which we did not give it to you in advance. If hearing what you just heard, what would be one key policy recommendation that you made that we go back today from, and we do try to work that? Prachi, maybe we can start with you and go that way, and end with Sandeep.
Sure. Thank you, Rajat. That's actually on my mind. There are 100 recommendations. But I think as a pharma company, I often feel we have to go through a lot of reluctance in terms of partnerships, and we have several barriers. UCPMP is a recent one where we can't reach patients, we can't reach doctors effectively. I think, but on the top of everything, Make in India policy needs to have a wider view because we need to bring innovations to India faster. Women should have access to the best medicines. India should consider how to get into the global supply chain rather than making end-to-end production in India. And that is, I think, the top recommendation for me.
That's a good question. No, one thing that I think is important as an understanding is from the policy level and all the way to the front line is the understanding that scale is super hard. You know, we all talk about partnerships, we all talk about scale, but it's the exception that this works, right? So scale is the exception, and I think before we sort of really understand what it takes to scale, and there I think, Rashmi, I like your picture of the mosaic, because it's not about this well-funded big, program with everything well-defined up front that necessarily will be the thing that ultimately scales and reaches the most. I think we all need the flexibility in the logic of the mosaic and how we bring different partners, different interventions together and connect the dots. So I think that's really, and also flexibility in how that is then funded. So I think also the time is over for the big, well-defined, globally funded projects.
Thank you. It's a it's a difficult question, but I think just to build on what Anna was saying, I think this acceleration of policy implementation is the critical piece, and actually we should be more explicit somehow as probably as a society, not as a private sector representative, in evaluating the costs of doing nothing or cost of not implementing, because when this morning when Professor Gudar was talking about this, that in Karnataka state it was taken kind of the inquiry into maternal death to finally start changing the policy and implementing these innovations which were available for the last 5 years, still not implemented, just like going into the implementation. And in the other states it's not yet even at that stage. So what is the cost of not doing the thing which is evident and already kind of proven and so on? So those are the considerations we should be more, maybe like the civil society should be more vocal about, and just push the bureaucracy into that. And but also on the flip side, there is somehow all of these constituencies, we need to make time for the dialogue, because what is difficult is just this find time to engage into those discussions, like find time for this kind of chaotic geometric figure table discussion. Because what I feel at the end of this discussion, that we did not have enough time to engage, right? And it's very frequently just I feel like that in different fora. So how do we engage in such a way that we have a meaningful and discussion, but also like practical follow through? Just what are the next steps and all the considerations? Thank you.
Thank you. Rajesh, please. Go ahead. We'd love to hear from you as well.
Okay. No, I can only bring in the perspective because it's the real challenges are being faced by my friends out there who have been trying their best to bring some innovations. But I think coming from and working closely with the government, what we realize is that probably those clarity on accountability, you know, your measurement frameworks, what is role clarity when you're dealing with the private sector. Like Vivek brought a good example of, it might be, oh sorry, my friend from UNICEF brought that it might not be 1 plus 1 11, but you have 1 to 1 3 at least. So getting that clarity from the government is going to be very important as we move along. And this is where I feel, when you don't have clarity, what are the performance metrics, how is going to be the payment method, what is going to be the role, what scale are you looking forward to? Now, it's not always the case that I would say, that it has to be at scale. And honestly, Anna, at scale is something which everyone is struggling to understand how to bring things to scale. And when you bring in the concept of effective coverage with quality, that's even more challenging. So moving forward, I would just say, let's be clear about your expectations. And this is where I think as WHO, that we look forward to playing that role of bringing more clarity in the processes, helping them things move towards a more streamlined process, and making sure that these models which have been created, the contextualized models that we're building, are brought to scale. And the learnings, it might be different learnings in another country, but that is what the regional, sorry, just one more minute, the regional PHC forum, just to bring about, is a fantastic forum that has been recently established. It has close to, I think, about 100 partners, all the 4 Ps and more than that. So this is a PHC forum. Now it's bringing innovations, it's bringing evidence, it's bringing sharing of best practices. Challenges are openly discussed. Similarly, in our area, in my field, we had the community of practice for point of care quality improvement. That was an innovation from the region, which has now been scaled as a global public health good. So we are doing this with professional associations, with private players, with philanthropies, all chipping in. But then I think to bring it to scale would require a slightly different process, looking into developing evidence-based guidelines, making sure the norms processes, but then translating those norms into countries level is where the real work will be. And that is where I look forward.
Yeah, I think a lot has already been covered. So I'll restrict my points to the self-care industry and India specifically. And if my points sound like a bit of a rant, please stop me immediately. So I think the short rant, okay. Rant is allowed, okay. So I think one of the biggest challenges that we have in our country is the lack of primary health resources. Okay, we all are aware of how many doctors we have, of what 1,500 people, 2,000 people, etc. And in this kind of a context, I think our country needs to give the self-care industry, okay, and the preventive health industry its due. Just FYI, OTC industry or self-care industry is not even regarded as a separate industry in India, which is different from most of the other countries in the world. Now, what that does is that it dramatically reduces access to self-care products or preventive health products for a vast majority of the Indians, most of whom live in the rural parts of the country, which means that 70% of the Indians or 70% of the people in this country don't have an access to preventive health. And while we talk about all these measures around infant mortality, maternal mortality, which are really critical, but the fact, what is the root of this? Is there a way to get it nipped in the bud so that it doesn't go there? We've had 60% deficiency. We've had anemia in 60% of the women in this country for almost 50 years, right? And the government has been running these programs for more than 50 years, I think. And yet the anemia has remained the same. So I think one is giving preventive health the kind of measure or the kind of respect that it optimizes your primary health efforts. So preventive health is exactly that. It will help you to optimize your primary health resources. I mean, this is the only country in the world where sitting in this room, you can get an iPhone in 10 minutes. But if you want a headache medicine, you can't get it. You'll have to go there, right? So what is the purpose of technology? What is the purpose of channel access? if you're not able to get healthcare resources in the hands of your consumers. Now, this is where it's getting into a rant, so I just stop here now. But that's what I wanted to say.
Thank you. I think one thing that I always see is that we end up reinventing the wheel a lot of times. There is no one single place where I can go back and look at what were these models that were applied in which parts of the world or whatever. I mean, I end up reinventing the wheel and I feel that I'm the first one to have done that. And then somebody says, oh, 20 years back we had done this. And and what I actually feel is that there needs to be a space where which actually is able to record, where people are able to go refer to, take the best practices, apply it, and things like that. Like, a lot of these PPPs, excellent results, just die a painful death, never getting scaled up. Whereas somebody who wants to scale it up has nothing to look at to scale it up, and they end up doing a pilot. And I think there needs to be one common space. I mean, it could be through World Health Organization, WHS. Somebody needs to take this up and actually, invite people to put their PPP models, their results, and this and that, and everything out there for people to really go up to and refer to. Right now, the one place that we can go to is Google.
Thank you. Thank you for that, Rashmi, and thank you all for that very much. And thank you for this. We do have a very overflowing room, and I think the next session people are getting started. So yes, please go ahead.
So just one aspect that I wanted to bring into the room, and as we go out for lunch, is we need to start looking at innovative financing mechanisms.
Correct.
That's something which is untapped, and it has significant resources which we can draw from the private sector. So some of the sentiments that we came up here with trust and solidarity, I think a lot of it can be addressed if you're looking at outcome-based funding or addressing risk. So just wanted to bring that.
No, thank you. Thank you. And as I think going back to what Oleg said, it always feels like we are short of time for these conversations. But actually, as we just recognize, while it does seem like that this is a conversation that may have just started, it is a conversation that has been going on for a very long time. The question is how we sustain the learnings, how we share the learnings, and how do we build on these models towards a more successful pathway for delivering for women, children, and adolescents everywhere. Thank you for joining us. Thank you for bearing with this rather clunky format, and hope you have a very good conference. Thank you.
फर्स्ट स्लाइड कर दीजिए. हाँ, ताकि ये नज़र ना आए, ये आ जाए, ये और मैं. अच्छा, थोड़ा सा पीछे चले जाइए. मेरा पीछे बैकग्राउंड और ये. थैंक यू. थैंक यू.
So, very good afternoon to everyone. I think we can begin, though we are before time. But seeing that everybody is here and respecting the time. So, I'm Sumit Malhotra, and I work as Professor of Community Medicine at All India Institute of Medical Sciences, New Delhi. And this is a workshop which is one of the series of workshops that are planned under the Cochrane India Network group. So the Cochrane India Network is a group of 9 institutes. AIIMS Delhi is one of the is an affiliate center. And one of the mandates that we have is to build the capacity of researchers, young people, scientists in undertaking systematic reviews and practicing evidence-based medicine. And with that mission, we are here in front of you. So we have whole team from All India Institute of Medical Sciences. I also welcome all of them and also welcome all of you for this particular workshop. I want to introduce also Professor Vijay Prakash Mathur. So sir is professor at Center for Dental Education and Research. Sir actually leads clinical research unit at All India Institute of Medical Sciences, New Delhi, and also the Cochrane Affiliate Center at AIIMS Delhi. And apart from dentistry and public health aspects related to dentistry, he is one of the very active researcher and also practitioner of evidence-based medicine. So I'll hand over to you. Sir is chairing this particular session, and then we'll have the other speakers also. I'll first hand over to you, and then we'll proceed with the session, sir, being you the chair.
Thank you very much, Dr. Sumit. Whatever is spoken is actually we are all students of science and we are learning every day. Government puts us with some responsibility to us, and we look after that responsibility. Otherwise, we all are learning every day, and I'm sure I'll be able to learn today something more. I may be from one generation before you people, but I still learn from you all. So we have a quick round of introduction of everyone, and then we go ahead with the presentations.
So I'm Professor Himanshu Prabhakar. My background is neuroanesthesia and neurocritical care. And I've been associated with Cochrane for several years, I should say. And yes, this is my area of interest. And that's why I'm part of the clinical research unit in AIIMS. And we've been doing these workshops. So it's a pleasure to be here and have you as the audience. It's good to see the full house. And I'm sure you all are from different backgrounds and specialities. So I really hope you make the best use of this, and we can always interact even after the workshop. Thank you.
Good afternoon, everyone. I am Dr. Pradeep, working as scientist epidemiology in clinical research unit from AIIMS New Delhi.
Good afternoon. So this is Sachit Anand, and I am assistant professor in pediatric surgery at AIIMS New Delhi. Thank you.
Good afternoon, I'm Dr. Kunal Dhingra. I'm additional professor in Center for Dental Education and Research at AIIMS New Delhi. And it is my pleasure to be here to give lecture in front of you, and I welcome you all to this session. Thank you.
Wasting much time, let's come back to the session exactly. The session is titled as How to Write a Protocol for a Systematic Review. For writing a protocol, actually 1.5 hours, we'll be able to give you just an overview of what it is. But for this, normally we have a 3 days workshop. So those who are interested, they can also attend some online courses, and some of you may be able to attend some of the training programs which we conduct in AIIMS. Very recently, Dr. Kunal Dhingra has also organized one such workshop. So we keep organizing under different banners, different headings, sometimes ICMR funded, sometimes AIIMS funded, sometimes. But it keeps on happening, so keep an eye on AIIMS website for activities if you want to actually do a full workshop. So that was about me. We all know about quality of evidence. I'm not repeating anything. All of you are very much aware of it. But there are several types of reviews in the market. So when we were studying, when I did my post-graduation at that point of time, the systematic reviews were not exactly the same way as it is today. That time, because of the limitation of resources, you imagine we used to write, the search was made in my institute's library, National Medical Library, and if we had some contacts in some other institutions, then we used to write, mostly it used to be a PGI Chandigarh, JIPMER, and that time the emerging institute was SGPGI. So we used to have our friends there. We used to do the search, keyword based, and we used to do everything manually. In that manual, you can understand how we would miss few things, and sometimes the bias would come. So things in the search bias and everything will be covered very soon. But there were many, many terms being used at that point of time. And when I was undergraduate, for us, a systematic review was few sentences spoken by a teacher, because they will collect all the information and then they will teach us. So narrative review, mapping review, there are so many jargons of words are there. But at the bottom of it, as evidence medicine, we would also always like to go as systematic. Now, systematic way of doing it, but you may make it an umbrella, or you may make it in a meta-analysis, or you may make it a evidence mapping, whichever way you want to do. But it is basically systematic review which is important, the methodology to learn to do systematic review and develop the protocol which is important. Now, if you go to the definition of systematic review, there are so many definitions, and this is the most accepted definition which is given by the BMC Medical Research Technology. They revised their definition in 2018. Although this is very, very technical definition, but I did not like this one. As AI is making changes in lives, making it simpler, I use this definition, which is AI generated. Yes, I gave some command to AI, and only few days back. So systematic review is crucial in medical sciences because they provide comprehensive and reliable synthesis of existing research. It does not give you anything new. Helping healthcare professionals for us to take clinical decisions or laboratory decisions, whatever we are trying to do, and also to help the policymaker and government in making informed decisions. And it offers a structured approach to summarizing evidence, reducing bias, and identifying gaps in knowledge. The last thing is for the researchers. If you do not know the gap, how will you do the next level? So with this definition, now I'm not going into the details of what are the steps in protocol development, because everything will be covered. The purpose of developing a protocol and registering it is mainly these four things. One is ensuring transparency and reproducibility. If with the same data, same time, somebody else does the same review, they should also be able to get the same results. And it brings transparency in your work, how you have planned, so that tomorrow you do not get biased. You got one particular type of studies, only 4, and then you decide, no, I increase my scope and don't do it. So that is why the protocol is being registered. Reduces your personal biases, reduces the bias of your team, and sometimes of your supervisor as well. It helps in improving the quality of evidence, because as soon as you go for registering, you will come to know what others have done already, and sometimes a very extensive database like Cochrane, they would also approve it. So it helps in improving the quality. And finally, at the bottom of it is what is required by all of us is the facilitating the evidence-based practice, even for doing a systematic review, because you are writing a protocol and you are going to follow that up, follow the same steps. Now the question comes is, I do my systematic review, I sit in my institute, I do everything, and I use it for my personal information. Is that correct? No, that is not correct. If you do that, there is a likelihood that you remain biased. It is not published. People do not come to know, and you have done a lot of hard work. Why not share it with the rest of the science? I use this jargon always, that you and me are not important. What is important in this world is the progress of science, the progress of mankind is important. Something which was first time coined by Newton or Archimedes or whosoever we name it, over a period of time everybody is going to forget them because we all are finally human beings. But what we do not forget is the principles of science, physics, maths, biology, whatever we have learned, that we are not going to forget. So names are not important. The methods by which you do, the work which you do for the progress of science is important. So to promote transparency in research, it is important to register, to reduce the biases which may come little later, to prevent duplication. That is also one of the bigger problem. 30 years back, it was very easy for any other medical college in this country. If they are searching for a thesis topic, the guide used to send the student to AIIMS library. They used to come and see the thesis index. They used to copy that and they used to do it. And nobody was asking them. But today there's indexing. Today there's a listing of everything. So duplication is not being done. So preventing duplication. So researchers will progress further. If somebody has done, X person has done a work up to this level, the next person will do X plus 1. We are not repeating. So as a student of science, we keep on progressing. So definition is that by publicly documenting the review methods and objectives, before it is conducted, researchers can avoid unintended duplication and ensure the review findings which are based on predefined protocol, enhancing the reliability and validity of your review. So this is the purpose for which you register. There are more than 8 places where you can register, but most common is Protocol and Cochrane, which will come subsequently. So with that, I'm going to give you my team to conduct this program. First will be Dr. Sumit Malhotra, then Dr. Pradeep, then Dr. Himanshu, Dr. Sachit, and Dr. Kunal. And at the end, we will be taking up your questions. With that, I invite Dr. Sumit. Baton is yours now.
Okay, thank you, sir. So as you know, we have multiple things that are there as part of the session. This is a very brief session, so we'll try to cover the major areas that entail writing a protocol and also introducing you to the several of the segments that are a part of systematic review. So how many of you have undertaken a systematic review? Raise your hand so that we know at least. Okay, so there are majority that have not, and therefore they are here. So what makes this review a different review than the other narrative reviews or the traditional reviews? Just 1 or 2 pointers. And I want you to please say something.
So for a systematic review, we have a search strategy and we try to find out if that search strategy is already applied somewhere or used somewhere so that there is no duplicacy.
Okay, so there is a search strategy and there is a transparent search strategy so that in case anyone wants to replicate it, should basically yield the same results. Any other important part and parcel of this review? Okay, so there is a PICO statement and we'll come to that, a little just a while from now. Any other thing? Any other important characteristic of systematic reviews? Okay, so there is a step-by-step methodology.
Involvement of multiple investigator to narrow down the.
Okay, it's a teamwork. It's a team science. You'll require, a team of people in order to do and undertake this task, which is kind of requires a lot of time also and energy. Any other thing? You want to say something? Yes. Yes, that's a very, very important thing. So once you have the search output, once you have the studies, you want to appraise it and you want to do a quality assessment. So you wanted to add?
Some new and inventive step also important. New and inventive steps.
Okay, so some steps are also there. Okay, fine. So I think yes. So it is very unique and it has a merit in place. So it has a very transparent search methodology. There are a number of steps that are there, and we also critically appraise for quality, and the evidence that is generated needs to be trusted. So you can have a trusted evidence at the end, and that is what you are looking for at the end of the systematic review when you carry out an important exercise. Now, there are plenty of systematic reviews that exist. There are intervention reviews, there are observational reviews, there are diagnostic reviews, within the systematic reviews also. So it's a very broad domain, and currently a very, very important, area that's being practiced for, development of guidelines and also, doing an evidence-based practice. Now, so that, people who are there can walk in. Yeah, we're sorry that this space is, I don't know whether they'll be able to, but yes, the organizers, if they can facilitate this process, so that, more people can be seated and accommodated. But we'll continue, right? Okay. So, any particular, research study, and this is also a kind of a research piece, will have a methodology. And methodology is a very, very strong aspect of doing any process, particularly when we want this to be trusted at the end. Okay, so this also follows a methodology, and to do any research work, even a kind of systematic review, you require something at the beginning. What is that? Research question. Okay, so question is the king always, right? So it plays a very important role. So it's a king. So any review will start with what is the question that you are trying to address, right? So this, what I'm going to talk for 1 or 2 minutes is talking about, the question. Now, the steps actually, if you see overall in a review, and we are going to cover one by one, each one of us who is here, talking about how do we search studies, what are the principles that govern it. Then, once we have the study, how do we extract data, and what kind of things we have to keep in mind while we extract the data. And then we talked about the quality appraisal, and then, some statistics, analysis to make some sense out of, all that we have reviewed, so as to generate a synthesized, finished summary output. And that's how we get the evidence, right? So we start with protocol, we start with title, but essentially a question. And there lies the PICO that, one of our colleagues mentioned about, that we have something called as PICO, and that's very, very important. Now, what that stands for is, the P is the population or the study participants that you are going to be, involving in your review. So in an intervention study, it could be, you want to study something related to elderly, or it's adult population, it's pregnant women, whatsoever, right? If it's an interventional review, you will have an intervention and a comparator. So you want to compare, one group with the another. And then what's the outcome? So O stands for outcome. Now this is an intervention PICO that you will be having. So always we talk about PICOS in a systematic review, and the S stands for the study designs that you are going to include. So are you going to include RCTs? Are you going to include quasi-experimental studies if it's an intervention? If it's an observational review, you will include, case control, cohort, cross-sectional studies. So different epidemiological study designs. So you can also have I replaced as exposure. So when you have the observational studies, you may think whether to keep a narrow question or a broad question. So a narrow question could be that I am looking a very particular segment of, or a subgroup of people confined, a particular type of disease, and I'm just finding out studies pertaining to that. So that's a narrow. A broad could be maybe, all age groups, all diseases, whatever that disease is, but that also will have a variety of things. So broad versus narrow, you need to decide. Each has its own pros and cons. It will, determine the generalizability of the findings and also the scope of work. The more broad questions, you will have to dig more literature, and therefore there'll be more time consuming, right? So you need to know what's your population, who is my question focused on, what is the intervention that you are interested in, do you have a comparator group, so one intervention versus the another intervention, what are you going to examine, what outcomes that you are looking at, and then what study designs you are going to include. Now you can't actually have RCTs and cross-sectional studies combined together. Of course, there'll be different settings and questions that will be answered, but even case control and cohort should not be combined. Cross-sectional should not be combined with the case control or cohort. They should be put as separate pieces of evidence. We have something other than this in public health context that's called as SPICE, and that SPICE stands for S is setting, so maybe what context you're talking about. Perspectives, so this is qualitative, particularly, you know, what perspectives are you talking about, whose perspectives are you talking about, and then you have intervention, comparator, and evaluator. So think about these key important elements before you really embark on a particular review, you know, thing. Now, because this is a review, you will be studying the literature that is already existing, published gray literature. You will be extracting the data, so you'll have to do, before reaching to the data, you'll have to see what all studies qualify to be included in your review. So you will have eligibility criteria, some inclusion and exclusion criteria that you will have to think through, and that's how you will be including your studies. You know, after, you know, having some search strategy in place and applying those search strategy, you know, in a particular search engine. So with that, we move on, you know, how to do this search and how to have a good output. I hand over to Dr. Pradeep in order to talk about that. Now, I'll urge you, if you have any questions, please keep noting down. We'll continue with the flow, but we'll try to address the questions, you know, towards the end. So if there's any question, please note it down. We'll visit that.
Thank you, sir. So, for doing a literature search, so there are basically how to do a systematic review. There are 12 key steps. Okay, you have to mention 12 key, you have to keep in mind that there are 12 steps, you have to follow that. First, you have to assemble a team. You have to make a team. Then you have to develop a research question. Then you have to set the inclusion and exclusion criteria for your systematic review. Then you have to plan a protocol, well-designed protocol you have to plan. Then you have fifth step is to conduct a literature search. And where to search, you have to define also which database you have to search. That is the sixth step. Seventh, document search, how you are going to search for the grade literature and other additional references. Eighth step is to manage your results, how you will manage. You have to you have to take the help of softwares, citation manager software, Jotero, EndNote, how you will manage your literature search. Okay, so there are numerous softwares, most commonly used are Jotero and Notes. Okay, ninth step is to screen your publication, whether these publications are eligible or not eligible. 10th, you have to make the quality assessment of the included studies. You have to evaluate whether the quality of the included studies are good, poor, or not appropriate to your review. 11th step is to extract the data and analyze it, and the last step is to write your manuscript and publish it. So how to proceed? So my talk for today is to how to conduct a search. So conduct a search. So there are databases. Most commonly databases in the medical literature is Medline or PubMed. Second is Cochrane Library. Next is Embase, APA, American Physiological Association, Sinhal, MCare. These are the important databases that are used for doing a literature search. Okay. So how to search? Search has the three Boolean logics. One is and, second is or, third is not. And will combine depression and anxiety. They will combine and will combine both the terms. Okay. Depression or anxiety. So either depression is available or anxiety, they will give you the all search. Okay, if you are using the or Boolean logics. Not will use depression, not anxiety. They will look for the depression keyword, not for the anxiety. So we have to keep in mind which Boolean logics you have to apply during your literature search. There are the three Boolean logics, that is and, or, not. Okay. So searching tips, there are three searching remarks. One is truncation mark. You can see here, if you put star mark in the psychol word, it will give search for the psychology, psychological, psychologist. So that is called as wildcard. If you put the streak mark, it will find out all the possible key terms that is related to your search strategy. Okay. Second is your wildcards. You suppose there is the American or British language. Okay. So there is the difference in the spelling. you don't know whether there is the spelling of Z or S. So you can use question mark, hash sign or dollar sign. You can just, for example, immunization. Immunization, you can keep this question mark, it will search for the immunization as well as Z or S. Okay, it will search. Next is the phrase searching. Phrase searching is that suppose you want to search for evidence-based medicine. So you put inverted comma from the starting. You can see here evidence-based medicine. So we have put it the inverted comma in from the beginning of the text evidence and the end word medicine. So it will search whole word evidence-based medicine. Otherwise it will give you the result evidence-based and medicine. You will get more number of literature. Okay, if you are putting the inverted comma in all the words, it will treat as a single word. Okay. So next is the free search filters. You can apply filters also. Suppose you want to look for the literature that is published in the last 10 years. So you can filter your search strategy by using the publication years. So you can fix the timeline also. You can look for the last 10 years, last 15 years. Suppose you want to search for the human literature, the studies which are conducted in human subjects. So you can apply filter subject to humans. Study type also, study design. Suppose you want to look for only randomized control trial. You can select the studies which are only randomized control trial or cohort study or cross-sectional study. So during this search timeline or during the searching process, you can apply these filters that will make your job more easier. Okay. So next term is MASS terminology. MASS stands for medical subject heading. Suppose you want to search for the diabetes. So you will get more number of hits. So diabetes is a only keyword. So you want to look for the MASS term, medical subject heading. So medical subject heading for diabetes is diabetic insipidus or mellitus. So that will be the medical subject heading. So you have to apply that MASS terms also during the search of your literature. So that will give you more number of hits. Okay. So for example, hypertension. Hypertension is the MASS term. And high blood pressure. High blood pressure is a key terms. Okay. That is the synonyms of hypertension. So you have to, during this searching, you have to put your search with the key terms as well as MASS terminology. Okay. For example, vitamin B12. So B12 deficiency is a keyword. Cobalamin deficiency is a keyword. But MASS term for the B12 deficiency is vitamin B12 deficiency. So you have to define both the terminology. You have to keep maximum number of keywords during your key search. Okay. So base search strategy you have to combine using the MASS terms and key terms. Okay. For example, anemia and pregnancy. Anemia is the MASS term. Okay. And pregnancy is also MASS terms. You have to also take for the synonyms also. For example, in PubMed you can look for the MASS database. You can find out the MASS terms, which terms can be a MASS term. So you can go to PubMed and you can look for the MASS database also. So search string should be, first you design a question, then you have to break into 4 parts. Okay. So you have to break your questions in 4 parts in the form of PICO as Dr. Sumit sir suggested you. So population, intervention, comparator and outcome. So in population you have to use for all the synonyms and MASS terms, you have to use OR Boolean logics. Okay. Combined with the AND for the intervention and all the types of synonyms of intervention or MASS terms, you have to use OR. Okay. And for comparison, you have to use OR, and you can connect all the PICO format with the AND Boolean logics. For example, here you can see here MASS terms is pregnancy and anemia. So what is it? Here is the population is the pregnant women. Intervention is report that is associated with anemia. Okay. Intervention outcome is anemia in pregnancy occurs. So you can drop your research portion is 4 different Pico format for making your search strategy. Okay. So in search strategy, you have to combine mass terms and keywords for all the Pico formats. Okay. Then you can get the maximum number of hits. For example, you search for search 1 for the P, search 2 for I, search 3 for comparator, search 4 for outcome. So you can combine based on the different number of combination, you can combine your all results and you can get, by combination you can get the pool results. Okay. So there are Cochrane library. Here is the example. You can see that I have searched oral anticoagulants, anticoagulants. So I have used the OR Boolean logics because they are the synonyms for the oral anticoagulants, anticoagulants, OAC. So for the synonyms word, you have to use OR Boolean logics. And for the comparison with different intervention group, you have to combine with the AND Boolean logics. Okay. So Cochrane library, you can search in the, you can go to the Cochrane library website and you can go to the search manager and you can define your search terms. Okay. In Ambase also, you can define your using the AND or Boolean logics. Scopus, there is a similar type of search strategy. In Web of Science, you can also apply filter and you can apply the date range of publications and all the other filters also there. So challenges in doing systematic review for doing systematic review, not getting the full text. So how you can get the full text? You can approach to the authors, okay, or you can have the account with the ResearchGate and you can request to the authors. They generally provide you in your personal emails. So you can get through the author request also. Okay. And the article which have been published before 1st January 2021, you can go to the Sci-Hub site and you can paste your DOI required. So you can get the PDF from that link also. Next, the simpler method, you can go to the Google search engine and you can just type your article title followed by .pdf and search it. Wherever the PDF is there, then you can get the full text of that article. Okay. So once you search in all the databases, you have to get the files. So files may be in the format of RIS format, BibTeX format, XML format, and BIB format. These formats are acceptable in all the citation manager softwares. So EndNote, Zotero, these all are the citation manager softwares. You can export your references identified through the databases and you can export to that reference manager for your further screening in your systematic review. Okay. So how you can save these RIS files? You have to go to PubMed and you can just you have to type here, you have to select the send to and you have to select the button collections or citation manager. Okay. Then you can get this type of format in the PubMed and you will get the format to save that file, that all the literature you have conducted search in the PubMed. Similarly, in the Ambase also, you will get the format to export in the format of RIS, CSV, plain text, PDF also, MS Excel also, you can export your search findings. Okay. Then how you have to screen this identified literature. So there are now there are softwares that are based on the AI based. Okay. So these are the softwares that is most commonly used softwares are Covidence and Rayon. These softwares are used to detect the duplicates that have been identified through the different databases. So once you export the reference file to that softwares, any of the softwares, they can detect the duplicates and they can identify the number of duplicates, and further you can screen the title and abstract for doing the full text review. Okay. So after you screen all the steps, then this is called as Prisma flow diagram. You have to explain, you have to give in your systematic review that these number of articles, number of databases, how many databases you have searched, and how many articles you have identified through this search, and how many were eligible. So this is the standard format for doing a systematic review and presenting the Prisma flow diagram. So this was my last slide. So thank you, and we will take the question in the last. Okay.
Yeah, so thank you, Dr. Pradeep. So now, we have, is there any burning question at this stage to Dr. Pradeep, or you want us to go ahead?
I just want to know that R and when you told that when you had to be used.
What?
The last 4 slides you told that the R and research gave,
Research.
Okay. For full text PDF.
No, not full stuff.
Rayan and Covidence.
Boolean, yes.
Boolean. Okay, Boolean. If you have just you define your research question, okay, then you have to split your research question in the PICO format. What is your population, and what is your intervention, what is your comparison, and what is your outcome. For P, suppose you are using the different synonyms of the population, pregnant women, pregnancy, or women with children. So you can use, for the synonyms, you can use or, okay, synonyms. And for the connecting with the population, intervention, comparison, and outcome, you have to use and Boolean logics. Okay, so that is the difference.
Okay, I think just one question only, and then we'll end the discussion. Yes.
Okay. Yes. Yes. For getting the more number of hits, you can apply to all fields also. That is recommended. Yes. Thank you.
Okay, so now that you have applied the search, you have to now extract the data, and you also have some important things that you have to keep in mind. So to now cover that, we have Professor Himanshu Prabhakar. Dr. Himanshu is Professor of Neuroanesthesiology and Critical Care at AIIMS. So over to you, Dr. Himanshu.
Thank you, Dr. Sumit. So now let's move on to another very important aspect of a systematic review, and that is data extraction. Right? So you formulated your title, you prepared your search strategies, you got results, and you've identified your studies. Now what next? So you have to extract data that you are looking for, or for which you are preparing that systematic review. Right? So this data, for all the systematic reviews, it has to be very accurate. Whatever you're extracting, it has to be very accurate, it has to be complete, and then it should be accessible. Right? Now, whatever method you're using for data extraction, that has to be transparent. So the reader should know how you have extracted the data. Everything should be there and written down. Right? That's very important. I'll tell you how we do that. But at this stage, just remember that whatever information you can collect from a study, that has to be done, and that is ultimately your data. Right? So what data to be collected now? It's like we keep saying, collect data from that study. So what is that data? Now, in simple terms, if I have to say, whatever you are collecting from the study becomes your data, right? Starting from the author of the article, the journal in which it was published, then what outcomes that those authors were giving, which country that study was conducted, all that becomes data for you, right? Now, Cochrane gives you a checklist of what all things should be there when you are planning your data extraction forms. So you start with information of the study first, and before that, whoever is extracting the data, his or her information should be there right on the top. So today is 25th April, Prabhakar H is collecting the data. Everything has to be started from there, right? So whoever is collecting that, extracting the data, it starts from there. And then as I said, name of the data extractor is there, and then you identify which study it is at a later stage, whether it's an RCT or whether it's an observational study. All that has to be noted down. And then whether this particular study is falling in your eligibility criteria or not. So eligibility criteria is decided at the stage of protocol. So when you plan your protocol, you will
write down what are the inclusion criteria, what are the exclusion criteria, right? So if that particular study, because your search results will give you thousands of studies, right? But not all are included. So finally, you select the included ones. Now from there also, once you start reading those studies, you try to identify whether it's really falling into my criteria, my inclusion criteria. If yes, then you proceed further. But if no, then you stop over there and that study is removed, right? So even that has to be written. Then what study methods were used in this particular study that you are analyzing, or from where you are extracting your data. That has to be done, whether it's a parallel study or crossover study. Everything has to be noted down in that data extraction form. Now, these authors who have conducted the study, what were the dates of that particular study? From which day to which date they were collecting the data? Whether these authors generated a randomized sequence or not, because since we are talking about Cochrane and these are interventional protocols that we are trying to develop, it is important that we take only the RCTs, right? But later on you'll understand that now we can do or prepare systematic reviews without RCTs also. For non-randomized trials also we can include. But we'll go with the basic ones. So whether random sequence was properly generated, whether there was concealing, whether there was blinding, everything has to be. So the most important part of any study that you are enrolling in your systematic review is the methodology, right? You get everything in that methodology, and that basically that methodology has to be extracted, right? Later on, of course, the results of that study, whatever the authors were getting. And then you try to identify whether there was bias in the study, whether there was any source of funding, right? So any study which is funded, it's a big source of bias. So everything has to be noted. So right till the acknowledgement, when you are extracting data, right till the acknowledgement you should read and try to extract as much data as possible. Now, again, the participants, whether the participants are there of your interest in that particular study. So participants, what interventions they are doing, whether they are there of your interest or not, that has to be noted. The outcomes. Now, there is a slight change. Earlier it used to be like, if your outcome of interest is there in the particular study, you include it. Otherwise, you can remove it. But now it has changed. Whether your outcome of interest is there or not in that particular study, it has to be considered as an included study, right? So even if your outcomes of interest are not there, but that study would be there, so that would come in your systematic review. Of course, you don't have the data. Suppose it's mortality, for instance. That mortality data is not there in the study. Doesn't matter. It will not go in the meta-analysis, but yes, in a systematic review, that study should be there. So that's how you have to systematically analyze everything, extract the results, and any miscellaneous information that you can see. As I said, the source of funding and any sponsorship, all that has to be noted. And then at the end of the data extraction form, you should keep a column. Suppose you want to do something about this. You have analyzed the whole extracted data. Now, do you want to do anything more? So you might say, yes, I wanted to find out what was the mortality in that particular study, but the authors are not reporting. So there you can write to contact the authors and find out. So you can always contact. So it's basically putting down everything that you're planning to do. So just in case you don't forget, at the end of the form, you just write contact the authors for such information, right? So that everything is documented. Now, so far you know what all data to collect and how to collect. But how do you document it, or how do you keep it? So it could be as simple as putting it in a paper, on a paper, and just noting it down. That could be one way. Then the second way could be an electronic format. So the electronic format could be Google Forms you can prepare and store your data. But now very popular is Covidence. So through Covidence, which also supported by Cochrane, we do the systematic reviews using Covidence. So that is another source. So everything is there on Covidence, and it's online. And you'll understand why it is important to have data collection or these forms, because every time one should not go back to the original study and start searching. So if there is any query, you don't have to go back to that article, right? So everything should be there in the data extraction form, so that each time you don't go, keep jumping here and there. So that's very important. And then whatever, as I said, transparency has to be maintained. So whatever data has been extracted, it should be known to everyone that this is the data that you have extracted for the study. Now, it is always said that how to design this data extraction form, right? So earlier, we used to do it on paper, of course, and everything used to note it down. But now you have Covidence, which is online. So online also you can create your data extraction forms. And as I said, every information that you can think of, you should write it and put it in that data extraction form. And it's always good because you are preparing a systematic review with a team. It's not a 1 or 2 person's job. So the entire team should be involved in preparing the data extraction form. Now, the story doesn't end there. When the data extraction has been formed, people should know how to extract data, right? So it is always good to do a pilot. Do a piloting and see within the team and see whether you are really understanding what questions you have put and what data you are extracting. Is it accurate or not? So that's very important. Piloting should always be done. So please remember, most of the things now we are so much used to using computers and everything is on electronic format, but this is manual process. So data extraction is a tedious job. It is a manual process. Although there are now softwares which can help you extract data, but please don't use it. Unless it's a figure or a graph. So you have softwares for that, that you can directly extract data from the figures and graphs. But even then, try to reach out to the authors and tell them, you prepared this graph, but I can't see the numbers or something is missing over there. Can you give me the exact number? So it's always good to collect numbers from the authors directly. Now coming to another very important part, that's the risk of bias assessment. So once you have extracted the data, that means you have included the study also. Now it's very important to analyze how the study is. Is this study a good study or a high-risk study? I won't say a bad study, but yes, it could be a high-risk study. So since we are generating evidence, we need to include studies which are all low-risk studies. So there is no risk of bias in those studies. And for that, you go through the methodology, as I said earlier. You see the methodology, how the study has been conducted, how the randomization has been done, and all these steps. So there are domains. Again, everything is there on the software. So Cochrane recommends the use of RevMan. So RevMan is a software on which you can prepare your systematic reviews. And these are the domains, the 5 domains. Now you must be wondering, what is risk of bias 2? So earlier there were 5 domains definitely, earlier also, but the answers, the options that you were given were only 3. So suppose it was asked, you will be asked that whether randomization has been done or not. So either you would say yes or no, or sometimes you are not clear about it. So you have to click on that unclear part. So there were only 3 options. Now they have introduced 5. So we don't have any sample paper here, but if you read any research paper, read the methodology and see what methods they have given for randomization. If it is a good one, computer generated, those kind of things, even flipping of coin is a good method. So if they have done that, you put it in a low risk. It is a good one. So you will be asked, is the randomization done? You will say yes. But if you're not sure, you may say probably no, probably yes. It's up to you. It's entirely up to you. Then sometimes there is no information at all, so you can click on no information. So that's the way we go about dealing with the risk of bias domains which are there on the software. And for everything, there is you'll be given a prompt, and you can read that prompt and answer, take the decision and make an answer. So and overall you will get a risk of bias for that particular study, which could be a low risk study, or it could raise some concerns, or it could be a high risk study. Now why all this is important? Because at the end of the systematic review and meta-analysis, you will give some conclusion, right? So suppose the conclusion is a positive one, like it is a favoring a particular drug, but then the reader should be very cautious. You have to tell the reader, please read my results very carefully. I am saying this drug is supporting this, the results are supporting this particular drug, but these results come from high risk studies, right? So the idea is take that information with a pinch of salt, right? It's not that if the authors are saying this is a good drug, just take my words for it. No, this information is coming from higher studies. So be very careful. That's the whole idea. So that's again the transparency lies. So whatever you're preparing, it's being shown there. So that's how you used to get, earlier we used to get these kind of graphs. So the green one is definitely a low risk, red one is high risk, and the yellow is unclear, we don't know. So if you see the Gemma 1997 on the right side, that study is a very good study, a low risk study. It has all green. But the rest, they are not so good studies, right? So this gives you an idea about that. Now, just a little bit of publication bias, although we have this in the later talks also. Cochrane says that if you have more than 10 studies included in your systematic review, you should create a funnel plot, right? So these funnel plots are created to know whether there was publication bias or not. So now there are all sorts of bias. I really hope you go and read about them. So whether there is publication bias or not, you can come to know through the funnel plot. Yeah, can you understand? Because see the top funnel plot. All the studies are scattered evenly. But see the bottom one. Most of the studies are on the left side. So this means that the left bottom study, that systematic review has some publication bias. But the top one, it doesn't have. So that's the whole idea. Now, as I said, it's not just about the randomized control trials because they give you the best level of evidence. Now you can collect evidence even from non-randomized trials, right? So for that, you have the Robbins tool. So Robbins is nothing but risk of bias in non-randomized studies of intervention. So that's the latest addition. It's very much similar to the ROB, the risk of bias, which I showed earlier, the same 5 domains. But here, these studies, they are primarily, the major concern is about the confounders. There are a lot of confounders you will realize when you're conducting non-randomized trials. So all those confounders have to be kept in mind. And again, you have these same domains which I said, and in every domain, you'll be asked what are the confounders in this particular study. So now just shift your thoughts to non-randomized trials. For randomized trials, it's very clear. Like you understand everything. But for non-randomized trials, it's important for you to understand the confounders. So whatever systematic review you're planning, whatever your title is, according to that, do you feel that there are confounders in this particular studies? If so, mention, right? So everything has to be documented. And again, based on analysis of all these things, you label your trials as low risk of bias or moderate risk, severe risk, or critical risk. And then you have to say no information. So having collected all this information, about analyzing these randomized trials, you ultimately give one, you categorize these studies as low risk or moderate risk, serious risk, and critical risk. So if there is a critical risk in that particular study that you're enrolling, including, please remove it, right? So you cannot include such studies. So that's the whole thing. And I would suggest you go and visit this website of riskofbias.info. Right? That will give you a lot of information of what a risk of bias is. So you have to have that basic knowledge of randomization, blinding, all those things, plus the risk of bias, how you need to assess. Okay? Thank you so much.
Okay, any question for Dr. Himanshu? One or two allowed, yeah.
Yeah, that's exactly what I said. So if you, there are, in that systematic review, if you have included 10 studies or more, right? Suppose you're preparing a systematic review and there are 15 studies. So for that, you create a funnel plot. These are all statistically analyzed, and these funnel plots are created based on the odds ratio, and all these statistical terms are there. So those tests are applied, and these studies are then placed on that funnel plot. So it's a visual thing. Seeing that funnel plot, you can come to know whether there is publication bias or not. So I showed you that slide. In one slide, all the studies, all those dots were studies. So they were all scattered evenly. And in the bottom funnel, all the studies were grouped towards one side, and this side was blank. So that gives you an idea that there is publication bias.
So regarding this confounders, generally confounders we treat in the statistical analysis. So
You will have to. Yes. Yes, yes, yes. So it's important that you identify what the confounders are, and then you address those confounders when you're analyzing the results.
Okay, we'll take it from there. Yeah.
Thanks. Regarding assessing risks of bias in observational study, how can we persuade other colleagues not to use the Newcastle Tower tool? Yeah, I know that Cochrane does not support this tool. Yeah, so how can we persuade that? And
No, I didn't get it. Say it again.
Newcastle Tower
Right.
tools. Yeah, how can we ask people not to use that? I mean, a scoring system. I
Right.
think that's not a good approach. So, what's your view on this one? Yeah, because you introduced the use of Robin's eye. So yeah, but that is a complicated system. So I think the key issue is how can we balance this? Yeah.
So basically, which tool to use? You mean to say that? With
Yeah.
No, Cochrane is very strict about it. Cochrane recommends the use of Robin's eye. It's developed by them, so you have to use their. Yes, yes, yes.
So there is a difference in Cochrane versus non-Cochrane.
Yeah,
so Cochrane has its own set of some rules and guidelines, softwares that are being prescribed, and you have to adhere. And even if you don't want to, the Cochrane system will make you use that, all the recommended aspects. So they won't allow you to basically deviate, and it takes really a lot of time to complete a Cochrane review from getting initiated to, the final output.
So whoever has prepared a Cochrane review, you will realize that it's very explicit when you're preparing. Everything has to be very explicitly written. And that's the reason why they have their own analysis system. They have their own software for like RevMan, as I said. They're very strict about it. You have to do it on RevMan. You have to use Covidence. You can't do anything without it. So that's one thing you have to follow with that.
So one thing I like to add, you can edit in the Robin tools that depends upon your NOS scale. You can refine your research questions for the quality assessment there. You can rename your quality assessment criteria. Okay. Suppose there is a blinding, so you can rename the blinding depends upon your NOS questions. Where is the comparability of your controls or not? So you can redefine there. Okay, in the Robin's tool.
Okay, thank you. We proceed ahead, and now that you have some data being extracted, you have to. Sir, you want to add something?
So I tell you, 2007-8 I'm talking of, the Cochrane team was here in India, and we were having stormy discussions about the difficulties being faced while doing a Cochrane review. And that time there used to be subject-specific committees of the Cochrane, subject-specific groups, and they used to take lots of time. And we were storming on them that, oh, we are very energetic and you take so much of time. You know what answer we got? The amount of hard work a person does for doing a Cochrane review, 3 times more work is done by the Cochrane team in ensuring it has been done correctly. That is why they are rigid. And that is why Cochrane has got its own value. I would not say it is universally very good, but yes, when we use the word Cochrane has given this, or Cochrane review has given this finding, it has got its own weightage. It is because of that reason. The robust methodology, yes, we know there are a lot of new things have come. They are little rigid to adopt. They are not actually, they are now becoming quite flexible. Past 3-4 years we have been working. Yes, there are problems in every system, but still we need to respect their system and we need to follow that.
So like, if you talk about evidence-based practice, so Cochrane is the topmost, and I'm ardent supporter of Cochrane and you will realize the fact that it is because how stringent they are at every step. Preparing one systematic review may take 2 years also, or maybe more than that. So like now I have 8 systematic reviews with Cochrane, so you can imagine how much hard work went through all these years. Now, again, I'll highlight the importance of this hard work. It is because of their stringent rules and regulations that Cochrane is sitting there in the WHO. They have a seat in the WHO. So you can imagine what level of evidence they generate. So I think you can use any software, you can do anything, but ultimately when it comes to Cochrane, I think they are the best, they are the leaders.
Okay, so now we move to the analysis aspects, which are relevant. So over to Dr. Sachit. Dr. Sachit is Assistant Professor of Pediatric Surgery, has led many systematic reviews. So over to you, Dr. Sachit.
Thank you. So I'll be talking about the data synthesis and meta-analysis plan, and my job has been made quite easier by the previous talk. So we will be covering these topics. These topics might seem a little bit disconnected among themselves, but just try and understand the concept so that it is easier for all of you to perform your own systematic review. Talking about the narrative synthesis and the meta-analysis. So narrative synthesis is essentially the first step in looking at the systematic review or the review which you are doing quite systematically and organizing the data in a systematic approach. And let me tell you that meta-analysis or the quantitative part, actually the forest plots and the most prized ornament, which is the diamond, it only forms a part of that systematic review. And there is a lot more in that particular systematic review besides that quantitative analysis. And 32% of the health-related systematic reviews, they use only this narrative synthesis and not building on the forest plots, because either the outcomes are not available or these outcomes cannot be pooled together. Because otherwise, if we'd be pooling different kinds of apples, then it would yield an orange. I'll show it to you later on. So narrative synthesis provides an alternative method of synthesis to meta-analysis of the effect estimates, and it has to be decided right at the protocol stage only. So what do we include in that narrative synthesis while we are writing a protocol? You need to have a very set rationale while you are conducting a systematic review. You need to distinguish the primary and the secondary outcomes, the direct and the intermediate outcomes. Then there should be a preliminary synthesis, and you have to describe the studies uniformly, need to have a pattern that which studies can be grouped together, need to form some kind of dummy tables, explore the relationships in the data which can cause within study and inter-study differences, talk about heterogeneity, and also talk about the maps and the tools which you will be using for the visual interpretation of the data. And last but not least, which Dr. Prabhakar has already talked about in detail, integrate the evidence in the form of risk of bias or grade tool, and discuss about the completeness and the applicability of the systematic review. So there is a checklist to it. So our job again has been made quite easier, and there is no need to cram these checklists. These checklists are prepared for a reason so that you can just follow it. So these are the SWIM guidelines, which is synthesis without the meta-analysis. You can use it for the narrative part of a systematic review also. Now that your Excel sheet or Google form is ready with you, you have already extracted the data, you will be performing some kind of analysis or meta-analysis. You will be pooling the data from different studies. So in that, you need to follow either of the two models, which are the statistical models. One is a fixed effect model. Because it is fixed, it is singular, it is fixed effect. The second is the random effects model. So I'll tell you about these assumption models. The fixed effect model basically assumes that there is only one true estimate among the studies which you have included in your systematic review. And all those studies are estimating that true effect only. So the only source of difference among those studies can be because of the differences in the sample sizes. On the contrary, the random effects model, in the random effects model, we assume that no single true effect exists. what we are trying to estimate is basically the mean of the distribution of the effects. And weights are assigned, like in the fixed effect model, the weights were assigned in a way that the study which had a larger sample size had a more weight. I'll show you the weight, how we assign the weight. While in the random effects model, weights are assigned in a more balanced approach. It not just depends upon the sample size, but also on the numerator, which is the event as well as the inter-study variance. So this is what I'm talking about, that in a fixed effect model, what we assume that all the studies, they have a fixed, they are estimating a single estimate, and the only difference among those is based on the sample sizes. While in a random effects model, this assumption model is basically used when there is no single true estimate. And we are assuming that we are estimating the mean of the distribution of the effects. So the biggest question is which model to use. Choice of the model must reflect our understanding of the systematic review, and it must be chosen in advance, which is that it is an a priori decision. Fixed effect model is used when you are working with a series of studies based on a single population. Let's say, for example, that you are working on a series of studies in which the population is third year MBBS students of AIIMS New Delhi. The population is fixed, then you will use a fixed effect model. On the contrary, the random effects model is used when you are dealing with different populations or which are different in any material way. So if in this example, the example would be that you are working on a study which includes third year MBBS students of all medical colleges in India or in New Delhi only. So in medicine, the studies are pulled from literature, and those studies are basically conducted at different centers across the globe. So generally, random effects model is used, and fixed effect model is used in very, very strict conditions. The most common error which we usually perform is that we start with a fixed effect model, and based on the heterogeneity, we switch to a random effects model. So which should not be the case, because it is a priori decision. So this is a very busy slide, and this is just to show that when we are dealing with different models, statistical model, either a fixed effect or a random effects model, we have to choose some statistical tools which are inherent to the software, which is RevMan, already talked upon by Dr. Prabhakar. So if you have an effect measure which deals with the dichotomous data, then you will either choose a Mantel-Haenszel model or Mantel-Haenszel tool or an inverse variance tool. While in case you have a continuous data, then you will use inverse variance, irrespective whether the effect measure is mean difference or standardized mean difference. So this is already available. You need not to cram this thing. Now talking about the most important part of meta-analysis, which is a forest plot, because I know that everybody is interested in that most prized ornament, which is the diamond. So apart from that diamond, there is many, I think you all know probably that there are many things attached to it. And if we see the column 1, then it talks about the study details, which is generally the study ID, and generally it is the first author's name or the corresponding author's name followed by the year of publication. Columns 2 and 3 would talk upon the groups that are being compared. The first forest plot is basically of a continuous data. That is why it talks about, it has mentioned the mean and the standard deviation and the total, while the second forest plot is of a dichotomous data. That is why it has only the events and the total. The fourth column is basically the weight that is assigned, which I was telling, that if the weights are very different, like if a study is assigned 4% weight and the other study is assigned 50% weight, then it is likely that it is a fixed effect model, because that assumption model is based on only sample size, while here the difference is less as compared to that because it is a random effects model. If you can see on the column 5th below the mean difference, I don't have a pointer, but below the mean difference, it is written as a random. So it is a random effects model. Then if we talk about the graphical part, which is very relevant, then there are some horizontal lines which are depicting each study. Now the ends of those lines are basically the confidence limits, the 5th centile and the 95th centile. That particular line is basically the confidence interval. And there are some boxes which are depicted by the green color. So that is the effect estimate. The larger the box, the more will be the weight. Larger volume of the box, size of the box, the more is the weight. If you can see that in the A forest plot, the 4th study has a weight of 42.2%, and the box 4th also is of the largest size. So it means that that has the maximum contribution towards the pooled estimate. Now there are some things which are mentioned like heterogeneity, which I will be talking about later. Then the test of overall effect, which is the final p-value of 0.01 of the overall effect, whether it is significant or not. And the vertical line in which is mentioned in the box, the vertical line actually denotes the line of null effect or no effect. So now talking about heterogeneity, which was mentioned in that particular graph. So as I said that there will be studies which are conducted at different centers across the globe, and probably you would want to pool the data in that. So this can result in heterogeneous data. So the different types of heterogeneity that can be present, one is a clinical heterogeneity, which is bound to happen, bound to occur. What is that? It basically refers to the differences that are associated with respect to the participant or the intervention information. So as I said that there will be studies which are conducted at different centers of the globe, and those studies, they have different baseline characteristics of the participants. So this yields to clinical heterogeneity. There is something in between, which is the methodological heterogeneity. So that methodological heterogeneity arises because of differences in the study designs, differences in the risk of bias, study designs as already Dr. Sumit Malhotra has mentioned, then the risk of biases as Dr. Prabhakar has already mentioned. So those will yield the methodological heterogeneity. And statistical heterogeneity is what we measure, which is denoted by the I-square. So statistical heterogeneity can be a result of the clinical heterogeneity or methodological heterogeneity or both. So in the clinical heterogeneity, you will have different shades of apples: green apple, red apple, light green apple, light red apple, dark red apple. Those will definitely be present. But if you are pooling the data of those apples, this will yield an orange. So statistical heterogeneity can occur, but you don't have to shift the statistical model from fixed to random or otherwise. You just have to talk about it and explain about the reasons which can yield this statistical heterogeneity. How do we assess this heterogeneity? The first way is to visually inspect the forest plots. You can see the confidence intervals of the forest plot, which is the first one. So the confidence intervals are kind of not overlapping. The 5th limit or the 5th centile of 2 studies which are in between in that first forest plot are going beyond or going on the negative side of the line of null effect, while for the first and the 4th study, they are on the right hand side. Those are not overlapping. While on the second forest plot, the confidence intervals are basically overlapping. The 5th centile, all of the 4 studies, they are on the left hand side, and the 95th centile is on the right hand side. So let's see the result. For the first forest plot, the I-square value, which is denoted by heterogeneity, is around 50%, 49%, because the confidence intervals were not overlapping. While for the second forest plot, it is around 0% because the confidence intervals were overlapping. So that is how we visually inspect the forest plots. So we have some other fancy tools also to assess the heterogeneity. One is the chi-square statistic. So the chi-square statistic, if the value is greater than the degree of freedom with a significant p-value, it denotes that the heterogeneity is significant. You can see that under the heterogeneity, it is written as tau square then chi-square. In the first forest plot, the chi-square value is more than the degrees of freedom. Okay, so it is kind of a higher heterogeneity, but the p-value is not significant. So this heterogeneity is kind of moderate, but it is not significant. While in the second forest plot, the chi-square value is 1.25 with the degrees of freedom 3. So the heterogeneity is also not moderate, it would be milder heterogeneity in this. And the second thing is a direct estimate, which is the I-square statistic, which I talked upon, that it is 49% in the first plot and 0% in the second plot. So the I-square value actually ranges from 0 to 100, and Cochrane has given some limits and divided it into 4 parts, if I am not wrong. One is 0 to 40%, which is kind of a milder heterogeneity. The second is 50 to 90%, and the last is, I think, more than 90%, I think. Whatever, earlier it used to be more than 50% is substantial heterogeneity. Now it has divided it into 4 levels. And actually, I-square is a test that includes 3-4 things. One is basically the p-value. Then it also includes the chi-square part, and also includes the magnitude and the direction of the confidence intervals. So the next thing which I would be talking about is how to handle the missing data in a systematic review, which is one of the biggest problems. So the first thing is to contact the authors for unpublished or the missing data. Now, if you write directed and specific emails, I think I have been at least lucky to get that data. Probably with the institutional ID of AIIMS, I have been lucky to get that data, missing data. But it is very important to write specific and directed emails. If you say haywire that I am working on this review and this is of this importance, and write another paragraph on it, then probably the authors would not return the data or would not reply to the email. So that is why write very specific and directed emails. Then if you are still unlucky and you don't have that data, then what you can do is, one way is what Dr. Pradeep mentioned, that you can either go to the preprint archives or the repositories like ResearchGate. The other thing is to impute. How many of you have done a randomized control trial? Okay, so there are some imputation methods, what we do in a randomized control trial. So what we can do is we can use pooled standard deviations and calculate the standard errors, or we can impute from the similar studies which are there. So let's say, for example, that you have 7 or 8 relevant studies in your systematic review. And out of those, 2 or 3 are from Italian center, which are geographically very close. And one study you are unable to find that data. So the population characteristics would be nearly similar. Or what you can do is do a propensity kind of matching between the 2 studies. The baseline characteristics can be matched, and you can impute the data of that study to another. However, it is kind of very risky business, because it can introduce a serious bias once you calculate that risk of bias, but you would still score the risk of bias higher when you would do the risk of bias assessment. The third thing would be to do a sensitivity analysis using the best or the worst case scenarios. and then you can use some model-based approach for imputing that data. Publication bias has been talked upon in detail by Dr. Prabhakar, but I just want to tell you that publication bias is basically a non-reporting bias. That we are all Homo sapiens. So if there is a finding which is negative, or if there is a finding which is not positive, we would not try to publish it, and that yields to a non-reporting bias. And funnel plot is one thing, how we can estimate that publication bias. The other thing is the Eggers test, which is a linear regression test, which can be easily done, and we can quantitate the publication bias in this. Thank you. So you can either direct your questions to my email. All the slides, I can share it with you. Thank you. Yeah.
Okay, any questions for Dr. Sachidanand? I mean, any pressing questions? Otherwise, we'll go to... Yes. So you can do meta-analysis in Stata. I mean, also...
So there are a lot of softwares. One are the access-based software. Access-based softwares are quite easy to work on, like Revit. We are working on meta-analysis.com. Okay, so the other softwares are no, I have never used it. So the other softwares are the algorithm-based softwares like R and other stuff. The third is what you have said, that there are online repositories and online softwares where you can easily work on. The only problem with those online softwares is basically related to data sharing, because I would be skeptical in using those open source online softwares. Rather than that, I would either go for the Revman by Cochrane. They have an option for Revman Public. Okay, so probably I have never used it. I've never used it.
Yeah, so the only, I think the limiting part is... It is paid, that's the only limiting, step. Yeah.
For publication bias, we need to have at least 10 studies.
Yeah.
Then only we'll be able to calculate.
Yes, so there is a limit to it, that for the Eggers regression as well as for plotting the funnel plot, you need to have at least 10 studies.
Okay, if it is less than 10, so how will we
It
be able
can't
to
be
calculate?
estimated actually, but what the handbook says, that if it is less than 10, then there is a high likelihood that the publication bias would be present. What I think.
If it is less than 10.
Yeah. Then it is already on the higher likelihood.
Yeah,
that the
definitely.
publication
I
bias
mean,
would be
for that you don't have to create a funnel plot.
Yeah, exactly.
So it's only when it's more than 10, then you create a funnel plot. Secondly, as I was supporting RevMan, so if you want, it's a paid, Dr. Sumit said, but if you want to use RevMan, go and register your title with Cochrane. And once your title is registered with Cochrane, you get in.
No, so Prospero is not same as Cochrane.
Yeah, so that's different.
Prospero is basically a registering database. It is a prospective database where you register, and you don't want duplicacy, or you just want to probably see that what other reviews have been registered on that particular topic, and then register on it. So it's just a registering repository or a registering database. It's not monitored. Cochrane. Yeah. Not monitored. Yeah. Cochrane is monitored.
Okay, so I think that sets the ground for the next, talk by Dr. Kunal. And Dr. Kunal represents, Center for Dental Education and Research. He's additional professor there. And this entire workshop aims at, protocol development. So we are back to the protocol after covering the different nuances, like what all goes in the protocol, and also how to register it. So over to you, Dr. Kunal.
Thank you. So, colleagues, it is now that we understood what are the basic steps of a systematic review, and the main aim of our today's workshop is to learn how to make a protocol, and finally when you have made a protocol, you want to register it. So basically, plan for a systematic review is a protocol, and it defines the steps that you will be undertaking in a review. As Dr. Sachidanand told, it is a prospective entity. So protocol for a systematic review should basically include the rationale, the objectives, and the methodology. And why should we register our systematic review. So the three basic objectives is to promote transparency, help reduce the potential for bias, and it also serves to avoid unintended duplication of reviews. It is also said that it is best to wait until your protocol is well developed and unlikely to change before you decide to register it. Where are the sites where you can register? The most popular one, if you are planning to do a intervention review, systematic reviews which incorporates intervention trials, then you can register and opt for Prospero. So Prospero stands for International Prospective Register of Systematic Reviews. It is a free database of systematic review, rapid reviews and umbrella reviews. The registration and submission of a protocol is free of charge here. Other site is Campbell Collaboration. It registers Campbell systematic reviews, evidence gap maps and research methods papers which can be registered on this particular site. Another site which is gaining popularity is InPlazi. So it is an international platform of registered systematic review and meta-analysis protocols. So it can be used to register systematic or scoping reviews. It is free. There is also a charge but there is a charge, and when they charge you, they also give you a digital object identifier number, that is DOI number also, like a published paper. The research registry is another popular site, which is Registry of Systematic Reviews or Meta-Analysis. There is a charge to register a review. Again, your protocol once registered will be given a DOI number. General registration sites are Open Science Framework, which is a free open source project management tool. Registrars can create a pre-registration on the platform. Your protocol will again be given a DOI number. Then there is Figshare, Zonedo and Protocols.io. So these are the general registration sites, but we will talk in particular about the Prospero. So once you create an account on Prospero, you will be first asked the question whether your review is of human or animal studies. So if you go for human participants, that is what they will go ahead with. Then the next question is this registration record been created by a student or as a part of a course or a module? So we do it for scientific purpose, so we are not doing it for training. So when you do it for a scientific purpose, you tick that option. And also there is one more question, that is what type of review are you planning? So Prospero allows only interventional reviews, not any other category. And the next question when you go for registration is writing your title. So acronyms or short forms should not be included in the title unless and until it is regarded as a very standard form like HIV. The title should of course be written in English, and if the final title of the review differs, then it can be displayed in the publication of the final report. So example is systematic review and meta-analysis of recurrence and survival following pre versus post-operative radiation in a localized resectable soft tissue sarcoma. So it is in that much detail that you will make your working title. Next, you will be asked what is the condition or domain that you are studying in your systematic review. So you have to very clearly mention which are the diseases. Next, rationale for your review. So this is what is being reviewed very carefully by the Prospero before they register your title, that you will describe the rationale for the review, explaining why it is being done and what it might add to the existing knowledge. Next question is review objectives when you want to register. So here you will provide an explicit statement of the objective or the question which you are addressing in a systematic review, and this should be stated clearly and precisely. The review questions may be specific or broad. Consider breaking very broad questions down into series of more specific questions. So a very good example which they have stated is, how does preoperative chemotherapy impact on survival of early stage non-small cell lung cancer as compared to surgery alone? So you are comparing the intervention and control, and also writing about the therapy and its outcome in your research question in a PICO format. Keywords, what they suggest in this column, that you give words or phrases that best describe your review. Be as specific and precise as possible. Avoid acronyms and abbreviations unless they are in wide use. Mesh terms will be applied in subsequent later sections. That should not be entered in this keywords. PICO terms also should not be re-entered here. Country, of course, which country you are planning to carry out your systematic review in. Then population. Here you have to write the described in the PICO question, the P stands for population. So specify the participants or population being studied in a review using inclusion and exclusion criteria. For example, you included adults with schizophrenia, which could be diagnosed by any specific diagnostic criteria. Exclusion, you excluded adolescents and elderly people. So be very specific when you're describing your population. Next, after population, it is I, that is intervention or exposure. So describe the intervention exposure to be reviewed. The prescribed format includes the details of both inclusion and exclusion criteria. Comparator, next, they will ask you about what is your comparator or control in your systematic review. So where relevant, give details of the alternatives against which the main intervention will be compared. That is another intervention, a placebo or a standard care. Study design is the next question. So give details of the types of study design that will be included. If there are no restrictions on the type of study that you want to include or certain study types that you want to exclude, everything should be stated clearly. If different study designs will be included in different parts of the reviews, then that should also be mentioned. But most commonly, as Dr. Prabhakar told about our inclusion of randomized controlled trials. So the review of clinical effectiveness will only include randomized controlled trials. This is one example. The review of patient experience will include focus group and interview studies. That is, patient-centered outcomes will be measured through focus group and interview studies, whereas the type of study design that you want to include is randomized controlled trial. So this is an example. Context. So give summary details of the setting and other relevant characteristics which help define the inclusion or exclusion criteria. For example, whether your study was in a hospital, accident or emergency departments, as Dr. Prabhakar told about in the data extraction. Research in LMICs could also be included here. Then the next question that Prospero will ask you, whether there are any similar systematic reviews registered in Prospero. So Prospero requests that to avoid unintended duplication, you check reviews identified as being similar to your own before you proceed with the registration. Your review title and review question together with condition, intervention and comparator tags and keywords are used to identify similar systematic reviews already registered in Prospero. Unless your registration is complete, each time this record is edited, checked, will be repeated by Prospero itself. Prospero, we have to note that Prospero does not stop you from registering a similar review, but then you have to state why you are doing another review very clearly here. Then next is review timeline, which they will ask you, that is when you want to start and end the dates of that. And availability of a full protocol, whether your protocol is fully available with you. If that is available, then you upload it as a PDF. If it is already published, then you can upload that also here. Then search for unpublished studies, whether you will carry out search for unpublished or grey literature. Then any restrictions to the language in your systematic review, language of studies, which are the studies, they are published in English or Chinese or any other language. You want to prefer to use studies which are preferred in, published in English or in any other language also. That is what they want to know. Then next question is which databases you want to search. So you have to tick mark them, that is you want to use PubMed, Medline, Cochrane, Embase, which our previous speakers have highlighted. How you want to do search literature. Then search date restrictions. Are there any search date restrictions from which particular year you want to search? You have to mention. Any other methods of identifying studies, that is contacting authors or experts, as Dr. Prabhakar and Dr. Sachidanand told about missing data, or they want to know more about any published data. So whether you're contacting authors or experts, reference list checking, searching conference proceedings, searching dissertation and thesis databases, searching trial or study registers, looking through all the articles that cite in the paper included in the review, which is called as snowballing effect. So then next question is, they will ask you to give link to your search strategy. So you can upload your search strategy, which databases and which keywords, whether mesh you're using in a PDF format, you have to upload there. Then you have to mention very clearly about data extraction. So how will you do? So data, the question that they will ask you is, data will not be extracted from publication. Data will be extracted by one person or more person, or independently by one person, and even a machine, that is the software which they talked about. Then next question is obtaining study data sets or individual participant data, whether you will do that analysis or not. Study the risk of bias or quality assessment, as Dr. Prabhakar told about, using ROB 1 or 2. Then what tools will you use to evaluate? So we have the options for intervention, most commonly Cochrane ROB 1, or now the latest version is Cochrane ROB 2. And then you also want to, the next question which they will ask you is reporting about the bias, so reporting bias assessment. So if the study results that are available and can be included in analysis differ systematically from those that are not available or missing, this can introduce a bias. So you have to state about this also. Certainty assessment is the important tool to assess that is grade. Anyone knows what is grade? Grade 2. So it stands for grading of recommendation, assessment, development and evaluation. So it is a tool with which you finally grade the quality of evidence that you are getting as high, low, moderately, low, everything. So there are 4 points there. So these are, in the end of your systematic review, you will use the grade rating. So how certain are you about the evidence that your intervention is better as compared to your control? So grade is a very big topic by itself. So that comes under certainty assessment. So they will ask you whether you will do that or not. So main outcomes, then they will tell you what are the main outcomes which you will analyze in your systematic reviews, as well as additional outcomes, in particular about patient related outcomes, that is quality of life. So how the intervention affects the quality of life, whether you will like to assess that or not, will come under additional outcomes. Then strategy for data synthesis, which Dr. Sachidanand covered, the meta-analysis and statistics part. And then last important point is, which they will ask you to declare at that time when you submit, that whether now that you are submitting your systematic review, so have you begun the search, have you begun the data extraction, so which stage are you in? So once you declare that and submit, then your protocol will be reviewed by Prospero, and the decision will be either to revise, and if it is accepted after revision, then you will be assigned a registration ID in the form of CRD, after that 11 digits. So that is your complete Prospero registration ID. So once you get that ID, then next step is to publish. So it is not mandatory that you publish, but it is very, very important that if you publish, it will again increase the transparency of your systematic review. So apart from the final systematic review, you can even publish your protocols also. So another way to make the protocols available is to publish it in a journal that accepts such protocols. So examples are Journal by Name Systematic Reviews, BMJ Open, Journal of Human Nutrition and Dietetics, and many more journals. So once you decide to publish, then there are guidelines how to write a protocol paper. So those guidelines are called as preferred reporting items for systematic reviews and meta-analysis protocol, which is PRISMA P, which came out in 2015. So it has 17 checklist items. So it helps you to guide how to write each particular section of your protocol when you want to publish as a manuscript. So when you're writing a manuscript, the title should identify the report as a protocol of a systematic review. So once you write whichever group in the PICO format the title, then you have to put a colon after that and write protocol of a systematic review. When you're writing a full systematic review, then after your title you put a colon and write systematic review or systematic review and meta-analysis. Here you have to write protocol of a systematic review. Then if you are updating a already published protocol or a systematic review, that also should be stated. Then you have to, if you have registered on Prospero, then you have to write the registration ID also. Then authors provide your name, affiliation, contributions of each author. Then amendments, if you want to do any amendment to already published systematic review or a protocol, then you have to write those. Then sources of funding also should be declared in your manuscript. Then when you're writing an introduction, so your protocol should have a clear rationale and objectives, which we have already discussed. Then methods should describe the eligibility criteria in a PICO format. Then information sources, that includes electronic databases or contacts with the study authors, trial registers or other grey literature sources. Then search strategy, as Dr. Prabhakar told about what is the detailed search strategy you have to mention, which all databases and what are the key terms that you have used. Study records, that is data management. So describe the mechanism that will be used to manage the records and data throughout the review. Selection process, state the process that will be used for selecting studies such as 2 independent authors. So that is a must. That through each phase of the review, that is 2 independent authors are needed for screening, eligibility and inclusion even in a meta-analysis. So data collection, as we have already covered. So what is your form, which was the data collection form you used, that has to be described. And data items, that is list and define all the variables for which the data will be sought, such as PICO items, funding sources, any pre-planned data assumption and simplification. Then describe your outcomes and prioritization, risk of bias, data synthesis, that is any statistics or meta-analysis that you have done. Then any meta-bias, that is publication bias, which Dr. Prabhakar has told about, the funnel plot. Any selective reporting within the studies you have to state. And last is, which I have told you, that is grade, that is confidence in the accumulating evidence. So describe how the strength of the body of the evidence will be assessed using grade tool. So that is how we write and report our protocol. Thank you very much.
So any questions? I mean, yeah, so we'll allow 1 or 2 because we've already exceeded the time. Yeah.
Thank you for the presentation. So I just want to ask that there is an increasing trend of using ChatGPT and AI in the publication and research articles. So is it allowed, or are there any restrictions? And if it is used, are we required to declare it? And what are the guidelines for that? Thank you.
This is a growing concern nowadays. Everywhere AI being used. Okay, so first thing is, 5 years back when we started talking of somebody using AI for help in a research article, as Committee on Publication Ethics, we refused that it will not be allowed, it will not be acceptable, it will be unethical. Okay. 2 years back, the forum met again, and the basic question was
If AI is helping in somebody whose primary language is not English or Chinese, whichever way it is, but they want to publish, where is the problem? So now, as on today, the stand is AI can be used for assisting, but it has to be verified, supervised by experienced people, and the responsibility of all the information coming through AI or whatever text is being generated or whatever tables are being generated, that lies with the people, those who are doing it. Okay, so yes, absolute AI, no. AI help only for construction of something is still okay, but you need to declare at the, like you do the acknowledgement, that way you need to declare. Some of the journals are allowing, some of the journals are still not allowing AI. So we are in a phase of transition. Maybe after 5 years, you just put a question and your Prospero will give the answer. It will happen. Things are happening very fast. But yes, as on today, science rely still on human minds, not on AI.
Okay, last question of the day for this workshop.
So with respect to study selection, do we have an upper limit as well as a lower limit to total number of studies that can be included as a part of screening?
No, there is no upper limit. More the number of studies, better is your systematic review, and hopefully only then you'll be able to carry it forward to meta-analysis. Because if there are no studies or just 1 or 2 studies, it doesn't carry any meaning.
Do we have a set limit, like, okay?
No. There's no set limit.
No. Do we have a limit above which the study, like the value of systematic review increases?
Okay, so everything sees a change. So COVID brought a lot of change, and we saw suddenly a hurricane of systematic reviews because people are doing desktop research. So now all the fora, wherever people are talking of evidence-based medicine, everywhere the senior most group is sitting and now talking that we should make at least some guideline that at least this much material should be there, then people should be doing systematic review and meta-analysis. Okay, I'm also part of one of the group where we are still trying to frame some guidelines, at least 4, at least 6, at least 10, whatever. Because we have seen during this last 4 years a surge, 80% surge in systematic reviews and meta-analysis. And many of them are just update of 1 year, last 1 year, maybe only 2 studies, and after exclusion, lot of heterogeneity, only 4 studies have come up and then they are giving some recommendations. So things have gone little in a wrong direction. Maybe it was due to COVID, and I'm not saying, but yes, as of today, no guideline. Everybody is thinking to make guideline for minimum. Maximum, there is no guideline.
So I'll just share my experience when I started working with Cochrane Collaboration. We had to fill a form. I'll just clarify your, I think you misunderstood that when I said register with Cochrane, that this registration is different from what we were discussing in Prospero or clinical trials or CTRI in India we have. With Cochrane, when you start working with a collaboration, you have to send a title. It's a simple email. You just send a title to them and you say that you want to work on this title. If they agree to that title, then it is said that your title is registered with them. Right? That is what I meant. And once your title is registered, you can get access to RevMan and you can start working on it. When I started preparing the Cochrane reviews, they used to ask, we had to fill a form to apply for that title registration. They used to ask, are there 2 RCTs available on the topic that you are working on? So that time it was 2. Now last year I submitted one proposal. Now they have started asking, are there 50 RCTs available? So the number 2, it has increased to 50. But then again, the topic which I am working on, COMA, it doesn't have 50 RCTs. But yes, there are around 10 or 15 RCTs that I know of. But they agreed to it. So again, the answer is no fixed limit of RCTs.
So I think we have to close the session and the workshop now. But once we close, you have the chance to also meet each one of us individually and come with a question, because we've already exceeded the time. In the next session also is about to be initiated. So thank you everyone for being here and giving us an opportunity to interact wonderful. We all enjoyed. Thank you also to the faculty at AIMS who basically took time out and shared their experience. So just the last part of ending. Yes, so as token of appreciation, from the conference organizers, so we'll present these mementos. So first to the chairperson.
I'll present
Okay, okay, okay. So, so we'll start with Dr. Himanshu.
No, we'll start with Dr. Sumit. जो हाथ में आ गया पहले. Please come here.
coming to have our workshop. It's really heartening to see people who've come and joined. There are 3 seats still vacant here. You can come and occupy them. So this particular workshop is about conducting meta-analysis and systematic reviews and meta-analysis. So I hope all of you know what's the difference between a systematic review and meta-analysis. How many of you know that? One person definitely knows. Okay. So it's not a great majority who know what the difference between systematic review and meta-analysis. So systematic review is actually a broader term. It is a bigger term, and meta-analysis is the statistical part of the systematic review. Systematic review is like conducting original research in which you have a research question and you have methodology to fulfill that research question with the methodology of a systematic review, which involves trying to find an answer to that question, which can come from literature. And for that, you have to search literature. And after searching literature, whatever you get, you have to critically appraise it. And then after you've critically appraised, you have to extract the data from that particular study. Those studies may be 100 or 20 or 5. And you have to enter them in a program so that you try to find out what is the relative value of those studies and whether you can pool the results of those studies. And once the pooling takes place, that is when it becomes, for that statistical pooling, that is what is called as meta-analysis. So it is one part of the whole thing. Also come to know now what is the difference between a traditional review and a systematic review. Do you know that? Hands raised. Yes, please tell.
Traditional review is basically collating all the evidences in the literature which you have, and systematic review is like systematically you have to look in the literature. There's a screening strategy, there's a PICO, there are some parameters in the results which you have to look. So that's a systematic review.
So traditional review is what we are used to doing. We look at a particular subject, we read randomly, we don't actually make a pointed search for literature. Whereas systematic review is something which has a method, and you have to follow that method like you follow a method of the research project. So it is almost like a research project that you are conducting a systematic review. And that is why systematic reviews are considered to be, like gold standard of evidence. So evidence-based medicine is something which is important to know before we go on for further discussion. So evidence-based medicine is the science of turning clinical problems or public health problems, into research questions, and then accessing literature, answer for that, accessing, that is searching, then analyzing, then you have to extract the data and then applying it, and after applying, you have to audit. So after the audit, you actually get to know the interventions which you thought were effective. You come to know whether they have to be put into practice or not. And once you put them into practice, again you audit the results, whether they've made any change in the lives of people or in systems wherever they've been introduced, whether they have made any difference. Then you modify your questions again, and then that cycle kind of repeats itself. So I have 2 minutes for you. You talk to the person sitting next to you, okay? And try to think of a question, the answer to which you don't know. And this question can be relating to an intervention. This can be relating to diagnosis. This question can be relating to prognosis, risk factors. Or this can be any question. This can be a day-to-day life question. Okay? So do that. I give you three, 4 minutes for that. Go ahead. Those of you who are sitting in rows of three, all three of you can talk to each other. I have some, वो भी है ना, slides भी है. कोई बात नहीं, हाँ, it's okay. उस पे आ नहीं रहा. अच्छा, slide show पे आ रहा. Those who are sitting at, standing at the back, you can also talk to your friends. Make some new friends. Introduce yourself and think of a question. So shall we start from the back? Did you talk to each other? Okay. So what is your question? You write your question on your on a piece of paper. You know, all of you have come here to do some systematic review, I think. You know, that is the reason you want to learn the methodology. So it's always good to think of a question which you would like to take up for your systematic review. And because that is something which will be useful for you, and you can follow the process of conducting a systematic review on that particular question. Okay. Please tell your question. Yeah. हाँ बैठे रहो, इस पे खड़ा बोलना मुश्किल. हाँ.
What is the incidence of pre-malignant malignant conditions in LGBTQIA+ population who are undergoing or have a history of gender-affirming hormonal therapy? Gender-affirming hormonal therapy.
Let's call it hormonal. Okay. You want to tell your question? Okay. Let's first listen to this. What type of question is this? So, you know, there are, because we were talking about intervention questions, diagnostic questions, prognostic questions. Now, this is a question which is about having an incidence or prevalence of a particular condition in a group of individuals. So these are also questions which can be subjected to meta-analysis. And I did not talk about these questions, actually, when I was giving you examples of questions. So incidence, prevalence of a particular condition amongst a given population, which varies in different, this may vary in different regions. For example, in India, it may be different than United States of America. So when you look at various studies, you may come across different kind of studies, and then you will have to use some methods of pooling. This certainly will be an observational kind of a study, somebody who has followed a cohort over a period of time and then has come out with an incidence or prevalence. The prevalence can be point prevalence, or it can be prevalence over a given period of time. So those are the kind of papers that you are going to be looking at. So this will be for observational studies. Okay. You had a question, Batai? Come to you after this. Yeah.
Are digital tools for tobacco cessation counseling better than in-person or physical counseling? That was my question.
So his question is, are digital tools for counseling better than the traditional tools for counseling for tobacco cessation? So this is one question which is an intervention question, in which you are thinking about digital tools. And this is the type of questions which are actually broken up into what is known as PICO. And PICO is population, intervention, comparator, and outcome. So here, what is the population? Would you tell what is the population? Did you listen to the question? So people who are smokers. Smoker is the population actually here. So smoker can be of any age, any gender. So you can qualify all those terms for that particular people. And then you have an intervention, which is digital intervention. And then you have a comparator, which is traditional intervention. That means calling them up, counseling them. There can be several methods. And outcome would be, what would be the outcome? Whether they have stopped tobacco, whether they have cessated tobacco or not. So how will you determine that? Again, you will have to find out the prevalence of smokers even in a given population before and after this intervention. And then you will compare it. And there could be some other parameters also, some other secondary outcomes also, which you may like to see, which may be, sometimes you're not able to get from people whether they have actually stopped smoking or not. So it may be certain biomarker which you want to see, whether that, like cotinine is one salivary biomarker which is there in saliva of people, of smokers. It's actually a product of nicotine. So whether that has disappeared or not, or its levels have decreased or not. So you can decide about the outcome measures yourself. So in this question, there is a PICO, and this PICO is population, intervention, comparator, and now in his question, which we had just discussed, again, there was an exposure there. There was an exposure to hormones. And he was looking at incidence of malignancy in patients who have been exposed to hormonal therapy. So PICO can sometimes become PECO. So this PICO will be PECO. So here it is a population, in your case, it is a population of, you said some gender, let us see females who are taking hormonal therapy. That is your population. So that is the exposure here. Population is females exposed to hormonal therapy. And then you find what is the incidence of cancer in those patients. And this can be compared to controls, because controls could be people who are not taking hormones. And what is the incidence of malignancy in those patients? So that can also be a study design which you can study. So आपका क्या question था?
Association of ambient air pollutants with adverse birth outcome in pregnant women.
So here the population is pregnant women. Exposure is environmental pollution, right? Yeah, environmental or air pollution. And outcome is adverse pregnancy outcome. So that is the outcome that you were seeing. So this again has exposure as a factor, and there may be a population which is not exposed to that level of air pollution. So you'll probably have to define air pollution, what it means, what PM 2.5 or whatever ambient parameters you will take for air pollution. So all these are very good questions. All these are questions on which meta-analysis may have already been done. So if a meta-analysis or a systematic review has already been done, then what do you do? So the next point, because after you have your questions, the next point is to see what is the answer to this question. Is it already existing in literature or not? So you will have two kind of papers. One could be systematic reviews or meta-analysis, which you will have to search in literature. All of us first go to Google, isn't it? And then we look at some papers. But the best part is to go to PubMed. And in PubMed, there is a proper search strategy which can be adopted. There are certain mesh terms. There are certain Boolean operators. And then you come out with these searches which are there. So in PubMed, there is a part called clinical queries. So in clinical queries, you get RCTs, systematic reviews, and genetic databases. So clinical trials and systematic reviews is something you are interested in. If there is a systematic review already existing, supposing that a systematic review was published in 2021, so obviously there is a scope for looking for more, and there are more studies related to that, then you can take it up and take that up as your baseline systematic review and then update it. If nothing has been done, for example, say in case of digital interventions, maybe you may or may not find interventions. In that case, you will see if there are any RCTs available or not, whether there are observational studies, whether they are available or not, because it will depend on the type of studies which are available that you want to make up your mind. So what we do initially is a scoping. It's called a process of scoping. So scoping actually tells you whether it is worth doing a systematic review on that particular question, or if a systematic review has not been done, you want to see what kind of studies are there. Are there RCTs present in an intervention scenario, or are there observational studies which are present? So you will then decide, yes, this is a systematic review, this is a question that I'm going to take up, and this is how I'm going to do it. So I'll just see the slides. So why do we do systematic reviews? Because evidence related to research should be summarized, and the practice of medicine must become evidence-based and well-informed. So when you want to do informed clinical decisions, you want to make informed clinical decisions, in that situation you need to know the evidence. You need to know what are the studies, what are the trials. But then if you start reading all 10 trials, it will become difficult. So if you find a systematic review which has been done on that particular topic, the job becomes a little easier. It becomes easier for you to take a message from that. But in that case also, you also have to know whether the systematic review has been done with precision or not, whether this is a quality systematic review or not, because everything is quality. And sometimes the systematic reviews are not meeting good quality, and that is what they are being classified as research waste. Because during COVID time, many rapid reviews were done. People were in a hurry to find out answers to questions. And they did systematic reviews which did not qualify for, they had missed out studies, or they had made wrong conclusions. So in that situation, quality systematic review is important. And since we are Cochrane people, we say that the best quality systematic reviews come from Cochrane, and they are published in the Cochrane Library. And Cochrane Library also gives you a very good methodology for doing systematic reviews. We actually are having an evidence synthesis unit of Cochrane now, for which I'm you can see they call me lead, but I'm like a coordinator, in which we can decide about prioritized topics. For example, all these questions which have come up are very, very important. Environmental pollution is important, smoking is important, hormonal therapy is important. So all these are questions which need answers. And if answers are existing, we'll find out by searching literature. If they are not existing, we'll have to do a systematic review. And there are certain things which are beyond systematic reviews. And that is what my friend Dr. Prateek is also going to talk about, That is, whether these systematic reviews can actually be applied to practice or not. That means whatever interventions we are studying, are they cost effective? Are they equitable? So because the question which is there in this particular topic is bridging systematic reviews or bridging evidence to equity. Because equity, equality, ethics, access, these are some of the points which are now becoming extremely important, and evidence-based medicine is now evolving into a new science, and very soon you will start hearing about that. That is called value-based medicine. So, you know, you go to a private practitioner or you go to a big corporate hospital and they tell you to, you know, get some intervention done, which is very expensive. And you go to another place, you consult another place, and he says, okay, no, you don't need it at the moment. So what is the difference? One is the patient will feel very happy कि उसको नहीं कराना पड़ रहा कुछ भी, or he may also feel happy if the intervention which is offered in one hospital was much more expensive and he's getting it at a lower price, will certainly be happy. So patient preferences are also becoming extremely important in evidence-based medicine. So it is not all evidence. It is not all what the researchers have found out. It is also what the population wants, what the person wants to himself or herself. And that will depend on the subjective criteria of this person. What is his economical status? What is his emotional status? What is his social standing? What is his educational status? So all these things which are related to patient are also important, and nowadays we will have to start looking at that, because value-based medicine will decide whether a cost-effective intervention is being used and whether it is acceptable to patients. It is not impairing their independence. It is not impairing their decision-making about their lives. It is improving their quality of life. And that is why now there is a lot of emphasis on quality of life. So all these interventions which we are talking about, the digital intervention, say for smoking, the person may not like, you know, these SMSs coming time and again. He say, mujhe nahi ye chahiye. I'm not going to follow it. He may actually start hating those messages. Ho sakta hai na aisa. So those kind of personal preferences, and those will be found out in the studies when they are being done, whether they are important or not, is something which will figure in this value-based medicine. So when we bridge evidence to equity, we also think of values, and those values are different types: economic, social, equity. Equity, what is equity? Equity is actually economic differences. We know that equity share, whenever you look at a newspaper, equity means how the price index is going up, or whatever is happening in the stock market. So it is related to money. So that is important, and that is something which we must understand when we are looking at evidence. So why we were going to do systematic review is that the studies that you get, they may be of insufficient sample size. They may be having high sampling variability, means that there may be a lot of heterogeneity amongst the studies, and heterogeneity may be related to methodology, that the composition of patients is different. The methodology which is being used in that particular study, say in digital intervention, one person is using phone, the other person is using computer or television. So interventions could be different. And then you may say that they are all digital, but there is a lot of heterogeneity. So if there is methodological heterogeneity, that is one problem which happens when there are different studies which are there. Or there can be statistical heterogeneity. That means if you have trials or studies in which there are different sample sizes. One study has done, say, 5,000 patients followed up for hormonal imbalance or hormonal supplementation, but one person has followed only 50 patients. So there is a lot of heterogeneity in this sample size. The results which you're going to get from a higher sample are going to be more reliable than what you're getting from a lower sample. So So that is why for meta-analysis or for systematic review, you tend to pool those studies. If you get like 10 studies with sample size of 50, you at the end, you get like 500 patients. And that is why you're pooling those studies. And this pooling is very easy actually. These methods which are used for statistics, don't just go by softwares. Try to study the statistical method of pooling which is there. And it becomes very simple, and you actually find out which study has how much weight, depending upon what precision is there, how much confidence intervals are there. So all those things are discussed in these issues. So have I passed my time or something? 5 more minutes, okay. So narrative reviews and literature reviews we have already discussed, that this is a summary of information which is available to the author. Their subjective opinion may be there, whereas in a systematic review, the opinion which comes out ultimately, that is not subjective. That is based on the relevance and based on the statistical strength of the information that we are getting. We may ignore sample size, treatment effect size, and research design in case of a traditional review, and that's why it is misleading to the readers. We see our students who write thesis. So we give them a topic, or they take a topic, and then they have to write a review of literature. So what they do is they go to PubMed and they find a search, and a lot of abstracts appear. What they do is they pick up an abstract and they just cut and paste, and that's it. That's the review of literature. So that is not what we are supposed to do. We should do a systematic review of literature with a methodology. So even if people are doing a thesis, a PhD or a MD, or you should actually do a systematic review of literature, because only then you will refine your research question, because that research question will get modified once you have information which is already available on the basis of that information. So systematic reviews were applied, for definition purposes, although there are many old definitions, and it was somewhere around 1995, 94, 95 actually Cochrane collaboration was established. 93, 94 they had, I think 94 they had the first colloquium. So there were many people who, Ian Chalmers and Doug Altman, these people were the main pundits on evidence-based medicine. And so systematic review is a review of similar studies prepared using systematic approach to minimize bias. So basically it is minimizing bias. Bias is something which you presuppose, and you want to go clear of that bias and then try to reach the truth. That is the main purpose. And random errors, which are documented in its materials and methods section. And it could also be application of scientific strategies that limit bias by systematic assembly, critical appraisal, and synthesis of all relevant studies on a particular topic. So any questions to be asked? Anything about systematic review? Now, I'm talking of very basic things about systematic reviews, but actually, if you understand the basics, it becomes very easier. Very easy. The methodology, methods, softwares are available. Methodology is there in Cochrane Handbook, plus there are many other, now books which have come up. So it is possible to do a systematic review very easily, but you should be very clear about your research question and then your methodology. So I think I'll stop here. I'll come back again. I'll ask Dr. Anil to take further questions.
More than 10 years. Yes.
So, good evening, everybody. Thank you, ma'am, for giving me this stage. So, I will take forward the talk of ma'am. Ma'am has already introduced about the concept of the systematic reviews that has been added a decade or 20 years back. So now some concepts, they are being updated, and now many more systematic reviews in the form of other types of reviews, they are being coming up. So I can just list, there are some umbrella reviews are there. So there are the network meta-analysis, they are coming, scoping reviews. So many more AI is being introduced in these things. So my topic is to introduce the basic concepts of the network meta-analysis. So this I will skip as this has already been conducted in the last session. So what is a systematic review? Ma'am has already briefly told us. A review that is conducted according to the clearly stated research question, scientific research methods, and is designed to minimize biases and errors inherent to traditional and narrative reviews. So that is this definition. So now the quick story of the meta-analysis. As we know that meta-analysis, it is a part of the systematic review because it is very much important that before going into the network meta-analysis, you should be familiar with what is the meta-analysis. As we can see here, we want to know that which is the best treatment for the breast cancer. So they are the two then we are collating all the evidence of different stages of the cancer, of the breast cancer, and then we did the meta-analysis as we can see here. But the I-square, it is 50 to 62%. So, but it is favoring. So what we need to do? So there is some heterogeneity. So we need to solve it. I-square.
So I-square, if it is more than 50%, that means there is significant heterogeneity. And significant heterogeneity agar hogi, so value of that conclusion is decreased. If it is a very homogeneous sample, heterogeneity is 25%, then the results are to be believed.
So then we did the subgroup analysis for the early cancer stage and the late cancer stage patients. So we found that in the late cancer stage, the treatment was better as compared to the early cancer stage. So now the big problem occurs then when most
apples and oranges likha tha isne. So
yeah.
Apples and oranges matlab, so you are trying to pool two things which are very unlike each other. Again, heterogeneity. So on one side you have, say, digital intervention of different type, which is entirely different from what you have done. Then you will say you're trying to pool apples and oranges. So jitna zyada homogeneous hoga sample, utna hi acha hoga meta-analysis. If there is, so this will lead to heterogeneity again, because, and that will be methodological heterogeneity. And it is not just in the population that the heterogeneity will be there. It can also be in the intervention. It can also be in the evaluation. If there are different methods which are being used for these different steps, then this methodological heterogeneity is something which leads to this apple and oranges concept. Yeah.
So the new evidence comes and bewildering flood of new data is there for a particular therapy. So then the case is that we have to find that among most of the interventions, which is the best intervention for the disease. So then the concept arises for the network meta-analysis. So network meta-analysis, it is an extension of the standard pairwise meta-analysis by including multiple pairwise comparison across a range of intervention. And it addresses the comparative effectiveness and ranking probabilities of multiple treatment alternatives. In a simple systematic reviews, we have a single pair of intervention we are comparing. But when there are two or more pair of the interventions from which we want to know that which have the highest effectiveness, which have the highest ranking probability of treatment. So then we do the network meta-analysis.
जैसे आपके केस में अगर you take SMS intervention, एक SMS हो गया, एक WhatsApp हो गया, एक television हो गया, एक internet पे media पे हो गया. So all these are 4 or 5 different kind of interventions. So different type of studies are there, but your outcome is the same, which is cessation of smoking. So here you may have to do network in different studies. So that is where network meta-analysis will be useful.
So there are two types of network meta-analysis which we will be going through. First is the indirect comparison, when you have a single one pair of treatment and you're comparing the two pair of the treatments which are having the same comparator. But I will show you in the next slides how it is being measured. And then is the mixed treatment comparison. It is a generalization of the indirect comparisons with more than two or multiple pair of treatments being compared indirectly. At least one pair of the treatment is compared both directly and indirectly, but in case of the indirect comparison, only the indirect we measure by the indirect way. So how it is being done? So there's a problem A, we have the two intervention A is to B. That is the old problem that that is a simple pairwise meta-analysis. Then comes other treatments such as C, D, E and F. Now the problem arises, which is the best treatment? So then we need to know which of the 6 available treatment is the most effective and the safest. Is treatment B better than the treatment F? Because at the lines you are seeing here, which are interconnected, they are the direct head-to-head intervention comparisons are there. But for B to F, there is no comparison. So that how we can evaluate? We can evaluate through the indirect comparison. So for that, I will give you an example. We have the 3 buildings, A, B and the C. As you can see here. So we know that C is how much taller the C is to A and how much taller is B is to A. But we don't know that how much taller is C is to B. So how you can find out this by, typically the difference of C over B is find out by difference of C over A minus difference of B over A. Simple stat. Nothing to do in a different manner. Okay. So in a similar manner, I can show you there are the 3 treatments A, B and the C. So how you can get the treatment effect of B, C? We can buy treatment effect of AC minus treatment effect of AB will give you the treatment effect of BC. And here A is the common comparator for B and the C. And then when you are finding the variance of BC, then you have to add variance of AC plus variance of AB. So we have the toothpaste and the gel, but we don't have any trial or RCTs that compare for their effectiveness. But for toothpaste is being compared with the placebo and gel is being also compared with the placebo. And we have found the standardized mean difference for both of them. In the similar manner, we can find the standardized mean difference for the toothpaste with the gel. So we can simply minus the gel placebo SMD with the placebo toothpaste SMD. This will give you the toothpaste gel standardized mean difference. So this is a network I am showing where we use both the direct and the indirect effects. If you use both the direct and the indirect estimates, then it is called the mixed effect comparison or the network meta-analysis. That is the other name. So here we can take this part. We have the direct SMD 0.04 and the indirect SMD we have calculated minus 0.15. So the mixed standardized mean difference will be after calculating with the both the indirect and the direct one. So now we need to know what are the main differences between the pairwise and the network meta-analysis. As you can see, the type of comparison for the pairwise meta-analysis, it is the 2 interventions at a time. But for the network meta-analysis, there are the multiple interventions you can use. And the evidence that is used, that is the direct evidence only for the pairwise meta-analysis. But for the network, you have to use both the direct and the indirect evidence. Then complexity, the pairwise it is relatively simple but network it is more complex and has some statistical modeling. Now they are the softwares, there is the inbuilt statistical models are there, and you don't have to worry about the calculations, and they will get you the all results. Then treatment ranking in pairwise meta-analysis, you cannot rank. But in the network meta-analysis, it provides the ranking probability of your treatments. Then we have the scope of analysis. There is, for pairwise, it is limited to existing direct comparisons. And for NMA, it is can include the treatments not directly compared in any studies. So statistically, pairwise, it is lower due to the favor comparisons, but for the network, the precision increases because you are measuring both the direct and in the indirect way, the comparisons. And then application for pairwise best when only 2 treatments are being compared, and NMA ideal for comparing multiple treatments where you have to formulate some clinical guidelines and you have multiple treatments there. And visualization, simple forest plot in a pairwise meta-analysis, but in NMA, you prepare a network graph and a league table. This Dr. Prateek will be showing in detail. So why we use the network meta-analysis, the question arises, because it combines the direct and the indirect evidence that I already told, provides the comprehensive comparisons across multiple interventions, and third is the increases the statistical power and the precision. So before going to the network meta-analysis, it is important that there are some assumptions you have to take care. In your research question or while doing the methodology of the NMA, that you should go through the homogeneity, transitivity, and the consistency. These 3 terms should be taken as key assumptions. That is there any homogeneity in the studies that you are taking? Is there transitivity? Is there consistency? I will get you the one by one. What are these? So first of all, we need to know by this diagram that what is the effect modifier and what are the prognostic factors before that. Can anybody? So one is that when you are giving any intervention, there is some treatment effect of that intervention. But other than the treatment effect, there are also other effects. It could be due to the route of the dosage of the treatment by the orally it is being given in the one study, and by any IM or IV it has been given, by the age or other variables which affect the treatment effect. These are called the effect modifiers. And there are some prognostic factors. These are some psychological factors or something that attenuates the treatment effects. So for homogeneity occurs when the true treatment effects in a direct comparison of two treatments across studies are the same. What does it mean? When you are doing a direct comparison of two treatments, so the pair of the treatment across the studies, the effect modifiers which are there, they are similar in both pair of the treatments across the studies for both same pair of the treatment. In a direct comparison I am talking about, not in the indirect. In a pairwise meta-analysis, there are some statistical clinical heterogeneity, and there is methodological heterogeneity, there is clinical heterogeneity. Similar it is here also, but it is up to the effect modifiers, how they are working here. And it is known as interaction by the statisticians and as effect modification by the epidemiologists. And it is caused by variation in measured effects, modifiers of the relative, unmeasured effects that are the modifiers of relative treatment effect. Then comes the transitivity. So transitivity is in terms of the indirect effect. So when there is a common, as I have shown in the previous slide, I will go here for the indirect comparison, AB versus AC. So I will simply show what is transitivity here. Transit is the A here, when they are the two pairs, AB and the AC, two pairs of the comparison, and we are measuring the BC here, that is the indirect estimate. So when we are comparing, we need to see that for a particular pair of A to B, the effect modifier is similar to that of the A to C. If they are both, if the effect modifiers are similar, then we can estimate the indirect estimate. Otherwise, the effect estimated will not be the reliable. So that is the transitivity. So you can also, it can be also clarified through these diagrams. As I have given the example before, AB and there are the two pairs, AB versus AC here. So there are the two models here, without heterogeneity and the with heterogeneity.
I think before we go into this, are you able to follow these diagrams? These are forest plots. Okay, okay. If you're able to follow them, then I think we should just go ahead. Yeah. Yeah, yeah, sure.
So here we can see that there are the two models here, without heterogeneity and the with heterogeneity. And these are the forest plots here. And these are having the three studies, and there is the pooled effect. And in the three studies, there are the severe to moderate ratio patients are being included. So here we can see in the without heterogeneity, the 70 to 30, the ratio of the severe to moderate is similar in the treatment effect of B versus A in the upper quadrant, with that of the lower one of pointer. There is no pointer, then I can show. Okay. Okay. No, I can. So you are able to see the cursor here. Okay. So again. So I can show here that without heterogeneity, the ratio of severe to moderate. This is a comparison of treatment of B versus A. In the lower one, the comparison it is treatment effect of C versus A. So in the both comparison, you can see the ratio of severe to moderate population is similar. They are the effect modifiers. So then this leads to the indirect estimate of C versus B. As you can see here, there is a valid indirect estimate of C versus B, this one. Because the effect modifiers in both of the forest plot without heterogeneity is similar. And when there is a heterogeneity, in the similar case, you can see also here, there is a same ratio of the severe to the moderate one. You can see in the both diagrams here, in the with heterogeneity. Okay, so in both cases, the effect modifiers are same, so transitivity is there. There is no lack of transitivity. But when we go to the next diagram here, you can see here the ratio of severe to moderate is changed. Okay, the effect modifiers, they have changed in both the scenario. So there is imbalance in distribution of effect modifiers between AB and AC studies in both the models of without heterogeneity and with heterogeneity. So there will be the lack of transitivity, and it will be a biased indirect estimate of C versus B. So is it you are getting up, or some queries there? Dr. Prateek will be going in more detail. So, okay. So there is another example. You can see the comparison of two trials here. There are the two car races are there. In the upper trial, there is a Porsche versus the Golf, and thus the difference is 2s. In the second trial, Volvo versus Golf is there, that is the 8s. So you can see here, is a Volvo faster than a Porsche? Is it there? By statistical mean, by indirect comparison, it is there, 8 minus 2, 6. But no, there is a biased indirect estimate. So that I was telling you. Due to the imbalance in treatment effect modifier. What is the effect modifier here? In the trial one, there is a surface. That is, there is a snow. The surface is not equal in the both scenario. So that's why the indirect estimate is not reliable. So while conducting a network meta-analysis, you have to take care of this thing. Then we come to the
Sir, transitivity, just simply remember, transitivity is can we transit? Suppose the study were between A and B and C are there. But we don't have a study for A and C. Suppose 3 drugs, phenytoin, levetiracetam, valproate. We have a study for phenytoin and levetiracetam. We have a study for levetiracetam and valproate. Now can we transit from phenytoin to valproate? For that, all the characteristics, or especially the important characteristics of the phenytoin, levetiracetam and levetiracetam valproate study. For A and B, the study, and B and C study. The study should be similar so that we can transit from A to C. That's it, transit.
So study should be similar means PICO has to be similar.
Baseline.
Yeah.
PICO should be
PICO has to be
That.
Then the inconsistency or incoherence, we call it. Previously what used to be called inconsistent systematic review. Now in the traditional meta-analysis, that we call it as incoherence. Incoherence is?
Incoherence.
Now that is I will cover. I believe it is clear. Transit.
So consistency and inconsistency, that is the another third thing. First we have gone through the homogeneity, then transitivity, then the consistency. So in most of the statistical models, there is an inbuilt inconsistent model and the consistent model. That there is a you have to see that p-value in the direct estimate and the indirect estimate. Is there any difference when you are calculating for a particular pair of the treatment? So if there is some statistical differences there, so it will lead to inconsistency. So this can be shown here also. There are 3 trials where in the first trial B is compared with the A placebo. In the second trial C is compared with the A placebo, and in the third trial C is compared with the B. So here you can see that direct estimate of C versus B. That is when the estimation of C versus B is in a direct is similar to that of the indirect estimate of C versus B, as you can see in the lower diagram of the consistency. So, but when it leads to inconsistency, as you can see here, when the the direct estimate of C versus B and the indirect estimate of C versus B are not same, as you can see here. The red portion here is not equal to that the purple one. It is larger as compared to the red portion. So these there's in the direct and the indirect estimate there is difference. So this will lead to the inconsistency. So how it is being interpreted? The software will show you this matrix where the direct, indirect, and the NMA values will be there, and at the last the p value will be there, which will show you if it is more than less than 0.05, then it will be an inconsistent one. Then we comes to the what are the different steps of network meta-analysis. In the first half, you have gone through the steps of the systematic review. These are similar to that, but what you have to consider for a network meta-analysis, that question should benefit from network meta-analysis, and which should define the treatment network. Then is the searching should be broad enough to capture the treatments of interest and abstract information on potential effect modifiers which may violate the assumption of transitivity. Then you have to evaluate the network geometry and evaluate the transitivity. Then you have to conduct the pairwise meta-analysis first, that is the direct estimate. Then you use the statistical models appropriate for the network meta-analysis, then evaluate the inconsistency. Then you summarize the results using approaches suitable for network meta-analysis such as the league tables, and if ranking, you use the Sukra curve. I will show you. These are new terms to you, but it will be covered. Then interpret the results carefully, especially the rankings, and interpret the results in context of their outcomes examined. And if you use the grade approach to evaluate quality of evidence, adapt for the network meta-analysis and follow the PRISMA extension for network meta-analysis. There is also the PRISMA guidelines for the network meta-analysis. So what are the statistical methods? I will not go into the depth, just name it. There is the Bayesian versus the frequency approach, then fixed effect versus the random effect model, and then the Markov chain Monte Carlo simulation in the Bayesian NMA. This will be covered by Dr. Prateek. Then interpretation. The interpretation is by simply as in the pairwise meta-analysis by odds ratio, mean differences, but there are also the important thing, that is the network structure. That is the this network graph, as you can see here. This is the important thing that NMA prepares. Here the node is the circle. Bigger the circle, bigger the number of participants in the trial. This is and smaller the number of participants in the trial. It is a trial, and the lines are the thicker the lines, the number of trials are more for that pair of comparison. And bigger this circle, the effect estimate is more. Then this is the league table. So I will not go into the depth. So this is the colors, they are being coded of different interventions. They are from the x-axis and the y-axis, and in each of the square there is a confidence interval and the effect estimate of the consecutive relative comparison of the two interventions. So ranking is being done according to the effect estimate. Then this is the summary forest plot. Here it shows that the placebo is being compared with all the other treatments, and it summarizes. You don't have to prepare the in a pairwise. You have to prepare the single forest plot of each pair, but here the common forest plot can be prepared with the placebo. Then ranking and the probability. This is the this is the Sukra curve here. Sukra is the surface under curve. It is prepared by the in the y-axis there is the probability, and x-axis there is the rank of the interventions. So in which rank how much is the probability? As probability is that probability of having the maximum effect estimate of that intervention, and ranking is that in which whether it is second, third, fourth, or which ranking among that intervention, in which rank it falls. Then this is the summarize of the forest plot matrix. This is also prepared by the software, and this will give you the confidence interval and the predictive intervals, and this is similar to that before that I have shown. Then there are the certainty of evidence. It is being measured through the Cinema app, and it has 6 parameters. These are the within study bias, reporting bias, indirectness, imprecision, heterogeneity, and the incoherence. These you have to take care when you are going through the studies. Then these are the strengths and limitations of the NMA, as I have previously been talked. And there are some benefits. The benefit is that there are the multiple treatments being analyzed, and treatment ranking is being done, efficient evidence is being used, and it is used for inform the policy and the practice and reveal the research gaps. And there are some softwares you can go through for conducting the this NMA. They are the Meta Insight, NMA Studio, Stata, WinBugs, R, Python, OpenBugs, Robman, and Meta Insight is freely available and you can use widely for both the Bayesian and the this frequentist model. Pairwise meta-analysis. So it will do. Yeah. And this is the training Cochrane training site from where you can study about the network meta-analysis. They have given all the videos for the network meta-analysis, and this is the homepage of the Meta Insight. This will be discussed by Dr. Prateek. So, any question? It was very fast forward, so sorry for that thing.
Can you show the reference?
Okay. Okay, yes.
Very much, Dr. Anil, for filling on network meta-analysis. You all must have gone through the slides, but you know it is important to do it hands-on. Only then you will understand what exactly. You should have some data in hand, and then you try to apply all these techniques which are there. So otherwise, you know, these are just facts which are transmitted. So you get to know some terms which you have to learn subsequently how to interpret the results. So I think best thing is to start doing something, and then you see whether you can apply network meta-analysis technique to that particular question. So now Dr. Prateek is going to talk to you about further about network meta-analysis as well as bridge to equity.
I will straight. Everybody's clear about. I think everybody's clear about incoherence, transitivity, and homogeneity. Because now I'm going to talk about little bit complicated things. So I will just skip all those things, and I will show you the. Everybody's clear about direct and indirect estimates. Now calculating indirect estimate. How to calculate the indirect estimate? That is the problem. Okay. So everybody has shown the network diagram. There is no, I think no doubt about the network diagram. What are the nodes? So this is a network diagram. Be clear about that. Network diagram. So there are nodes, loops you can see, and all the loops are, it can be thick, thin, nodes can be small, nodes can be wider. So it depends on the how many studies are there comparing. Then it can be just dots. For indirect comparisons, there are dots. You see that? It's clear? Now everybody is clear on net dot diagram. I will not repeat that again. So coherence. Coherence is without transitivity, there is no coherence. If we cannot transit, how can you calculate that? So if there is no transitivity, we can still conduct a NMA, but there will be a lot of complications. We have to adjust for a lot of things. But if we have transited, then we will see whether the direct estimate and indirect estimate can be combined to calculate the mixed estimate. If direct and indirect estimates are too far away, then we have to adjust it. In that case, the incoherence factor will be high. You don't have to do anything. Everything the software will calculate. Just you have to remember the terms. So Meta Insight, R has certain packages, R Studio. I think everybody must have used R Studio. Then Stata, Jasper is also there. Meta Excel is also there. So easiest to use is Meta Insight. So please everybody open in the Google Meta Insight. So this is hands-on. So everybody is clear about the mean difference. Mean difference, the formula is simple. Just AC minus AB is BC, okay? But that's not the same for variance. So if you are variance, it will be, what it will be? It will be added. Variance is the standard error reverse. One. So variance, when we are combining indirect estimate, now there are two types of variables. First of all, be clear, there are qualitative variables and quantitative, otherwise called categorical and continuous variables. Categorical variables, the effect size is estimated in the terms of odds ratio, risk ratio, risk difference. Fourth one is, that is not required, number needed to treat, and attributable risk. So just forget and just remember odds ratio, risk ratio. I will not go into the formula of odds ratio, risk ratio, because I assume everybody knows what is the, I think everybody is clear, odds ratio and risk ratio, what is the difference. For quantitative variables, mean difference, standardized mean difference. Standardized mean difference, when different studies have used different measures of outcome. Kilometer, miles, how will you combine? So, mean difference of study A minus mean difference of study B by divided by mean difference of study A is standardized mean difference. Okay, everybody is clear? So now, so when I will go into the, directly into the, this one, incoherence factor. So, just we again started with A, B, C, D, E. We have a complex loop. Now there is a simple loop, complex loop. And there are some data sets. So supplementary data set is what? Now there is a problem. Suppose there are two drugs. We have a placebo control trials. Now we have a, suppose you have proven A versus placebo, A is better than placebo. B is better than placebo. But now we don't know whether A is better than B or not. But placebo is not required. So placebo becomes a, one of the extra nodes. We don't require it. But they will all be included in something called as synthesis comparator set. Very clear? So we use this frequently, this in our estimation. So now we have transited. We have now calculated the direct estimate, indirect estimate. The only difference is when we are combining direct and indirect estimate, there are certain formulas. We have to use the standard error and variance we have to take into account, and it will give you the mixed estimate. But incoherence is not about the mixed estimate. It compares between the direct and indirect estimate, and it gives you the value. You don't have to calculate it, just remember it. So now it is just like a consistency, but here we call it as incoherence. So now I will go to the meta. So these are the formulas. I will skip the formulas because these are complicated and these are not actually required. And we will do in the, I think everybody is opened Meta Insight. In the Meta Insight I will show everything. So starting from the beginning. So I have started this data. So I have started a study. So risk of bias, everybody knows the tools. There is something called as, just remember the term, ROBVIS. ROBVIS. So for RCTs, the tool is risk of bias 2.0. For observational studies, just remember the term. You don't have to, in ROBVIS tool, it automatically guides you. It automatically guides you to the tool. It might be Robbins 1. For prognostic studies, it is QUAPAS, and for diagnostic accuracy, QUADAS. So you don't have to do anything, you just have to fill the data. It is the low, moderate, certain. This is the first step, risk of bias calculation for the studies. So this is a part of the systematic review, not of the meta-analysis. But without this, we will not find. So this is the first step. This is a summary plot and there is a traffic light plot. We have plotted it. Second step, this is the network diagram. So just for the timing, we are comparing three drugs with a simpler, I have shown, ethosuximide, valproate, lamotrigine. You can see that the ethosuximide, it is a small one. So it must be the number of patients who has received the ethosuximide must be studies must be less. And you can say maximum number of studies are comparing between valproate ethoximide and valproate lamotrigine. 9 is thicker. We'll go to now, this is the Rebman. Rebman forest plot. First we have calculated the direct comparison. Now in the forest plot you can see there are study identifiers, then two groups. You can see that it is a categorical variable or quantitative variable. Very good. So it is a categorical variable, so there should be event rate out of the total rate. Event rate can be success or not success depending on the context, which you can decide. Then I've already told you we can combine meta-analysis. Go to the Rebman. I cannot show you because of the time is limited, but Rebman, add study, then after adding study you can go for the add data. There are sections. In that you have to enter all the things. Then you have to select what effect size or the effect measure you want to select. It might be risk ratio, risk difference, whatever it is. What is the model you want to use? Normally use for qualitative variable or categorical variable, we use Mantel-Hansel model, that is written here, MH, it will automatically come. Then what is the fixed and random effect? Everybody is clear? Fixed and I think it has already been covered in the previous meta-analysis section, so I will not go into that. If anybody is doubt about the fixed and random effect, then we can, otherwise I will go ahead. Okay. Then automatically it will calculate the heterogeneity. Heterogeneity is a purely, here whatever heterogeneity is calculated, that is a purely statistical one. Heterogeneity can also be in the PICO. So that you have to calculate manually. Okay. So then it calculates this is a forest plot and it calculates the I-square value. If it is less than 40%, 50% is okay. So, and then test for overall effect. It's okay. So it automatically plots. You have to only give the event rate, total rate, study identifier and select the model. Fixed effect, random effect. So now direct comparison is over. So now the indirect comparison starts. So indirect comparison will tell you, it has now mixed both the direct and indirect comparison and it has given the risk ratio for mixed estimate. It is automatically calculated. Now we will show you how to calculate this one. So you are seeing this ethoxoximide and lamotrigine versus valproate. So what it is showing? This forest plot is different than the forest plot which we have previously shown. Here we are comparing ethoxoximide versus valproate not only from the direct comparison but also from the direct and indirect mixed comparison. Clear it is? So it has calculated. So how it has calculated? And then just one thing, remember, this is the Renkogram. So what is this Renkogram? Renkogram is, suppose we have used 3 things, 3 drugs. So suppose for the rank number 2, every drug has a probability, valproate has some probability, ethoxoximide has some probability and lamotrigine has some probability. So we have shown that probability here. If you see the other way around, mean rank. Similarly for the top, valproate has some probability, ethoxoximide has some probability. Suppose valproate is the best one. So for the rank 1, it will have the highest probability. So it will be at the top, but it will not be 100%. It will not be 100%. It might be 99%, but it will never be 100%. So how to calculate this rank? There is something called as SUCRA, surface under cumulative ranking, just like a area under curve. That I cannot calculate manually. That will be calculated only by a software. So the value will range between 0 to 1, just like area under curve. It's clear? So now this is a sample data. Sorry, I could not give you all the data and laptops and all these things. So what I brought is, I brought a sample data. So in the sample data in the meta insight, in what format you have to fill? Just the same thing, event rate and total rate. you can also include one covariate. That can be duration of the treatment, or that can be any covariate depending on your study. For each study there will be at least 2 columns. It might be a multi-comparison. Suppose a trial which is there which is compared valproate, ethosuximide, levetiracetam in the 3. So there will be 3 rows. So this is, everybody is clear how to include the data in the meta insight. This is the way how you have to prepare. This can be prepared, nowadays ChatGPT prepares it, so we don't have to remember it. But for the purpose of it, you can remember it. This is the easiest way to prepare. So then this is, yes ma'am, please ma'am. Yes ma'am, yes ma'am. N is the total number ma'am, denominator ma'am. R is the ma'am event rate ma'am. Event rate, it depends on success rate, or it also depends on the failure rate, whatever you choose ma'am. And you can include one covariate ma'am, definitely. So this is how the meta insight looks. Meta insight, you can, this is a software we can use for diagnostic accuracy studies, normal meta analysis, but I will today show you the network meta analysis. So you can choose again the odds ratio, risk ratio. I have already told. Same thing we are doing. Again we have selected the effect model. Same thing. Again we have selected the, then we can do the data summary. So you can look at the careful data summary. It has already given you, calculated the everything. Total number of pair-wise comparison, direct comparison, indirect, how many numbers it has calculated, total sample size, everything it has calculated. So number of interventions, number of studies, total number of patients in the network, total pair-wise comparison, total number of pair-wise direct data, and for indirect data, everything it has calculated. This is your data summary. So when you are going to write the result, you don't have to just, you can just write it in the text format. It will show you the basic summary of the network meta-analysis, what you are going to do. Next, now you can calculate. Previously I have shown you the direct comparison meta-analysis plotted from Rebman, because I wanted to show you the Rebman, which is the standard for direct meta-analysis, but it can also calculate. It has calculated taking into account both direct and indirect. That was meta Excel. This is meta insight. The same thing they have used. Only thing is odds ratio, it is calculated. Again there will be a, for any odds ratio or risk ratio, there will be a confidence interval. Again the same thing, it is compared levetiracetam versus valproate, oxcarbazepine versus valproate. Here the comparisons are different. So this is, now you can do the sensitivity analysis also, results for all studies, or you can exclude one study for sensitivity analysis. It will, or just click on that. So this is the frequentist network meta-analysis. So everybody is clear up to this. If this is over and everybody is clear up to this, then this session's meaning is over. So everybody now, I think frequentist approach, everybody can include the data and can include, this is for qualitative variable for the timing, and I have not shown the quantitative variable, but it is the same format. So anybody has any doubt in the frequentist network meta-analysis? How to put the data and how to get the result? So you can easily reach up to getting a forest plot, risk of bias. So now you are going to little bit more complicated. So how to represent the data? So you can represent the data in a league table. What is a league table? Just a simple thing. So there are multiple odds ratios. How to represent the data in a manner so that the reviewer can easily understand. So you can see that valproate, oxcarbazepine, levetiracetam, they have written it. Now in each cell, it represents one row and one column. So it is the intersection of a row and a column, each cell. In that row and column, whatever the intervention effect is written, for that, whatever it is, that is the odds ratio. Suppose we are going for the second row, first column. It is the intersection of valproate and oxcarbazepine. So this 0.81 shows it is the ratio of, it is the effect size or the odds ratio and its confidence intervals for comparison between valproate and oxcarbazepine. Everybody is clear? Third row, second column, comparison between levetiracetam. So this can be more complicated. I have kept it simple just for the timing sake. So everybody is clear about the league table? Okay. So now it has calculated, somebody wants to see direct and indirect estimates. Sometimes we have to give it in a tabular format. For the, if you are doing lots of, there are complex networks, then we don't give these plots. But if it is a simple network, sometimes we have to give the direct and indirect estimate, because the reviewer also wants to know how much is the direct. So that will be shown in the contribution matrix. How much is the direct? How much is the indirect? Suppose 80% is indirect and 20% is direct. So then there might be, that is used for grading, that is equity, that I will cover in the next. So that is the, then this is the Renkogram, it automatically plots. I have covered the Renkogram already, and the Shukra. So this is the same thing, it has plotted for the draw, and it has also given you the, so everybody is clear? You just clicked on the Renkogram and it is plotted. Everybody is clear up to this point? Which one, madam? Ma'am, in this slide or previous slide, ma'am? Yes, ma'am. Yes, ma'am. Exactly. Very good question. I didn't want to complete, but you can see that this one, there is a 0.81, 0.59 to 1.11, 0.81, 0.54 to 1.20. So I have already told that you can do sensitivity analysis, and also you can do Bayesian. I will go to the Bayesian. So Bayesian, yes, it is in the downs, it is given the Bayesian. That is the, I will cover in the next slide. Credible interval and the, so for the timing, I have shown you the frequentist. So there is something called Bayesian network meta-analysis. That will again give you something called as credible interval rather than confidence interval. So that has been shown. So if you are choosing when to choose frequentist, when to choose Bayesian, I will tell you. So these are, everybody is clear to this. So now the madam has asked the right question. So when to choose frequentist approach? Frequentist approach, we don't know anything. It is a simple loop. We have large number of data, and we know that we can combine it. Even if we don't have any prior knowledge, whatever we are getting, we can directly apply it into our clinical setting. There are large studies, 1,000, 2,000 children are there in the study. But if we have a prior knowledge, that valproate is better than lamotrigine, at least by 20-30%. Studies are complicated. Some of them are small studies and complex networks. So we have a prior opinion, and we are not certain that we cannot combine 10 small studies to create one large study. So what we do is Bayesian method, or we can do meta regression, but that is different thing. For the thing, Bayesian means we assume something, that is called a priori, then we calculate, instead of this Bayesian, here we will get some credible intervals and we will get a probability. So frequentist approach will never give you the Renkogram. Bayesian approach will usually give you the probability, and you can easily calculate the Shukra values on the basis of that, because here we are considering about probability. How much probable it is. But even in Bayesian meta-analysis, even if you don't have any prior information, you can straight away go to Bayesian meta-analysis. You just have to click on the Bayesian and it will give you a probability and confidence interval. It will give you credible interval, which madam has asked previously. Clear in that? The same thing again it has done. Same league table has been plotted, but this is for credible intervals. Okay. So now we have, everybody is clear about Bayesian meta-analysis and this one. So now you have lot of plots. So how to show the Renkogram? There is another, we have two things. One is a mean rank. Valproate has a mean rank of 2.8. It cannot be 3 or 1. It can have a mean rank of 1.5 also. And we can also have a Shukra value. So the two things can be plotted simultaneously. It will have a better representation. The rank plotted against cumulative probability, that is called as litmus. There is a, you can see the color, na? Litmus Renkogram. Or if you want to give more pictures, then there is another better picture, that is called as radial Shukra. So these are more better. If it is not required for every, mandatory for every network meta-analysis, whatever I have shown up to frequentist network meta-analysis, that is mandatory. But if you want to make your paper better, then you can plot these things also. So the story does not end here. Now you have to show the inconsistency, because the most important thing is now you have to grade it. Now you got lot of results, but you have to grade it. Everybody is clear about the grade? So grade, how it can be high, moderate, low, but it does not end there. There is also one very low. But for network meta-analysis, it is difficult now. There are individual study problems like inconsistency, indirectness. I think grading has been covered in the previous, or I think grading has not been covered. So inconsistency has been calculated here. Indirectness you will calculate. Indirectness is if you are if the comparison is not that much direct, then it is indirect. Then I think I have only. So imprecision, whatever I have shown imprecision, and I think and inconsistency. Everybody is clear about the imprecision and inconsistency? How much precise it is and how much consistency it is. So that you have to calculate. Inconsistency here it is incoherence. Indirectness is whether there is direct comparison is available for every part. If there are a lot of indirect comparison are there, then it is indirectness. And obviously risk of bias. So these are the things which will downgrade the evidence. Okay. So inconsistency factors are there and incoherence factors are there. It is automatically calculated. On the basis of that, you will calculate. Suppose somebody is more interested in this, he needs the more detailed results, then it will give the more detailed results, but it is mainly for mathematicians, not for us. Then there is something called as, which sir has already covered, MCMC, Monte Carlo simulation. What is this Monte Carlo simulation? So Monte Carlo simulation is, suppose still you are thinking there are small number of data, so you automatically create large number of data by using mathematical models. So, and on the basis of that, it will give you this Gell-Mann convergence assessment plots by using the Monte Carlo simulations. You don't have to do it, it is a mathematical formula, just Monte Carlo simulation will automatically give you. So, then there are also residual deviance and all these things. These are very complicated things, just to forget about those things. But you can plot those things. Everybody should remember about Bayesian network meta-analysis, frequentist network meta-analysis, network diagram, contribution matrix, league table. And everybody is clear? Now, everybody is confident enough to enter the data into MetaInsight and get these plots? Or you can ask me questions anytime. I think anybody, any doubt about anything in the network meta-analysis, you can ask me. Or you can even try. I think 5 minutes I think I have completed beforehand. I think it is 6:27. So? There is one question about reading the league table. Yes, ma'am. As we know that every cell is an intersection. Yes, ma'am. And we can find when we read a particular cell and there is a odds ratio or risk ratio. Yes, ma'am. We know that these are the two drugs. Yes, ma'am. Of which the odds ratio is given. But yes, ma'am. Usually when there are two.
So I was saying that when we are reading the league table and in a cell there is a odds ratio. So we know the odds ratio is between these two drugs. Yes, but even when we are interpreting a particular odds ratio, we need to know which one is the reference. Like the odds of the outcome in which drug versus the odds of
the upper one. The upper one versus the lower one.
Okay, so whichever drug is written on the top,
that's why it is called as league table, ma'am.
Okay. So the drug which is written, the intervention which is written below is the reference.
Odds of getting, but that is also depends on the context. Suppose you are going for risk ratio, then that context will change. So that it depends on, we always don't choose odds ratio. Sometimes we choose risk ratio also.
Thank you.
Thank you. Any questions? Any doubt or anything which don't understand anything, any doubt about? Even you can, there are some sample data are there, everybody can see that. Any slide, any doubt, anybody could not understand what is transitivity, what is coherence, what is imprecision, what is indirectness, then I will cover it. Otherwise we will be, I think we were ending towards the final session. Whether I hope this session might be useful for all those who attended, and I think we can do it. I didn't go much into the theory. I mainly covered the practical aspects. Transitivity. Ma'am, it's very simple. Suppose there is air in the slides. In the slides you want, ma'am? Ma'am, it's over, ma'am. I'm just taking the questions, doubts, ma'am. It's over, ma'am. It's over. Okay, ma'am. Thank you, ma'am. Thank you, ma'am.
So shall I? So transitivity, we have seen that car example, but when we see it in the this software, how it is represented, the indirectness, is that what?
Ma'am, transitivity is not there, then we'll not do the network meta-analysis. Transitivity is a subjective thing, ma'am. Transitivity is a manual thing. You have to, ma'am, compare. Transitivity, we have to see there is no transitivity factor. They like the incoherence factor, but for transitivity, you have to see that whether all the important baseline characteristics and important effect modifiers, like Sir has shown, that you have to manually think whether we can go ahead for the indirect comparison. And I have already in the first line, I started the presentation with, without transitivity, there is no coherence.
Do you have an example where you have stopped the network meta-analysis because you realize that, okay, these are the factors?
Yes, ma'am. Suppose in the, let me give you an example, very simple example, ma'am. Suppose we had epilepsy cases and we compared drugs, phenobarbital and phenytoin in 1970 in adults. Now in children, we compared in 2024 phenytoin versus levetiracetam. So adult and children, lot of things have changed. 1970 and 2024, a lot of things have changed. Drug, formulation and all these things have changed. So now you don't have a direct study of phenobarbital versus levetiracetam. So can we plot the indirect estimate here? No. So in this case, the transitivity is not there.
Because we are trying to translate the
Exactly, ma'am. Exactly.
comparison
So
to
if there is
children.
transitivity is not there, so that is not dependent on a single factor. You have to take a lot of factors. What are important for you? If we think you cannot transit, then there is no need of calculating the indirect. You cannot, but you can actually calculate, but you have to take into account lot of adjustments. Suppose incoherence is high, then also you can adjust it. For that purpose only, this Bayesian network meta-analysis and Monte Carlo simulations are there. In Bayesian, you can put it in the prior assumption. You can put it in the prior assumption.
You need to do some detailed network meta-analysis workshop. It was more of a
Yes,
primer.
ma'am. Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
Thank you. Thanks
Thank
a
you.
lot.
Thank you, ma'am. Yes, ma'am.
We have the odds ratio as 0.78 and 0.77.
Yes, ma'am.
So which one to choose here?
Yes, ma'am, exactly. Like they have already told, it is a selecting both things. There is a credible interval and there is a, so the interval will change. So it has shown both things. So one, it has shown the frequentist by what you have, this is a customized representation. You can choose two things. Like you have done a sensitivity analysis, then it will again show you the sensitivity thing. So you excluded one thing. So it is just a representation. Ideally this part should not be there. But here two things are being represented. Suppose they have, ideally the league table should be half. Like this one is the half. But we have represented two league tables here. One is an inverted league table. So they are representing two data. One is either this is a direct comparison without sensitivity analysis and direct comparison with sensitivity analysis. Or it is a frequentist approach, it is a Bayesian approach. Now you are getting that. There are two league tables here. One is superimposed over the other one.
Okay, sir. Thank you, sir.
Thank you everybody. And I think we will have a detailed workshop in AIIMS Rishikesh sometime.